قربت.
بسم الله، يلا بينا.
We are live now.
طيب
حنشغل الفيديو بس ثواني.
يلا بسم الله. مفيش صوت يا ريس. مفيش صوت يا ريس.
تمام دكتور، شكرا.
استاذ علاء مفيش صوت، انت عارف؟
حاضر يا دكتور، حاضر ثواني.
طيب تمام، بديك فيدباك بس.
مجموعة مستشفيات السعودية الألوان ممكن.
لو في مشكلة في الفيديو خلينا طيب بسم الله.
عام 2020
كان عام 2021 بداية مرحلة جديدة في تاريخنا.
كده كويس.
فبعد
كده
أكثر
اشتغل.
من 30 عاما من شهرتنا
كده
باسم
اشتغل.
مجموعة
خد بس
مستشفيات
مش داخل
السعود
الفيديو.
الألماني، بدأنا رحلة تجديد وتغيير علامتنا التجارية لتصبح السعود الألماني الصحية. لا يقتصر التغيير على الاسم والتحديثات البصرية فحسب، بل يعكس قدرتنا على التطور والابتكار والتغيير الإيجابي أيضا.
دكتور I think we'll start بدون الفيديو. معلش نبدأ بدون الفيديو. طيب مستر فيصل ممكن تحاول مرة ثانية؟
من شهرتنا باسم مجموعة مستشفيات السعود الألماني، بدأنا رحلة التجديد والتغيير على مدينة الألمان الصحية. لا يقتصر التغيير على اسم والتحديثات البصرية فحسب.
الآن في صوت، أنا وقفت الآن.
استاذ علاء وقف من عندك كده، ما عايزنك وقف من عندك يا عم. من عندي محاوله، لو ما كانش نبدا من غيره. وقف من عندك كده. ايه الاخبار؟
بداية مرحلة جديدة في تاريخنا.
ايه الاخبار؟
فبعد أكثر من 30 عاما من شهرتنا باسم مجموعة مستشفيات.
اشتغل؟
اشتغل ممتاز ممتاز.
طيب. ابدا من عندي يلا.
يلا نبدأ بعدين نقدم المؤتمر بقى.
مرحلة جديدة في تاريخنا.
طيب يلا.
من 30 عاما من شهرتنا باسم.
وقف من عندك انت بقى. يا استاذ علاء ابدا.
نعم يا دكتور. نعم يا دكتور.
ابدا الفيديو.
ابدأ.
كان عام 2021 بداية مرحلة جديدة في تاريخنا. فبعد أكثر من 30 عاما من شهرتنا باسم مجموعة مستشفيات السعود الألماني، بدأنا رحلة تجديد وتغيير علامتنا التجارية لتصبح السعود الألماني الصحية. لا يقتصر التغيير على الاسم والتحديثات البصرية فحسب، بل يعكس قدرتنا على التطور والابتكار والتغيير الإيجابي أيضا. 2020 مليئا بالتحديات والفرص، ولكننا تمكنا من التعامل مع كليهما بالطريقة الأمثل. تحدي التكيف مع الوضع الطبيعي الجديد والفرصة لمواكبة التقدم في عالم دائم التغير. نحن تواقون للاستمرار في تقديم طرق العلاج المبتكرة وتحقيق التقدم الطبي وبناء شراكات دولية وتحسين خدماتنا، وقبل كل ذلك أن نهتم بكم وبأحبائكم ونرعاكم كأهالينا. نتمنى لكم عاماً مباركاً مليئاً بالصحة والسلامة والازدهار.
Thank you, Dr. Talat. Kindly stop sharing. بسم الله والصلاة والسلام على رسول الله وعلى آله وصحبه ومن والاه. أهلا وسهلا بكم جميعا في عرس جديد، عرس أكاديمي جديد من أعراس المستشفى السعودي الألماني. Welcome all in our ER emergency SGH emergency international symposium. First of all, let me introduce the chairman of the conference of the symposium, Dr. Muhammad Talat. He's ER consultant and the HOD for the ER department, and lot of other, mashallah. Please, Mr. Dr. Talat, introduce yourself. The mic with you, please.
الله خير. السلام عليكم from المدينة المنورة, مدينة النبي صلى الله عليه وسلم. I'm very honored to be with you in this symposium. My name is Muhammad Talat. I'm a consultant of emergency medicine, and I'm the chief of emergency department in Saudi German Hospital Madinah. And I'm very honored to be with you today as the chairman of this symposium. Before we start, I just want to share a thought with you. 2 years ago, who could have the ability to anticipate what happened? I'm not going to dig deep, but I'm just going to ask you about the whole world is looking to us now. It's a very unprecedented look. The whole world was looking to us, seeking hope, seeking a safe shelter from unknown, unexpected, very changing enemy. In our today's symposium, we are going to just do a try to make what we are doing in a better way, increase the quality of what we are doing, increase the knowledge. The only weapon that we have in the battle with this enemy and other unknown enemies as well. I have to thank all the faculty, and I also thank the Saudi German Hospital, Dr. Ahmed Isa, and the academic affairs. This symposium is in coordination with the governmental sector, the emergency medicine in Madinah, and the health cluster in Madinah. Dr. Khalid Atiyah, I'm much appreciating you. The mic is yours.
Alhamdulillah, wassalatu wassalamu ala rasulillah. Thank Dr. Talat for this introduction. We are really happy to have our distinguished speakers from all over the world, and most of the other speakers are our teachers. So we are really glad to have them today with us, and we hope we can enjoy our 2 days conference with our great sponsor here and the main body of the conference, Saudi German health sector, with the help of Mr. Ala and Dr. Muhammad Talat. I hope we will enjoy these 2 days. Thank you.
Thank you so much, Dr. Khalid. Let's start. I don't want to waste your time. We are going to start with the lecture of Dr. Ammar Ismail. Dr. Ammar Ismail is an American board certified of emergency medicine, and he is emergency ultrasound fellowship, consultant of emergency medicine at King Abdulaziz Medical City. He's Saudi Society of Emergency Medicine ultrasound section head of the Saudi Society of Emergency Medicine, SASM. Dr. Ammar, thank you so much. The floor is yours.
السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. I am really honored to be invited to speak at this great conference. It is an honor to even participate in a conference that is actually being broadcasted from the great holy city of Medina. It is my honor. My talk today is going to be about the ultrasound of respiratory distress, which is one of the talks that I actually like to talk about, especially with the pandemic that we just had over the last 2 years. So when we talk about ultrasound of respiratory distress, the Blue Protocol was proposed a few years back. There was an article published in the Annals of Intensive Care in 2014 by Dr. Lichtenstein about the lung ultrasound in critically ill. Basically, what we are doing in the Blue Protocol is we are basically looking at the lung sliding and then making sure that we go over this pathway to diagnose the following diagnoses or looking at the following conditions. And then beyond the lung ultrasound, we are also looking at DVTs. And then even maybe at a certain point, we are looking at undifferentiated shock and maybe incorporating any protocol that will help us with differentiating the undifferentiated shock. So what we are going to talk about today is going over the lung point of care ultrasound, how to approach a quick approach to a COVID patient, how to do a DVT, and then going over the thoracentesis, and then maybe a few slides about the Rush protocol. So the chest ultrasound, the point of care application basically is going to be looking at the diagnosis, guiding management, doing procedures, and then even rolling out complications after doing the procedure. So probes that we can use, we can start with even linear, curvilinear, or phased array. Whatever we got, we can use those. The lung, it depends on where the pathology in the lung going to be. Is it going to be in the peripheral, which is very accessible by the lung ultrasound, or is it something a bit deeper, which can be a bit challenging, or if there is any effusion that we want to see. So the more areas that we can cover, the better the yield of the diagnosis or ruling out life-threatening diagnoses. So what we are using, for example, here we are using the phased array probe, making the probe marker in the upper direction. And then here we can see that we have two rib shadows, and then we have the pleural line at this level right here. If we are using the linear probe, and then we look at this video clip in real time, you can see that the pleural line is sliding back and forth. So this indicates that we have lung interfacing with the chest wall, making the diagnosis, making sure that we are seeing a good artifacts, which is something that we actually like to see in lung ultrasound. And at this point, we can tell that maybe there in this interspace we don't have pneumothorax, for example. So the pleural line, when we are using the linear probe, the ultrasound probe is gonna penetrate and then maybe gets reflected if it hits a rib, but then it actually penetrates through to the pleural line, and then it does not continue. Why? Because the alveoli are filled with air, and when the ultrasound beams hits the alveoli, the ultrasound beam actually gets reflected everywhere. So the artifact that we said we like actually to see them, starting with the A-line reverberation artifact. which is the reverberation of the ultrasound back and forth between the lung and the pleural line. It will give you these parallel these parallel lines representing the A-line reverberation artifact. These are present in normal aerated lung. They are present in an asthmatic patient. They are present in a COPD patient. B-lines, which is the second type of the ultrasound artifacts, are you can actually in this image you can appreciate that we are using the curvy linear probe, and then we are setting the depth to a kind of a deeper setting when you compare it to the shallow setting that we used in the linear probe. In this image, you can actually see here that there are some artifacts that are projecting all the way across the screen, giving an indication that this is multiple lines, or actually a fan of lines projecting all the way from the pleural line all the way down deeper into the lung field. So it's a series of diffuse brightly echogenic lines originating from the pleural line and projecting into the lung field in a fan-like pattern. So what is the significance of the B lines? You can see them in interstitial thickening, so fluid or fibrosis, or if there is an alveolar fluid in consolidation, for example, at the beginning of consolidation. So this is what you can see in this artifact. Of course, you can use the phased array probe that can give you a bit of more of a noisy screen, but it will give you, it will serve the same purpose. It is really good to kind of like assess the severity and then even guiding management. So in this example, you're going from like negative to a mild, few B lines here and there, to moderate, and then all the way to being severe. How do you get it? Well, if you want to look at B lines, you actually expect the B lines to be present in the areas where you suspect to hear crackles by a stethoscope, if there is anyone who's still using a stethoscope, which is something that I actually recommend, because ultrasound is not going to be able to replace completely the stethoscope application. So one of the good things about using point of care ultrasound is guiding management. For example, in this situation, you actually have a patient who came in looking like this, and then you do your magic, and then after you're done with your magic, you can actually see the result of the intervention, and you actually get reassured and minimize radiation. So lung sliding, as we saw before, can diagnose pneumothorax. You can again use any of the probes. In this example, we are using a linear probe. This is an example of a pneumothorax. You can actually see that we're not seeing lung sliding in this video clip, and it seems like it's not moving at all. Maybe you can see a bit of a chest wall movement or intercostal retraction, but we don't see the lung sliding that we saw before in the normal sliding ultrasound. And if you want to get a bit more specific, you can use the M mode, activate the M mode, and then put the cursor across the intercostal space. And then this line is actually going to get grafted out over time. You can see that this chest wall is not moving, so that's why it's grafted out as a continuous line. However, once you get the pleural line and then go down into the lung tissue, because it is moving, you can actually see that it is a bit dotty. So this is what we call the seashore sign, and this is indicative of absence of pneumothorax in this interspace. Compare that to lung ultrasound of a pneumothorax. You can actually see that we are doing the same. However, we have the same of the chest wall up here, but then after the pleural line, still we are seeing a continuous line. Why is that? Well, because we are not seeing any sliding back and forth, causing that dotted line and seashore sign. And this is what we call it the barcode sign, or well, the old version of barcodes that we can see, and this is in the to diagnose lung pneumothorax. When you put them side to side, this is the difference between the two. The chest wall is actually the same, but then beyond the pleural line, this is what we are seeing. The comet tail, it is a normal artifact and it does not have much significance, but we want to see the artifacts, as we said before, because it helps us. A comparison between the chest X-ray and ultrasound, a bedside ultrasound in a supine anteroposterior chest X-ray for identification of a blunt trauma for pneumothorax. In this study, actually, they found that it is more sensitive. And here we are talking about the chest radiograph, the AP chest radiograph in a supine patient when you compare them to a bedside ultrasound. So what happens if you don't see lung sliding? The disruption of the visceral parietal interface can be a result of either a pneumothorax, which is one of the most important things that we need to think about. However, there are other differential diagnoses for the disruption of the visceral parietal interface. The loss of lung volume can happen from atelectasis, mainstem intubation, or mucus plug or pneumonectomy, or even if you have pleural scarring causing that disruption, so talc pleurodesis or inflammatory pleural disease or infectious pleural disease or radiation therapy, all of these can cause the loss of lung sliding. So in the appropriate clinical setting, just keep these in mind. So the clinical context is going to kind of dictate how do you use it and how can you apply it to your patient. If you have a patient with a previous pleural disease or manipulation, probably is not going to be as helpful as we wish. So there is another thing called the lung point, which is the lung point. Actually, if you can see here, the lung is moving. This area is not moving at all, but this area you can actually see the beginning of the lung sliding at this point, covering half of the interspace. And this lung point is defined as a sudden appearance of a sliding within an area with no lung sliding. So it is highly specific for pneumothorax, and it reaches, actually the specificity is 100%. However, the sensitivity is 66%. There is another phenomena that's called lung pulse, which is the perception of a slight movement of the pleural line with the heart pulsation, and this actually indicates that there is a normal visceral parietal interface with a sensitivity of a 93%, not bad, and a specificity of 100% for atelectasis. Another finding of lung ultrasound is lung hypotization. Lung hypotization meaning that the lung, the tissue of the lung is going to look exactly like the tissue of the liver. And in this example, probably consolidation is a good example to represent that. So in this case, this is a case at the beginning of the pandemic. This patient actually tested out negative for COVID, but tested positive for flu. Chest X-ray was not actually in the initial visit. It was not showing the finding, but then a chest CT actually showed this consolidation later on. When you actually look at the lung tissue and then try to put your ultrasound at this area, you can actually see that nothing is here, and then boom, it's showing up in the screen. So another angle, you can actually see that there was like a normal lung sliding, and then boom, everything is changing. So you can actually see consolidation with B lines and all that stuff that we are expecting from an infectious process. So at the beginning of the pandemic, or actually midway in the pandemic, there was like multiple application to approach a patient with COVID using POCUS. So looking from a normal all the way to severe. In this paper, they proposed 3 cases. This is the first case, a 93 years old with a complex past medical history. having congestive heart failure, presenting with cough and fevers and came in acute respiratory distress. When you get this chest X-ray, was actually read negative at the beginning, but then when you put the ultrasound probe, you actually can see multiple B lines in more than one space, and also you can see an irregular subpleural pattern and subpleural consolidation posteriorly. Another case, a 66 years old female with a history of fatigue, fevers, and shortness of breath. Well, everything is COVID, right? So peripherally distributed bilateral patchy opacities. You can actually see that in real time if you put the ultrasound probe in the areas where you suspect either to hear the crackles or to see it on imaging, but saving the patient the extra radiation. So and also when you see that there is like an irregular pleural line and subpleural consolidation, this is another helpful way to do it. Another patient with respiratory distress presented earlier and had a normal chest X-ray. The bilateral opacities on the second visit, you can actually see the confluent B lines posteriorly in this POCUS. So basically, the comparison between chest radiograph and lung POCUS, well, I'm not going to say it's unfair, but you can use either, or you can use both to assess. But at the same time, you cannot just keep repeating plain films trying to save radiation. So is it really important to use ultrasound in a patient when you suspect COVID? Well, it depends. In a patient where you are undetermined, in patient you're considering admission, you want to assess the severity. Maybe looking at patient with the ultrasound can help you. And then if you have a patient who you decided actually to admit, but you're not sure whether you should send the patient to the ICU or a regular floor or a step down unit, these two situations, probably the ultrasound of the point of care ultrasound of the lung is going to be of benefit. However, if you have a patient who's clinically well, or if you have a patient who's like really critically ill, using ultrasound to make this decision probably is not going to be as helpful. However, we are talking about critically ill patient today, so let's go over these. So the next, after covering the main bulk of our lecture, going over a few things. So we said we're going to talk about the deep venous thrombosis. We are doing point of care ultrasound to look at the lower extremity DVT. For emergency physician, such as myself, and the emergency physician can perform a 2-point compression ultrasound accurately, and then decide whether there is or there isn't a proximal DVT. So it is it has a rapid implementation of therapy and shortens the length of stay if you're working in the emergency department. But if you're working in and taking care of a critically ill patient, maybe you want to actually know more on how to do it. So basically, we are doing a 2-point compression studies in starting at the inguinal area. What you are doing here, you're just using this area and then this area. That's it. You press, and then you have a nice sensitivity and specificity if you're using a POCUS ultrasound for proximal part. So either you can have the patient externally rotate and abduct the leg, and then you can come from behind, whether the patient is sitting on the bench, or you can actually slip it under the patient. So how do we do it? Well, basically, you just gonna visualize where the vessels are, and then gradually make your compression to see if the blood vessel is being compressed completely, or if it's not being compressed completely in case of a non-occlusive thrombus or a complete thrombus like this one here. So if there is a complete collapse, that means in this area we don't have a DVT, non-occlusive thrombus, and then an occlusive thrombus. A couple of examples, whether you're looking at femoral vessels, and then in this example, you can see that the femoral vein is completely collapsed. You can actually see that here in a video clip, it actually is completely collapsed. The popliteal vein, this is popliteal artery, and then popliteal vein completely compressed. So these are example of normal patient. But when you are seeing maybe an artifact or something inside, and then you try to compress this all the way, it does not compress. This is an example of an non-occlusive thrombus, for example. And then a couple of other examples. You can also use Doppler to assess whether it's an occlusive or a non-occlusive thrombus. Doing an augmentation test, pressing on the patient calf to kind of get these artifacts. So basically, you don't want to, well, if you have a patient with phlegmasia cerolia dolens, like this one, probably, well, ultrasound is going to be an adjunct, but it's very obvious clinically. Doing thoracentesis in a patient who is in respiratory distress is an important tool, and you can use either ultrasound to diagnose it, or you can even do the procedure. So we are doing it for a diagnostic purposes or therapeutic purposes to relieve the respiratory distress the patient is having. You can either use it in real time, and multiple studies actually have shown that it is safe despite the coagulation parameter of the patient. It determines, well, you can actually use it to determine which side you want to stab, and then again, the risk of bleeding in a patient with coagulopathy situation. You can diagnose it with focus. You can determine where to go. You can actually see it in real time. You can actually use ultrasound to determine if there is a loculated pleural effusion. So maybe you don't want to do that in this patient and defer it to more advanced procedures such as cardiothoracic surgery. Doing the procedures, good preparation, good positioning, and then using either the linear or the curvilinear, and then going over the procedure, making sure that you have a good lung sliding, and then move to the area where the pleural effusion is happening, and then actually looking at knowing the anatomy is important to augment that with the ultrasound, avoiding the neurovascular bundle, doing the zigzag technique. You can either mark the area and then go well, air quotation blind, or you can actually do a real-time ultrasound. Once you're done with the procedure, you're showing where is everything. You can actually see in this video clip, you can introduce your needle and then avoid hitting the spleen and the diaphragm underneath. Doing the fluid analysis, doing visual inspection, and then even evaluating what happens after that, and looking for complications. So we're talking about having inducing pneumothorax or cough or infection, because this is an invasive procedure. How do you diagnose lung sliding? How do you diagnose the occurrence of pleural pneumothorax? Well, you can do lung sliding after the procedure. Again, you can use the M mode to confirm. If your patient start to cough, maybe you can stop temporarily, and but if it persists, you need to kind of terminate. One of the things that can happen at the re-expansion pulmonary edema, which is happening in terms of dyspnea, tachypnea, and tachycardia, cough, and frothy sputum, you can avoid those by limiting the amount of fluid, or you can predict that if the pleural pressure is more than minus 20 millimeter of mercury. How do you diagnose the re-expansion pulmonary edema? Well, as before, using the lung focus, looking for the B lines that we talked about before. Well, maybe the last part of our talk is to do the rapid ultrasound for shock and hypotension, the RUSH protocol, or any other protocol to differentiate the to look and investigate the cause of shock in a patient with hypotension. So it will help you identify and guide the therapy, and then you have a question: do you give more fluid, or do you start pressor, or do you do something else? So going by the high map mnemonic, looking at the heart, inferior vena cava, and then the fast aorta and pulmonary, differentiated between the multiple types of shock: cardiogenic, obstructive, hypovolemic, and distributive. So in this situation, you want to start with the heart, assessing the ejection fraction, looking at other findings in terms of tamponade or massive PE, learning the basic cardiac views, how to do those. It's going to be important to look at multiple normal findings, so you can actually, when you see any abnormality, you actually can detect them in pericardial effusion, or if there is a pericardial effusion causing tamponade, or if the patient's heart is not moving at all. This is a standing still in a patient with cardiac arrest, looking at and seeing no cardiac activity. Multiple views, so the parasternal long view, and then in this image you can actually see that just visual estimation, the ejection fraction is poor. In this example, the ejection fraction is also poor, but this is due to dilated cardiomyopathy. In this situation, this is a hyper dynamic heart trying to compensate. Contrast to this one, which is a tachycardia with normal ejection fraction, giving the impression that this is a hyper dynamic. And moving to the parasternal short views, looking at different levels, so at the papillary muscle, at the mitral valve, at the aortic valve, and then the D sign that happens with massive pulmonary embolism, pushing the right ventricle across, pushing the septum by the right ventricle to the left ventricle, not giving the chance to the left ventricle to fill up. And then even if you have a patient with mitral valve vegetation or any kind of vegetation that can be visualized, multiple angles can get you or reveal what you want to look at. And then if there is a regurg at a valve, all of these are within the scope of our practice, and you can do them in, once you get a good view, you just do them in less than 5 seconds. In this example, you can actually see that the right ventricle is actually the same size as the left ventricle, and you can actually even see that the septum is pushing and bowing inside the left ventricle, so you can predict the pathology of this patient. Or if you're dealing with the pericardial effusion, respiratory distress patient, whether it's a small effusion or a medium-sized effusion or a large-size effusion, what we care about is if this is actually causing the patient to have a respiratory distress or tamponade. Estimating the ejection fraction can be done with multiple ways. One of them is the E-point septal separation or the visual estimation. Multiple areas that you can look at. The way that you do it is in a parasternal short views across the mitral valve leaflets. You can actually see that in this the difference between those two patients. This one is not moving at all. You can see the anterior leaflet of the mitral valve not moving at all. Compare that to the previous one. So it's not going to be as accurate. You need to take it with a grain of salt if your patient have mitral valve abnormality or stenosis or regurgitation, aortic regurg or extreme LVH. And then looking at the other, the remaining part of the Rush protocol, or whatever you want to use. So the inferior vena cava, looking at the respiratory dynamics, how much is it collapsing, and then looking at which is the surrogate for a CVP. So you want to see whether the patient is normal, euvolemic, dry, or hypervolemic. It depends on the patient if the patient is spontaneously breathing or on a mechanical ventilation. So you want to also look at the Morrison's pouch. Maybe the patient is it's kind of rare to see a patient with free fluid in the abdomen causing respiratory distress. So it's not going to be as important to look at to approach it in this patient, but also aorta is part of it. However, maybe you're not going to see a respiratory distress situation with this kind of patient. So the take-home point, the lung ultrasound is, or the approach to a respiratory distressed patient using ultrasound is a point of care, and it's not very comprehensive. The artifacts are useful. We talked about the A lines being present in normal, asthmatic, and COPD. The B lines is present in fluid fibrosis or alveolar fluid. Lung hypotization and consolidation can be visualized very easily. The differential diagnosis of lung sliding knee, we need to identify it. We can use the ultrasound to guide our therapy for procedure, for example, and then looking at the venous system, and then even using the POCUS for undifferentiated shock. Thank you.
Thank you so much, Dr. Ammar, for the informative lecture, as usual. We received a couple of questions. One of them, is there any recommended depth while checking for B lines?
Yeah, so when you want to check for B lines, you need to, number one, use the curvilinear or the phase array. Curvilinear is better, but you want to put it at the maximum depth because you want to see these comma tail projecting all the way to across the screen. If you use the linear probe on a limited amount, you're probably going to see comma tail, which is a normal artifact in normal lung. But if you just looking at a shallow depth, it's not going to penetrate. Maybe it's going to penetrate in that shallow depth, but you want to see them penetrating all the way across the screen.
Okay, thank you. There is another question. How many lung zones should be checked on each side?
So the more, the better. However, more comes at the expense of efficiency, right? So if you have a patient with respiratory distress and you see B lines in the upper zones of the lungs, probably by default, the patient is going to have B lines all over, okay? And this is, we're talking about maybe a patient with respiratory distress due to congestive heart failure. You're not going to see a patient with respiratory distress that does not have like B lines probably all over.
Okay, thank you so much. Any other question, guys? Anyone has any question to ask? Okay, we will take this as no. Thank you so much, Dr. Ammar. And the next is Dr. Ahmed Abdel for a detailed lecture about the Rush protocol. Dr. Abdel is an emergency medicine consultant in Lincolnshire, as he told me. It should be pronounced like this: Lincolnshire Hospital in UK. He has a fellowship of Royal College of Emergency Medicine, European Master of Disaster Medicine, European Board of Emergency Medicine, and mashallah, he's a fellow of the Emergency Medicine and Echo Ultrasound in Ireland. Dr. Ahmed, thank you so much. The floor is yours.
Thank you, Dr. Muhammad, for your introduction. It's really a privilege to be part of this international symposium by Madinah Saudi German Hospital. Thank you so much for inviting me. I really appreciate it. I'm going to cover today rush protocol. Let me share my screen, if you don't mind. 1 second. Assume you can see my screen now. Okay. So, Bismillah wa sallallahu my today talk is about the rush ED protocol. Dr. Amar covered a couple of points. We will go in depth and in details about the rush ED protocol. Muhammad, I presume that this could be an interactive session. Is it okay, or I just go?
Let's try.
Once I give.
It all depends on the enthusiasm of the audience that you are going to create.
Okay, that's fine. So today we will cover a couple of points. So what is rush ED? It's a rapid ultrasound in shocked and hypotensive patients in the ED. Today we'll cover a case scenario, some objectives. Also, we'll go through some overviews and some facts. So the case scenario, we have a male patient, and this is a real case I've seen. Male patient, unknown name or age. He looks in his 40s. He was brought in by ambulance after he being found collapsed in the street with a strong smell of alcohol. On arrival to the ED, he had mild tachycardia at a rate of 112 with a blood pressure borderline of 80/50 and GCS of 13. We did a dipstick urine tox screening and it was positive for benzo and cannabis. His ECG was unremarkable. There was no signs of trauma except for a very mild graze to his forehead. His pupils were equal and reactive to light. What do you think, if someone wants to interact, what do you think we could do for this patient if you have this patient live in your ED? You could type or you could talk. I don't know if there is a room for talking. Okay. We can start with the Apcde approach. And as you see from the scenario, airway is patent, could be at risk because of the GCS is 13 and the blood pressure is borderline, but it's patent. Breathing assessment, nothing of importance. Circulation, as you see, blood pressure, heart rate, capillary filling time was 3 seconds. And finally, there was no signs of abdominal trauma or pelvic trauma. And we attached the patient to monitor, and this is a sinus tachycardia. Disability, GCS 13 out of 15. We don't know if it's from a trauma or this is from the hypotension or this is from the alcohol. And pupils are okay. Glucose was fine. And finally, a full head-to-toe exam. We couldn't find anything, and the patient wasn't very cooperative to tell if any tenderness or anything. So the plan was to do a CT brain to rule out any intracranial bleeding, which we have done, and there was no bleed, and to give some fluids, and to do a VBG, and to do sets of bloods. And after 500 ml normal saline, the patient had a good response. I will defer the rest of this management of this scenario to the end of the talk, and we'll come back to it. Okay. Just going next. Yes. So rush in ED. There are some people, they like to say it there are two different schools. You could say it in the way high MAP ED, mnemonic, or some other people, they like to say it, you check the pump, you check the tank, and you check the pipe. Both are okay, whatever you like. So the high MAP mnemonic, you check for the heart, for the IVC, for the Morrison pouch or the fast, You check for the rest of the high map, as we will see, the Morrison, the aorta, the pulmonary, and the ectopic pregnancy, and any possible DVTs. Or you go through, sorry, one technical error, 1 second. Just take us back. Okay, so or you check it the way we said, which is you check the pump, you check the tank, you check the pipes. Why we do the rush? It's a very useful tool to assess for what is the cause of hypotension or shock state for this patient, and when to do it as part of your clinical assessment. As you know that there's a new era of point of care ultrasound. It's the new stethoscope to the emergency medicine physicians. So it used to be inspection, palpation, percussion, auscultation, and now they added the 5th pillar to the assessment, or the basic pillars of the assessment, to become inspection, palpation, percussion, auscultation, and insonation. And how we do it, this is what we are going to see next. Okay, this is like a map for what we are going to do. If you see here, we usually, most of us, we know about the FAST exam, or focused assessment by sonography for trauma patient. We check the right upper quadrant, we check the left upper quadrant, the pelvis component, and the xiphosternum or subxiphoid. You add to them a view of the heart, or 2 views of the heart, pars-sternal long axis and short axis, and the other one is the apical. You check both lungs, and you also check the aorta on 3 levels. If you are good enough, you can add the suprasternal approach. This is a high map, as we said, and this is the pump, the tank, and the pipes. For the sake of this lecture or presentation, we will focus on the high map approach. We'll go through some facts first before this. In 2001, Rosenthal, they reviewed an ultrasound protocol they had created to evaluate the undifferentiated hypertensive patients. And in 2004, they studied the effect of early goal-directed ultrasound for ED patients with hypertension. And luckily, they found that the study showed reduction in number of conditions that needed to be ruled out. And they found that it's a quicker time to final diagnosis. So it's a really useful tool to use while during our daily assessment and daily work. And since 2008, it was the first hit on a Google search for rush exam from this date on, and it was published in 2009 about the rush protocol. Shock state, we have 4 types of shock. As you all know, we have the hypovolemic shock, which could be an external and or internal bleeding, or both. We have the distributive shock with the 2 components of anaphylaxis and sepsis. We have the cardiogenic shock, and finally, we have the obstructive shock. Obstructive shock, like tension pneumothorax, pericardial tamponade, pulmonary embolism, massive pulmonary embolism, or severe aortic stenosis. Okay, let's go now focus on the high map. We start with the H component, which is the heart. You are looking to the heart to see, would the ultrasound answer any question about the heart here to guide you what is the type of shock. And again, it's like a puzzle. So you have your history taking, you have your clinical assessment, and you have the ultrasound, and you have the investigations, and you put all the picture together, and then you get an answer for your question. What is the cause of shock for this patient? So it's not only you do only the H, and then you found that the patient if there's a problem in the heart, and you don't continue. No, you are advised, or we are advised, to complete the full protocol and the full assessment of the patient. And as Dr. Ammar said, it's a point of care ultrasound. It's part of your clinical assessment. It's not a departmental ultrasound. It usually gives you an answer to a certain question you are asking. It's not like a full assessment for the organ you are looking or the problem you are looking. Okay, and I usually say this to my patients and to my colleagues. Okay, the heart component. What are we going to look into in the heart? You look if there's any pericardial effusion, if any, how about the left ventricular function contractility? You can assess this by something called EPSS, and we'll go through it, or fraction shortening or ejection fraction. You can look into it also by visual assessment, and also a comment on the RV, right ventricle. Is it dilated? Is there any signs or signs of strain? Is there any thrombus you can see? So you will get an idea about these three things. Pericardial effusion. There's good literature behind us as emergency physicians on how we can accurately and correctly identify the presence of pericardial effusion. Okay, this is like a quick video to demonstrate how can we assess pericardial effusion. Use a phased array probe or the cardiac probe, put it subxiphoid. You see here the right ventricle, left ventricle, and you can see here the white pericardium. Here there is black shadow, anechoic around it, so it's pericardial effusion. And there's the next one is really interesting. When you see there is a pericardial effusion, as you will see next, 1 second. You see here, there's pericardial effusion and there's clot inside the pericardium, tamponading the right ventricle here. It's not like filling at all, okay? So that was a question for, is there any pericardial effusion or not? So I presume that you got the point behind this part. If there's a pericardial effusion and the patient is hypotensive, so you are looking into pericardial tamponade. So you should proceed to, if it's acute deterioration, you should proceed to pericardiocentesis, whatever, ultrasound-guided or landmark anatomically. It depends on the local policy or protocol you have. The second question, the assessment for the left ventricular contractility. Again, a piece of literature behind this, that the emergency physicians can perform this examination and get an estimate of left ventricular contractility that compares well with that measured by cardiologists. So we are well good in assessing the left ventricular functions. And simply, you just check, is it contracting or not? Is it squeezing or not? You don't have to fancy regional motion abnormalities. See on the right-hand side here of the screen, left-hand side of the screen, there is good contractility. And here, there is almost no contractility or very diminished contractility. Also, I need from you to have a look on the anterior leaflet of the mitral valve, as you see here, how it's hitting the septum, okay? And here, the anterior leaflet of the mitral valve, it's not like close to the septum at all, okay? If you put the M mode here, as you will see in the next image, over the tip of the anterior leaflet of the mitral valve to measure the distance between the E point, okay, of the mitral valve opening and the septum, this area is called EPSS, which is E point septal separation. If it's above 10 millimeters or 1 centimeter, so this is an indicator of heart failure. If it's below 7 millimeters, it's less likely to be heart failure. This is a two-dimensional technique, so it's not very reliable, and there are some exclusions, like if the patient is having severe mitral stenosis or severe aortic regurg. However, in most of our cases in the ED, it can give you a good idea about if the patient is having heart failure or not. Okay, I hope this is useful. Then next is the assessment for the RV. So for the LV, you assess for by left ventricular function, like visual assessment, and by EPSS. And here for the RV, you check if there's any dilatation or not, any strain, any thrombus. Again, this is a video. Simply, you do apical, you do parasternal long axis, you do whatever the view you do. If you are doing apical, you put it over the apex of the patient with the probe mark to the left-hand side of the patient. You'll get this image. You'll see the RV and LV. Usually, the RV is 1/3 of the heart diameter, and LV is 2/3. Or in another way, LV is double the size of the RV. If you found them both equal, or the RV is bigger, and now you can say that there's RV dilatation. A small trick here, or very important point, that if your probe is switched and you are not sure that it's you put your landmark correctly, you might be confused which is RV and which is LV. So make sure that your probe marking is properly directed. So you will see here an example of a normal RV. See, this is LV, and this is an RV, which is almost 1/3. LV is bigger. See the next image. See, a huge RV, and this is the LV. Okay. There are some more signs like McConnell sign, and you can measure the thickness of the post-septal to see if it's acute or chronic RV dilatation, but this is a little bit more advanced, and we won't cover it today. The next component, now we covered the first component, which is the H. Again, just to remember, we check for any pericardial effusion, LV and RV. And for the LV, how is the contractility? And for the RV, is it dilated or not? Is there any strain or not? And is there any thrombus or not? The next component is very, very, very useful component. You can use it as part of your protocol, and also you can use it to add it to the blue protocol or in your daily basis to see if the patient is dehydrated or not, which is the IVC. What we are going to assess in the IVC, it's the size of the IVC, the diameter, the collapsibility, and if there is any fluid responsiveness. Okay, so the size, simply, and we exclude from this any patient who is connected to mechanical ventilation. The patient shouldn't be connected to mechanical ventilation to apply these rules in. It's a simple way to guide you on how the central venous pressure for this patient without an invasive method or technique. If the size of or diameter of the IVC is less than 1.5 centimeters, with a total collapsibility, you expect the central venous pressure to be 0 to 5. If, on the other hand, if it's more than 2.5 centimeters with no collapsibility at all, you're expecting the CVB to be more than 20 centimeter water. So it gives you an idea quickly what is the CVB. And as you all know, if the central venous pressure for this patient, for example, is very low like this, you're expecting the patient to be dehydrated. And this could be with sepsis, could be with hypovolemia, like internal or external bleeding. On the other hand, if the central venous pressure is above 20, this could be cardiogenic shock, could be obstructive shock. So it depends. So this is the second piece of your puzzle. You put it beside the LV assessment and the heart assessment. Okay. Again, a piece of literature about how we can assess the IVC and about how the CVB assessment in relation to the IVC is reliable. Here, how can we do the IVC? The same way when we've done the assessment for pericardial effusion subxiphoid, and you rotate your probe, okay? You can do it by the curvilinear probe or the phased array probe. You see here, this is a very useful video to compare between a stunned or obtunded IVC on the right-hand side, non-collapsible, more than 2.5 centimeters, and on the left-hand side, it's almost, let me get it back to you again, it's almost kissing, and it's very small with a full collapsibility. Definitely this patient is hypovolemic, and definitely this patient is overloaded or hypervolemic. Okay. You see here, if the CVB is low, it's expected with hypovolemia, with distributive shock, with neurogenic shock. If it's high, it's with obstructive or cardiogenic shock. And if you go to the history taking, clinical assessment, and the H component and the rest of the components, you can answer and differentiate more. I hope this is useful. Okay, now we'll move to the M component of the high map, which is the Morrison pouch or Morrison's assessment, or it's the FAST. And as you all know, FAST is focused assessment by sonography for trauma patients. You check the right upper quadrant, the pelvis, and the left upper quadrant. And usually in FAST, you check also the pericardium, but we already checked it in the H component. Okay, literature, you can get to 250 ml up to 620 ml to be commonly cited by average trained person. However, if you are very skillful, there's some literature behind getting low volume up to 100 ml. First, in trauma settings, it's not a replacement to the CT scan. However, if the patient is unstable and a positive fast, the patient should go directly to the theater. Okay. The right upper quadrant component, as you will see in this video, you put an mid-axillary line, 7th to 9th intercostal space. Every patient has his own anatomy or their own anatomy. This is the anatomy, this is the kidney, this is the liver, this is the diaphragm, and you expect the fluid to be accumulated in the lower pool of the kidney, then in the Morrison pouch or the upper pool, and finally you can check the subdiaphragmatic as well. You usually check 4 places: Morrison pouch as here, upper pool, lower pool, and subdiaphragmatic. And if you are good enough, you can check the spine sign, and you can check also the lung curtain sign. You see the free fluid here? And a very good tip about the free fluid, it's pointy because it's filling in the spaces between the organs. It's not like inside the hollow of viscous. Okay. I know that I'm talking a little bit fast, but I need to cover a couple of all the points. The pelvis component, I usually start with this as part of my fast and I usually start with the longitudinal one because we forgot it sometimes. You do the transverse one. This is a bladder here, and this is a bladder, and this is a free fluid. And don't get confused if it's like seminal vesicles. Also in female, the longitudinal component is very important to check if there's fluid in between bladder and uterus in the Douglas pouch or behind the uterus. Okay, you see here. And when you start to see your images are very clear, this is not because you are starting to master your ultrasound. This is most probably the patient is having a free fluid making your images better or more clear. The left upper quadrant component, the same like the right upper quadrant, it's more posterior and more higher. So you go 5th to 7th intercostal space, and in the posterior axillary line, you have the stomach here, so your axis should be different to avoid the stomach bubble. And then you are expecting the accumulation of fluid to be mainly in the pouch or subdiaphragmatic, but you cover all the areas, the lower pool of the kidney, the upper pool of the kidney, the pouch, and subdiaphragmatic. Okay, as you will see now. Here, this is a spleen, and this is a fluid, and this is the kidney. It's not the best image, but it gives you an idea. Here again, diaphragm, spine, pouch, lienorenal pouch, spleen and kidney, lower pool and upper pool. You don't have to see all these components in one image. You could sneak in between ribs and be parallel to them to try to get an idea about all these parts. Okay, so now we finish the fast component. So if we presuming that the fast is positive and the patient is hypertensive, if there's a history of trauma, so this is a traumatic hypovolemic shock. If it's a spontaneous, could be something ruptured, like ruptured chocolate cyst or ovarian cyst, could be a ruptured spleen, could be anything else. So it depends on the history and the other components. You are expecting the IVC in a hypovolemia to be collapsible, okay, and to be almost kissing, expecting the left ventricular function to be normal or as baseline of the patient. And then we will move to the next component, which is the aorta. It's really important to have a quick look at the aorta to see if any abdominal aortic aneurysm or any dissection. We can rule out if there is any AAA by ultrasound, but we cannot rule out the dissection. We rule it in. So the rule of the ultrasound, point of care ultrasound for the dissection, it's to rule it in, not to rule it out. It's the same for like PE. If you have a patient coming with shortness of breath and you put the probe, you throw the probe over the chest of the patient and you found that the RV is not dilated, you cannot say no, this is not a PE. However, if you found that the RV is dilated, you could say, okay, it could be a PE. So it's a good to rule in, not to rule out. Okay. Here we are going to look. Suprasternal, you have good skills to have a look in the right pulmonary and the aortic arch. Excuse me. And you have a look in the parasternal long axis and short axis view. You check the epigastric area, and you go down to the bifurcation at the level of the umbilicus. Okay. Here, very good literature about the ability of the emergency physicians to perform ultrasound to detect AAA, and it's ranging from 93% to 100%. This is a sensitivity and specificity approaching almost 100%. So you should trust your abilities if you have good training. Excellent. The aorta, we use the curvy linear probe, the low frequency. Excuse me. And as you know, aorta, if it's above 3 centimeters diameter, it's abnormal. If it's above 5 with hypotension, it's a rupture AAA and needs vascular referral. If it's above 6, it needs urgent vascular intervention. We measure outer to outer. We don't measure inner to inner. Otherwise, we get like a false measuring or false negative. You start in the epigastric and you go down till you see the bifurcation. The first thing you look into in this image is the vertebral body. In front of it is the aorta, round, well-formed wall, non-compressible, self-pulsatile, IVC, oval, not well-formed walls, could be the transmitted pulse. Here you see this is the aorta. If you measure from here to here, it's going to be much smaller than if you measure the full lumen. So you measure from outer to outer. As you will see here, if you measure this, it's going to be 3 centimeters or 2 centimeters. If you measure the whole diameter, including the hematoma here around the aorta, is 7 centimeters. Okay. Some other images, but this is a leaking here around it. So you measure all of this. Okay. That's fine. Okay. So we now know about the aorta. And if a patient coming with abdominal pain and hypotension, and you examine his tummy with the ultrasound, and you found that the aorta is big, you have an answer for the question, and so on. You could also have a quick look on the parasternal long axis view to see if there is dilatation in the aortic root, or especially left ventricle out tract flow, to see if it's big or not, to expect if there is any dissection in the aortic root. If you can see the descending aorta in the parasternal long axis view. Again, you could see descending aorta and after the arch, and you can see if there's any dissection or not. When you see the AAA or the abdominal aorta for assessment of AAA, don't forget to get a longitudinal view to see if any flap could direct you to a possible dissection as well. Okay. Pulmonary, why we are assessing the lung. I'm not going to talk much about this part because it's covered by Dr. Ammar already, but we will just complete the puzzle by giving a quick hint about it. We assess for pneumothorax, we assess for hemothorax, and we assess for pulmonary edema or any overload in the lung, and also out of the trauma settings, any pleural effusion or empyema. The pneumothorax, as Dr. Ammar said, here some good literature about sensitivity and specificity, and you imagine that the ultrasound is higher sensitive and specific than the chest X-ray in detecting pneumothorax. Okay. Here is the pneumothorax assessment, just a very quick video to guide. You put it in 3 different zones in each lung, and you put it in between ribs. You will see a rib and rib shadow, and you will see in the image next. Yeah, see here the rib, and behind it the rib shadow. And here, the interface between the two pleura, visceral and parietal. And if it's sliding the white line and the slide is horizontal, they call it anti-Marshall sign. It means there is no pneumothorax. If it's not sliding, it could be pneumothorax, because there are plenty of diseases can cause a non-sliding. Okay, there's a good example about no sliding. It's moving vertically, not horizontally. So this is not considered sliding. So this could be a pneumothorax. In a setting of trauma, I'd say this is a pneumothorax. In different settings, we need to know the differential. Some other important and specific signs like the lung point, I'm sure that it's covered by Dr. Ammar in his lecture. The pleural effusion, as part of your FAST assessment, you can do it, or you can ask the patient to sit up if the patient is not trauma and it's okay. You can ask the patient to check the diaphragm and the base of the lung. Very, very, very important sign here, which is the spine sign. Okay, here, liver is one of the friends of the ultrasound. So you put the probe here, so the ultrasound waves go through the liver until it reaches the spine. So you can see well till the spine. And then the spine is ending here. In reality, spine is continuing, but you can't see it because this area is full of air, the air of the lung. So the ultrasound waves didn't penetrate through the air. Air is one of the enemies of the ultrasound. So you cannot see the spine after the diaphragm. If you can see the spine continuing after the diaphragm, it means there's a different media here allowed the ultrasound waves to reach the spine, which is most probably a fluid, which could be hemothorax, pleural effusion, or empyema. We'll show it to you. Again, spine, this serrated part here, ending at the diaphragm. You can see the mirror image, which is a healthy sign in this area. Okay. When you see the positive spine sign, you will get better idea about, yes, you see here, spine should stop here, but now there's fluids here, and the fluids allow the ultrasound to reach more deep, and you see the spine continuing. Another, this is double fluid. I'll put it back for you. Here, this is pleural. Here's pleural and peritoneal. Okay. Okay, and here there's pleural fluid, but it's full of particles, so it's most probably empyema. Okay. This is an assessment for the B lines as covered by Dr. Ammar. Plenty of B lines, more than 4. If the B lines are scattered everywhere in the chest, so it's either ARDS or pulmonary edema, or if it's localized. If it's in a trauma setting, it's mostly lung contusion. If it's in an infection setting, it's chest infection, and so on. It's well covered by Dr. Ammar, so there's no point to repeat it. Okay, so this is a pulmonary component. So when you have a patient, left ventricular functions are impaired in your H component, IVC is obtunded and non-collapsible, collapsibility is less than 50%, and FAST is negative, and the aorta is okay, and you found the pulmonary component, there are a lot of B lines everywhere, you would say, okay, this is a cardiogenic shock. On the other hand, B lines, there's no B lines, and left ventricular functions are okay, and IVC is collapsible, and a setting could be suggesting sepsis. So definitely this is sepsis, especially if you found like, do I still have time?
يا مدير انت ما في تعرف عندنا واحد يوم ما جاء كلهم مكان فيه هون كل مكان ايش؟ جياتس حرنيه في معركه البين الحرنيه كل مكان هون.
Can we mute our mic, please?
What is that condition? The patient have many holes.
Doctor, please unmute. Doctor, please unmute your mic.
Okay, thank you so much. Sorry for this error. Okay, so the next component is going to be the ectopic pregnancy, which is the ED part. So the ectopic pregnancy is going to be very quick. A patient, female, coming with collapse, positive pregnancy test or still pending. Don't get deceived plenty of times we've seen it in the ED settings, patient coming saying that I'm sure I'm not pregnant. I am on my period now, and then you find that this is not a period. This is just a PV bleeding, and the patient is pregnant, and this is ectopic pregnancy. So any patient coming with abdominal pain within the childbearing period, you consider doing pregnancy test, either urine-based or serum. It depends on your local policy. Okay, I won't forget this patient, female patient coming with a collapse, blood pressure borderline. This is a hematoma with a free fluid, and you see the rest of the free fluid in the peritoneum. The other views here, pregnancy test was negative for this certain patient, but if it's positive, it's a rupture ectopic. And you see the free fluid, how it's pointy. This is the tip of the liver, kidney, and the patient. This case I published it in the ASM. It's a case of ruptured chocolate cyst or ovarian cyst, and the patient was taken to OR and survived. Thank God. Okay. For this, finally, the Dvt component, which will aid you to the pulmonary component and to the RV assessment of the H component. So if you have RV dilatation and strain, and pulmonary is showing that there is no B lines and the IVC is obtunded, and you have a Dvt, so you're talking about a pulmonary embolism causing obstructive shock. A piece of literature about our assessment of the Dvt. There are plenty of literature about behind this. One of them is saying that even up to 2 hours of training on Dvt assessment to emergency physician, sensitivity and specificity are up to 95% to detect Dvt. Okay, here is you check the common, simply you check the common femoral artery, you check the common femoral vein, superficial femoral vein, and the popliteal vein. There are plenty of protocols. The most common ones either the 3 points or 2 points or the walkthrough protocol, and you check for compressibility. You don't have to see the clot. If it's non-compressible, the vein, it means it's a Dvt. If it's compressible, it's not a Dvt. As simple as that. Okay. So, questions, please. Just 1 second, guys. Sorry for that. So we covered all the components now, which is the heart, the IVC, Morrison pouch, which is a fast, aorta, pulmonary, ectopic pregnancy, and Dvt. Any question?
Assalamu alaikum, Dr. Ahmed. There is one question we received. Thank you so much for the lecture, wonderful lecture you have given. This is your usual. One of the comments that was sent to us is, no one knows how to measure it exactly. He's talking about, or she's talking about the IVC. No one knows how it's measured actually. Many experts love M mode, but it has serious flaws. And I think the other one is also about the IVC. They said that we don't even know where to place the probe. There's a lot of approaches. So can you comment on this?
So let me just make sure that I got your question correctly, Muhammad. Please. Your question is how to measure the IVC and how to properly or correctly place the probe. Is that correct?
Yeah, that's right.
Okay. Regarding the probe, you put the probe in the subxiphoid area. You can use any of them, like the curvilinear probe or the cardiac probe. And then you get an image of your heart, subxiphoid, and then you rotate. If you're using the curvilinear probe with the landmark to the right-hand side, okay, you will rotate your probe to the landmark to be towards the head. So you rotate your probe clockwise. If you're using the phased array probe and this is subxiphoid area, and you see in your heart, okay, you put your marker down, which is again clockwise. So you just rotate your probe, any of them clockwise, and then you tilt your probe a little bit towards the left, okay? You will see the IVC, okay? Another thing, the other part of the question is, once you see a good IVC entering the right atrium, you measure a distance away from the right atrium entrance, 2 to 3 centimeters, and then you measure over this. You can do it on M mode, or you can do it live on the IVC. Some people, they don't prefer to do it on the M mode because due to the respiration, the patient will move, so it's not going to be accurate. So whatever you like. Is that the answer for your question?
I hope so. Guys, anyone has any question, please send it to the Q&A section. Okay, I think this is no.
Okay, I need to summarize if you don't mind.
Please.
Just 30 seconds. Okay, so just to sum up, we knew how to do the rush protocol by checking the IVC, the aorta, fast assessment, any blood clots in the deep venous system, any ectopic pregnancy, possibility, fusions, right ventricle assessment on both lungs. Excuse me. Or the other image we done before for the 9 places, the 2 lungs, the 4 components of the fast, the heart component, and the aorta. And thank you so much.
Thank you so much, Dr. Ahmed. And please say hi to Afaf. Thank you so much. Now, could you please stop sharing?
I will. Thank you, guys.
Okay. Now the next lecture will be Dr. Chris Moore. Dr. Chris Moore is the chief of the section of the emergency ultrasound in the emergency department of Yale University. Dr. Chris, it's an honor to have you with us today, sir. The floor is yours.
Good evening or good morning here from Connecticut. It's an honor and a pleasure to join this conference. I really appreciate the invitation. Several years ago, we had tried to arrange me coming over in person, and I still would love to visit Saudi Arabia someday. So I hope that that comes to pass. So I'm here at Yale. I've directed the ultrasound program here for going on 20 years now. And you've asked me to talk about ultrasound-guided vascular access, which I will speak about. If we have time, I may go into some other procedures. I really think that understanding vascular access allows you to do many other procedures better, more safely, more effectively using ultrasound. Can you see my screens okay? Everything okay? All right.
Yes, everything is okay. Thank you. Yeah.
I do have some disclosures. I'm currently funded by the Biomedical Advanced Research Defense Authority, BARDA. We're looking at lung ultrasound and COVID actually now. Doing collaborative research with Philips Healthcare, another company called Caption Health that does automated intelligence with ultrasound, and I have stock options with RealDX. We do teaching. I may show a video from that company. So here's a video, and I don't know if you guys are using the chat or the Q&A. If you want to type in what we think we're looking at here, it's a linear probe. We're looking across the skin and soft tissue, and you'll see this motion over here on the left side of the screen. On the right, we have an area of hyperechogenicity with some reverberation or shadowing coming down. And this is actually the trachea. And what we're seeing here is an endotracheal tube that is in the wrong place. It's actually being put in the esophagus. And then they pulled it out here. And this shows the ability of ultrasound to guide a variety of different procedures, in this case, intubation. Now, hopefully you don't need ultrasound for your intubation, but I thought it was kind of a neat video to start with. So I don't know what the legal climate is like in Saudi Arabia, but here in the United States, we have a lot of lawyers, and they're always looking to see what's going on in the medical system if there's a lawsuit available. And I actually subscribe to this medical legal report. It's Moore's medical legal report, but there's no relation to me. And I'll just show you these cases that were recent. In this Smith versus Franks in Kentucky, a patient came to the emergency department in a diabetic emergency. The ED physician placed an emergent femoral line to give fluids and medication. Patient was resuscitated and admitted to the ICU. Later, it was discovered that the line had been placed in the artery. The patient required a resultant amputation of the leg. The plaintiff says, you placed the line in the wrong place and caused my amputation. You should have used ultrasound when placing it. Defense, the line was promptly removed. This is a known complication. The amputation was a result of underlying chronic disease. Result, verdict for the defense. So here's somebody who they put the line, they did not use ultrasound. They put the line in the artery. The guy lost his leg and they said, okay, that's fine. That's just something that happens. Here's another case, Blackman versus Webb in Georgia. Patient comes into the ED in shock with hypotension and tachycardia. They made 2 attempts at subclavian access, then found a pulmonary effusion. CT showed blood in the chest. Chest tube was placed. A large amount of blood was returned. The patient that went into brady-systolic arrest and died. Plaintiff, you lacerated my subclavian vein and didn't recognize it. You didn't ask fast enough. Defense, this is a known complication, and verdict for the defense. So these are 2 cases that are not long ago that just kind of show that in the United States, as far as the courts are concerned and standard of care, they don't consider ultrasound guidance to necessarily be standard of care. I actually hope that this changes at some time in the near future. We had a report going back now more than 20 years by the Institute of Medicine here in the United States that found that there were between 44 and 98,000 deaths per year in US hospitals due to preventable errors, with more than 5 million central venous catheters placed per year in the US, and mechanical complications occurring in between 5 and 26% of these. These mechanical complications include arterial puncture, which usually can be remedied fairly quickly, cannulation or laceration, pneumothorax, and then there's other things, just infection and things like that. So what's the evidence on this? You can go back to 1996 in critical care medicine. They did a meta-analysis, which means there had been dozens of studies that were done before this meta-analysis. And they concluded that when used for vessel location and catheter placement in real time, ultrasound guidance or Doppler ultrasound guidance improves success rate and decreases the complications associated with IJ and subclavian venous catheter placement. So we know that this works. We've known this since 1996 or even before. And yet we still have standards coming out. I've participated in standards with the American Institute of Ultrasound and Medicine. This one is from the Society of Echocardiography and Cardiovascular Anesthesiologists. They reviewed the evidence and basically concluded on level 1 evidence that properly trained clinicians using real-time ultrasound can reduce the incidence of complications associated with the insertion of large bore catheters. And yet, and this is going back a little ways, but still there are many places that are not using ultrasound routinely to guide their central venous access. This is from the NICE guidelines. This is in the UK actually, but they found that only 28% of anesthesiologists were compliant with the guidelines. So I don't know what it's like in Saudi Arabia. I'd be interested to hear if you want to place it in the Q&A or the chat, whether you're using ultrasound for line guidance, and hopefully you are, but if not, why not? There's many reasons where people say that they can't or aren't able to use ultrasound. It is a user-dependent technology, meaning you need to know what you're doing with the ultrasound. It's not just as simple as putting the ultrasound on the neck or the groin and having the needle go magically into the vessel. You have to really be able to track your tip. And they've actually shown that there are complications that can occur even with ultrasound. And there's some case reports of posterior wall penetration, things like that, where you're actually not following the tip of the needle as well as you should be. Simulation training can certainly improve this. This was a study done at our site where we looked at simulation training with central venous catheterization. We used one of these models that's fairly realistic for both IJ and subclavian, and trained our residents and showed that they were able to improve their success rate and decrease complications by using simulated training. So is this or will this be a standard of care in the United States? And I'm still waiting for cases to come out about this, but we actually looked at, what is it that makes something the standard of care as technology evolves. And this is a paper that I wrote with a colleague of mine, Ed Monaco, who's a lawyer as well as a doctor. And we looked at basically, what happens when technology comes into the hospital and the medical workplace. Going back to 1987, there was a case in Washington, D.C. of a patient who was intubated and they put it in the wrong place. It was esophageal, was unrecognized, and they ended up with a hypoxic brain death. In this case, end-tidal CO2 is not used. And the lawsuit stated, that they should have done it, even though it wasn't being done in many places around the country at the time. They felt that it was part of an emerging standard of care, and that a teaching hospital or a medical center, these places are responsible for adopting the cutting edge technology. And so I do believe this is or will be emerging as a standard of care, and I hope to see that happen. Even so, there are people within our specialty in emergency medicine in the United States who are resistant to this. And this was an article or a letter, I should say, in Annals of Emergency Medicine, which is our sort of lead journal. And basically it's saying, even though they showed that ultrasonography could be helpful for IJ placement, it is premature to universally accept this technique as a new standard of care, and basically stated the customary standard of care may persist if the burden on physicians to incorporate new innovations under an evidence-based medicine standard proves to be too great. In other words, if it's too tough to do this, maybe it shouldn't be standard of care. And this can encompass things such as, do you have the equipment? Do you have the training? But I really do believe that it's gone far enough that we need to understand that this really is and should be standard of care. So this is again from our article, evidence suggests that emergency ultrasound should become standard of care practice in certain clinical scenarios. Okay, so let's get down to, actually talking about how we do this. And I'm reading in the Q&A right now from Ahmed Jaber. Just my opinion, ultrasound use in Saudi for large venous line insertions is getting more popular for sure, though it is still based on where you do work in Saudi. Some places in Saudi have it as standard and others use it if they have it. And I would say that that's actually quite similar to what's going on in the United States right now. There's a lot of places, at our shop, it's rare, if ever, that we put a line in without ultrasound guidance, especially a central line. But there are definitely places around the country where there are physicians who just didn't train with ultrasound, or their equipment isn't there or up to par, and they aren't using it. They're used to blind subclavians, which really have a high rate of mechanical complication. So I do hope that you continue to learn how to use this and incorporate this technology in your country. So let's talk about how we actually do this. Transducer selection, in almost all cases, we're going to be using a linear transducer. I will say, there are other transducers you can use if things are really deep or really tough. I had a colleague who really liked to use the endocavitary transducer for necklines when they were being done by a junior resident, and he would put the probe on there and have them do it so he could watch while keeping his hands far away from the needle that the junior resident was yielding. But in any event, linear probe is typically what you're going to do, and that's going to give you high frequency, high resolution. And the way that I think about using this is that the indicator, which is shown by a P in this case, I keep it to my left all the time. So even if you're going to the head of the bed and looking down, this is one time where the indicator will be to the patient's left, so that you're looking through that plane and you're able to adjust the needle as you need to. So linear high frequency probe. So there's a couple ways to do this. You can do it two-person, meaning one person's holding the ultrasound and the other person's holding the needle. I really do think that as you evolve into doing this, a one person is the preferred technique. The other thing you can think about is whether you want to do it statically or dynamically. So a static technique would be similar, basically to just visualize the vessel and then put the probe down and kind of remember or know where you're going, make sure that you've got no clot in the vessel, that sort of thing. And I actually think a static technique is maybe very reasonable for things like paracentesis or thoracentesis, where you have a large pocket of fluid and you just want to find the best space to go. But I do believe that for something like vascular access, you're going to really want to evolve towards dynamic single person guidance, meaning you're holding the probe in one hand and then going in with the other hand and really tracking your needle as you go down. So I do think it's important that you pre-scan the patient before you get sterile, just to make sure that you're in the right place, that you have a good vessel, that there's no clot in the way, and then find your best access point. Confirm that it's compressible. These things can be tricky sometimes, especially in patients that are hypotensive or in shock. And even the veins will show some pulsations. A lot of time it's more respiratory variation than pulsation per se. But what I do is I press on these vessels, make sure that the venous system collapses, and you can press on the artery enough to kind of put it into an oval shape and watch the pulsations, and then know that that's the artery versus the vein. You want to get sterile for central venous access, obviously. For peripheral IVs, we use a cover, but it's not necessarily sterile. We don't necessarily do peripheral IVs using full barrier precautions. So you want gel, typically inside and outside of the probe cover. There are some good adhesive covers that don't need gel on the inside, but if you're using one of the longer ones, you want to make sure you have gel inside and outside, including sterile gel on the outside. So there's a couple different ways to approach the guidance of the actual needle going in. And this is from a New England Journal article I wrote, has good illustrations on this. And this is showing in plane, and it's often referred to as long axis, but I really prefer the term in plane, meaning that the needle is in the plane of the ultrasound. And there's some real advantages to this in the sense that when you do it correctly, you can see the entire needle shaft and the needle tip going in. And on the bottom right image here, we see a long axis to the vessel, in plane technique, watching that needle shaft go along and enter the vessel with the tip there. So there's some definite advantages to in plane in terms of seeing the tip, but the disadvantage is that you may not be able to center it correctly. Now here's another clip showing phantom, basically, and we're putting that needle in the in plane axis with the tip coming in, and then as we pierce the wall of the vessel right there, then we inject a little bit of saline here. And you can see some of those little micro bubbles or little punctate hyperechoic things. And you'll often see that even if you're not trying to put air in there, anytime you inject something, there's often little micro bubbles, and you can definitely use that to help confirm that you're in the right place. So this is a video, it's kind of long. This is back in the days where we were recording our images on DVD, but it's somebody trying to access a vessel, and they're coming in an in-plane technique. But the problem is they're actually, the needle is not over the vessel. So then they're going side to side, they're finding the vessel and then finding the needle, but they really don't know exactly which way to direct the vessel, or the needle, I should say, because they can't see the needle and the vessel at the same time. And this is the problem with in-plane, meaning if you use an in-plane technique, if you're in the right place, it works great. But the whole point of ultrasound is that it helps direct you when you're not sure where you are, or if you're not in the right place. And this is the reason why I use, and I recommend that you use, the out of plane technique, sometimes called the short axis. Really, short axis refers to the axis of the ultrasound versus the vessel where it's cutting across it. The out of plane means that the needle is actually out of the plane of the ultrasound. Now, the nice thing about this is it allows you to direct the needle side to side, but the downside of it is that you can sometimes cut across the shaft of the needle more proximally, and you may not know where the tip is. So what you really want to do is kind of fan along here until you find the tip of the needle. And we call this the vanishing target sign when you see it inside of a vessel. In other words, you're going to advance that needle, and you can see it on this image right here, where the needle is in the center of the vessel, and it looks like a target sign. But then what we're doing is fanning the probe along a little ways, and you can see that punctate needle in the center sort of vanish. And it vanishes right in the center of the vessel. That's what we call a vanishing target sign. And that basically ensures that the tip of the needle is centered in the vessel, and you're then good to go as far as sliding a catheter or putting a wire in. So my advice on doing this stuff is that you learn how to do ultrasound-guided peripheral IVs really well. These are tough, especially in patients that have difficult vascular access. I estimate it probably took me about 30 procedures, maybe even close to 50, to get really good at this. And it's a procedure that I like to do it. I do it often. I'm the one they come to when nobody else can get it. And it is challenging because it's a small vessel, it's a small needle, it's often deep. A lot of times these patients will have some scarring, but I use a single person dynamic guidance. And the thing about learning how to do these peripheral IVs is that if you can get good at doing these, all the other procedures become very easy. The large central venous access procedures become a piece of cake because it's such a big vessel that you're hitting when you can do the peripheral IVs well. And this also translates to just learning how to guide your tip, and that translates to many other procedures, whether that's paracentesis, arthrocentesis, pericardiocentesis, whatever you're doing. So for peripheral IVs, I think it's really key that you choose your vessel correctly. If it's super shallow, you usually can palpate it or see it, and ultrasound doesn't necessarily help that much, and it actually may even get in the way by compressing the vessel if it's very superficial. So I would say that 5 millimeters is probably the ideal depth. 5 to 15 millimeters or up to 1.5 centimeters is okay, and I often get vessels in that range. When you get over 15 millimeters, it can be really tough. I've done them as deep as 2.5 centimeters. We do have another ultrasound catheter that we use that is 2.5 inches long and has a Seldinger technique or wire built in, and that's called the Apcde catheter. But for most of these, I use the longer catheter. It's a 1.88 inch catheter. A standard catheter in our facility is 1.25, 1.25 inches. So this is slightly longer. And I really recommend that you use the longer catheters for ultrasound-guided access, peripheral access. And the reason is, they often are quite deep. You're going in at an angle. So you need to make sure that you have enough of the catheter in the actual vessel. These do have a tendency to slip out, especially the shorter ones. And the problem is if they infiltrate and it's quite deep, it can be difficult to tell. And we have had cases where we've had problems with contrast or even vasopressors extravasating when the needle or the catheter wasn't far enough in or wasn't correctly placed. So be careful with these. Use the longest catheter that you can. Again, I recommend using an out-of-plane technique to track my needle tip down there, to find that vanishing target sign, and then to thread the catheter. I do rely on the image, not necessarily on the flash. And the reason is you can easily backwall a vessel and get a flash. That doesn't mean that you're necessarily in the vessel right then. As you get good at this, you'll kind of feel that pop when the needle goes through the endothelium, and you'll know that you're in, and you can see that, that vanishing target sign, that tip right in the center of the needle. So this is a clip kind of showing what can happen, especially with a peripheral IV in a patient that is hypovolemic or the venous pressure is not very high. And that is basically what's happening here is the needle is going in, and we're showing it in an in-plane, which does show the whole needle tip. And you can see that the endothelium is kind of pushing into the other one. So the vein is collapsing. And then as soon as the needle goes through, it goes through the anterior and then the posterior right away. So that is what's called backwalling. And it actually happens quite frequently when you're doing these. It's nothing to be worried about. You just need to recognize it. And then what you need to do is kind of pull back. And then oftentimes I'll switch to a short axis or in-plane or out-of-plane technique, I should say, that bottom right clip where we see the tip of the needle or the catheter kind of bobbing in the center of that vessel. And then we fan along to make sure that it vanishes and we know that we have the tip centered in the vessel. So, endothelial tenting is something that, I think is tough. It can sometimes make it look like the tip is in the vessel, but it actually hasn't pierced the endothelium yet. So make sure that you kind of get through that, that you feel that pop. And sometimes I'll flatten out the needle a little bit and advance it a little bit further to make sure that it gets in. So here we go. You can see this tenting, and then the needle pops in there, and you can see again we're injecting a little bit of fluid, and it's we can see the micro bubbles kind of going along there. But you see that sort of lining of the vessel, the endothelium, kind of tenting in as you push in. So you just have to push hard enough and far enough so that it gets through that, and you know you're inside of the vessel. So here's again showing back walling and then kind of come back. So if you go in and you go too far, you want to pull back and then flatten out the needle and kind of advance it a little bit further until you can see that vessel right in the center. So again, watch out for the back walling and try to straighten it out. Okay, so here's a clip showing an actual wire going into the IJ. This one's fairly deep. You can see the carotid next to it, but we're tracking that wire down. And once you get in, I do think it's really important that you verify this, and we actually require that our residents in particular, or anyone doing this, performs a flush, where you put that needle in and then you flush a little bit of saline. You can agitate it some, and that may help, dissolve some of the microbubbles that allow visualization of the flush that you're putting in there. The other thing you can do, which I often do, especially with central lines, is prepare a flush and then look at the heart. If you can get a good look at the right atrium or right ventricle, often just a subxiphoid or maybe a parasternal, if you're flushing in correctly, those bubbles should go straight to the heart. It's essentially what you do with a bubble study. And you should see that opacify the right side of the heart, and that can ensure that you're in the right place. So here's a flush. We're showing this in the short axis or out of plane, so we're a little bit upstream. And we're just taking a 10 cc syringe with some saline and flushing that in and ensuring that we're actually intraluminal for our catheter. So that's peripheral access. I want to go through the basic central venous accesses that we do, just to give you some tips. IJ, an ultrasound-guided IJ is probably the most frequent ultrasound-guided line that I do if I need to do one in the department. And basically, you want to have the patient in Trendelenburg. Remember, your landmarks for this are your two heads of the sternocleidomastoid, the sternal and the clavicular head, and you kind of go up to the where those come together. You're directing your needle to the ipsilateral nipple. And just a note here, I mentioned this before, but when you're at the head of the bed, make sure that your indicator is to your left, which is the patient's left as well. That will allow you to adjust the image and the needle direction correctly as you go in. So be careful of overlap. Here we're showing in this clip on the right, where the IJ is actually directly over the carotid. And that may not be ideal. You may track up and down the vessel to find a place where it's more lateral, but there are times where that's still your best access point. And you just have to be super careful that your needle doesn't go too far. You're going into the IJ and you're not back walling it and getting into the carotid. So here's an IJ, again, coming in. We're compressing that vein to show it. We're trying to find it lateral, but it looked like the best place to approach it here was close to the skin. And it's tenting in a little bit. As we're watching it, we're making sure that our tip goes in there and doesn't go too far. So I'm reading in the question and answer here. I used to work in different hospitals before. Why is there lack of culture of using vein detectors in spite of being well set up hospitals, still depending on manual venous access? Yeah, that's a great question. And there are certainly alternate technologies aside from ultrasound for peripheral veins, particularly in pediatrics. And I know, there are places that use those a lot. And I'm certainly not opposed to that. I think it just depends on your hospital culture. I mean, certainly there are times where a peripheral venous access is easily done just by landmark technique and being able to palpate it and see it. And a good nurse, maybe you'll get that. But I'm not opposed to other technology. I think it's just important to get the right thing. I do think for central venous access, ultrasound is definitely a huge asset for doing this. So for femoral access, some people say you really don't even need ultrasound for femoral access, but I would say, it is, there are times where it's not completely straightforward to get the femoral access. A lot of times these patients are obese, they may be hypotensive. I have seen people, I've come into rooms where somebody's about to place a dilator, and I said, let me just check that with the ultrasound, and they've got the needle going into the femoral artery. And especially in patients that are sick, hypotensive, or in shock, you know, the pressure may be low, the blood may be dark, it may look like it's venous, you may think you're in the right place, but like that case that we talked about at the beginning of this, you know, you can misplace these catheters. So I think it's important to visualize it using ultrasound. The other thing to note is that, you know, with the femoral vein in particular, it dives deep to the artery very quickly as you go distally. If you start at the inguinal ligament, the vein is typically medial to the artery. But if you go just a little bit distal, it'll dive deep to the artery. And it's tough to access it there. You don't want to go through the artery to get to the vein. So take a look and make sure that you're proximal enough when you're accessing this. This is an old but good illustration from Anesthesia of 2000. It's showing how quickly the vein dives below the artery. So at the inguinal ligament, the vein is quite adjacent to the artery, it's medial. But as you go 2 centimeters, it starts to dive down at 4 centimeters, which is really not that far. The vein is completely below the artery. So just be aware of this, make sure you're going high enough, use your ultrasound to show where the vein is actually medial and you can access it correctly. So here's a clip again showing good compression. You can see the saphenous vein coming in from the medial. This is in the patient's right leg. So the vein is medial. And we're using good compression to find that vessel and then track into it. So subclavian, I will just preface this by saying I'm not a huge fan of a subclavian access. I just think I've seen too many mechanical complications from people doing this, especially blind. It is a little tougher to track this one using ultrasound because the clavicle gets in the way of the ultrasound beam. A lot of these are actually sort of axillary vein cannulations when you use ultrasound, which is fine. And you certainly can use this. And there may be situations where you want to or need to do this, this line. And I think, you know, ultrasound can certainly help you with this, but it is a little bit tougher. The other one, so we'll watch this right here. You can see the skin and soft tissue, and then we're actually starting in a short axis and then going to a long axis to track that vein. And this may be an instance where you kind of do want to come in the in plane or long axis technique. Another one that is sort of uncommonly used, but I actually like it, I've used it a fair amount, is the supraclavicular approach to the subclavian vein. And this is something that was described as far back as 1965 using a landmark technique. But with ultrasound, it's actually a pretty good line. It's a little bit lower in the neck, so it's better for infection control. It's a huge pool of blood. If you track the IJ down to where it merges with the subclavian, you can do a very nice, in-plane access to the subclavian. So I'm gonna sort of pause there. We'll talk about confirmation, but wanted to know if there are any questions about vascular access. This is the one that I'm talking about where you use the agitated saline to inject, and you can see the bubbles opacifying the right heart. The other thing that's worth doing after you do anything that's near the chest, including IJs, which can go deep sometimes, is to take a look and confirm after your line placement that you still have lung sliding, that you haven't caused a pneumothorax. So ultrasound can certainly be helpful to guide your vascular access placement, but can also be helpful to confirm your placement and to ensure that you haven't suffered any other complications. Okay. So that's what I had to say about ultrasound-guided vascular access. I believe I have about 10 more minutes, so I'm happy to take questions, but I also thought maybe I'd talk a little bit about some of the other procedures we do using ultrasound, if that's all right. So anybody want to type in the Q&A what we're looking at here? This is a less common procedure that we do. So in this case, we're actually using what we call the endocavitary probe. Some people call it the transvaginal probe, but we prefer endocavitary for this exact reason, which is this is actually placing the probe in a patient's throat. And what we're visualizing here is a complex hypoechoic structure with some septations in it, and that's a paratonsillar abscess. So we're able to kind of find where that is and then go ahead and drain it. It's sometimes tough to do this in a dynamic technique to have the probe and the the needle in the same place. But you can often at least determine that there is a peritonsillar abscess and really get a sense of how deep it is and exactly what angle you want to approach it at. So that's using endocavitary probe to detect peritonsillar abscess. This is actually a little bit deeper, and you can see the carotid there, which is something you may want to avoid. They actually did published in Academic Emergency Medicine about this and found that, of 28 peritonsillar abscesses, they were able to identify 100% of them using ultrasound and was much more successful when ultrasound guidance was used. Thoracentesis. So we do these in the emergency department. I think ultrasound is great to, first of all, identify a pleural effusion, and secondly, tell us where to best access it. It's going to be typically inferior, and I usually come in from the back. But you can go up and down far enough to find the diaphragm and to find your biggest pocket of fluid. This is a procedure where I do think static technique is acceptable, meaning you put the ultrasound probe on there, you find the biggest pocket of fluid, and then you mark it. A lot of times I'll use the end of a pen to kind of indent the skin, and then I'll put the probe down and then prep it, and then the indentation will still be there as I go in with the needle. This is a clip here showing a linear probe, and you can see that there is an effusion. The diaphragm is pretty close there, so we might want to go a little higher here, but you can see that needle, it's in there and it's right in the space, and it hasn't quite come in contact with the diaphragm yet. So paracentesis. This is another one where ultrasound guidance can and should be used. First of all, just to make sure that you're actually dealing with ascites. I can't tell you how many junior internal medicine residents have come up to me and talked about shifting dullness and fluid waves and things like that, but they've actually just been palpating someone who's obese and doesn't have actual ascites. So there's no substitute for ultrasound in terms of ensuring that you have ascites and finding your biggest pocket. And again, this is one where you want to look, and I often use a static technique, find the biggest pocket of fluid that's closest to the skin, and then put your probe down and access it. You will see bowel in this case. People worry about puncturing the bowel. In 20 years of emergency medicine, I've never seen that happen. And actually, if you watch it with ultrasound, it's actually tough to actually puncture the bowel because the bowel moves around. So if the needle comes in contact with it, it usually just kind of pushes it out of the way. You'd have to have scarred down bowel and a lot of force to really to perforate the bowel with a needle. So here's showing that needle come in into a large pocket of fluid in a paracentesis. The other thing to be aware of, we often are doing these procedures in patients that are coagulopathic, they have liver disease and ascites. You can check their coags and their platelets, but a lot of times they still need the procedure. So the one thing you really want to avoid is the inferior epigastric vessels. And ultrasound can be pretty good to localize these. They sit right on the peritoneum. They're small, and there's typically two veins paired with an artery. We're showing color flow Doppler on here, and you can see those three vessels, the artery in the center and the veins on each side. And it's really good to localize those, just to know where not to go with the needle. I mean, it would be pretty tough to hit those if you were trying, but that's something you don't want to hit when you're accessing the abdominal wall with a needle, particularly in a coagulopathic patient. So briefly on pericardiocentesis, when we do these, a lot of people, you'll see in emergency medicine that if they have to do it, they attempt to access it using a subxiphoid approach. What I would say is that that's a long way to go. A lot of times, especially if you're going through the liver. And in fact, the Mayo Clinic, which published one of the largest series on actually accessing pericardial fluid, found that out of 211 cases, they felt the paraapical approach was the best one in 173 of them. And I would agree that if you're trying to access fluid, you're best off finding your biggest pocket of fluid that's closest to the skin. And a lot of times that actually is paraapical and not subxiphoid. It can allow you, by looking at the chest, to see where the lung is coming in. So if you're getting lung come in where you're planning to put your needle, you may want to slide down a little bit or away from that. But when you can see it well, this is the upper right is showing a paraapical probe placement where the distance to the fluid there is only about 2 centimeters, and there's really no lung coming in right there. So you should be able to access that well. And I would just like to put a plug in if you have to do this procedure, that you consider a para-apical approach rather than a subxiphoid. Here's a still image actually showing that needle tip. One thing you can do is even if you're coming in para-apical, you can use a subxiphoid approach to see when the needle gets into the space. That way your needle is not in the way of the probe. Static technique is also acceptable here, but especially if you have another observer or somebody else in the room who can hold the probe and watch it from a different angle as you come in using an approach from the chest. So here's a condition. I don't know if anybody is willing to type in the Q&A. I don't know, and I'm not sure if there's a chat. I haven't been able to monitor that, so I'm looking at the Q&A. But can anybody tell me what condition we're looking at here? So this is actually 3rd-degree heart block. If you watch closely, you can see that there is some atrial contractions, essentially the P waves. You can see that mitral valve moving, but only every once in a while is the ventricle contracting, and that's because there's no conduction of the electrical signal, and there's a ventricular escape beat or rhythm that's about 30, I would say a heart rate of about 30. So what are you gonna do for this? If they're hemodynamically unstable, you can try to pace them transcutaneously. But the other thing is to use ultrasound, first of all, to get your central venous access, typically an IJ, and then to watch your transvenous catheter go down and really get placed at the tip of the right ventricle. And it will also allow you to see if there's mechanical capture. So this is an actual transvenous patient that we placed going down through the tricuspid valve into the right heart. You can use the EKG tracing, but I really think ultrasound is a great way to see if that pacer wire has made it to the tip of the right ventricle and if it's capturing mechanically. I probably don't have time for a lot of this as far as nerve blocks, but I'll just show you. This was a patient that we saw who actually had a shoulder dislocation. You can see that distance between the humeral head and the acromion, or essentially the glenoid fossa right there. So here's your space and the humeral head. And then what I actually do on these, a lot of times if I'm trying to avoid procedural sedation, is to do a nerve block on the interscalene brachial plexus of the neck. And you can see this kind of stoplight configuration between the medial and anterior scalene muscles. Here's the stoplight, red, yellow, green. And this is me actually doing an ultrasound-guided approach onto the interscalene muscles. She had a shoulder that was out. We were able to put 10 cc's of Lido in and reduce it with no pain and no procedural sedation. Okay, so in the interest of time, I'm just gonna go through this. Arthrocentesis, make sure that you have a pocket of fluid before you try to get in there. But if you have one, it's a really good way to get in there with the needle. This is a knee effusion where we're tapping that. Hip you can do as well, especially pediatric patients. And this is an abscess, another thing you may want to take a look at before you're actually cutting it open. This is an example of actually not an abscess, right? This is a linear probe. We're looking in somebody who had swelling and erythema to see if we found a pocket, but it's really just cobblestoning and nothing that you need to cut into. I'll end with this procedure here. We're using a curvilinear probe. Here's the bladder, and here's a needle coming in. This is a patient who we were unable to place a Foley catheter. They were in urinary retention, so we placed a suprapubic catheter, and we watched that needle go right into the bladder. So anytime you have fluid and a needle, ultrasound is your friend to help you guide a procedure. This is a slide. I was able to have a sabbatical a few years ago. I took my kids down. I practiced medicine in New Zealand for about 4 months. We would pick them up from school. It was at the top of a hill, so they would slide down into the back of the car, and we would go from there. So I will stop there, and I am happy to take any questions. But again, I appreciate the opportunity to join you all in this conference, and good luck.
Thank you so much, Dr. Chris. Really appreciating the effort and the marvelous lecture you have given us. I have a question from me myself, actually. I'm a big fan of the internal jugular vein approach while having a central line catheter insertion. But sometimes, especially in the geriatric age group or the really shocked patients, the vein is already collapsed. Even when you try to raise the legs a little bit, and so it's really collapsed. Is there any tips and tricks you can overcome the puncturing any adjacent structure?
Yeah, sure. I mean, that's tough if they have a short neck. I mean, certainly putting them in Trendelenburg, so you have increased venous pressure, and that'll dilate the vein. If they're able to cooperate, they can do a Valsalva, which will kind of blow up the IJ, and then turning the neck enough to try to really elongate that vessel as much as you can. But it can be a challenging procedure for sure. So you just got to use your best judgment in terms of which site you're accessing.
Okay. Okay, thank you so much, sir. I didn't receive any question in the Q&A section. If any question come to us, we are going to forward it to you. Thank you so much. Thank you.
Okay, thank you.
Thank you. I think we're going to have like 20 minutes of break now for prayer and rest. Then we are going to restart again at 6:30, inshallah, with Dr. Mahmoud Saad. Thank you so much.
واحدة في تاريخنا. فبعد أكثر من 30 عاماً من شهرتنا باسم مجموعة مستشفيات السعود الألماني، بدأنا رحلة تجديد وتغيير علامتنا التجارية لتصبح السعود الألماني الصحية. لا يقتصر التغيير على الاسم والتحديثات البصرية فحسب، بل يعكس قدرتنا على التطور والابتكار والتغيير الإيجابي أيضاً.
السلام عليكم ورحمة الله. Thank you so much. We are back again. Dr. Mahmoud Saar will be with you. Dr. Mahmoud.
Hello, good afternoon, everyone.
Assalamu alaikum, Dr. Mahmoud. Sorry for the interruption. I have to introduce you. Dr. Mahmoud is a consultant of emergency medicine in Lincolnshire Trust. He is Egyptian Board of Emergency Medicine, Fellowship of Royal College of Emergency Medicine, and Trauma Emergency Medicine Fellowship in Hamad, Qatar, Hamad Hospital in Qatar. Dr. Saqr is an ASIP teaching fellowship from the USA. He is an instructor in ATLS, ACLS, and also in European Association Council. Thank you so much, Dr. Mahmoud, for being with us. The floor is yours.
Thank you very much. Good afternoon, everyone. Thank you very much for the invite. It's a really honorable event and honorable speakers. It's a pride for me, indeed. Bismillah, alhamdulillah, salatu wassalamu ala rasulillah. So today, I think most of my presentation has been introduced by Dr. Ammar and Dr. Abdul Sadiq. Because you know the echo or the ultrasound is a continuum. Most of the time you are dealing with a patient as one piece. So you need to do sometimes the echo, sometimes the rush, sometimes the blue protocol. So they interfere with each other. So most of my lecture will be like reiteration for what they have highlighted. So I'll start with, sorry, I need just to activate, yes. We will start with the introduction for today. Our objectives, we will know some definitions about the echo, and we will read about some literature. We will understand the role of the POCUS or the point of care echo in the ED. We will know how capable is it for the emergency physicians to do an echo. Is this something really easy to perform or no? Is it a trustable thing or no? Can you generate data that the patient will benefit from or no? And we have some the views of the echo. We call them the views, which are the windows of the echo. How can we obtain them? And I have 3 quiz cases. All of those are real cases, and we will see how to get the best image. So most of the videos, I try to get all the videos in this presentation are our patient videos, not from online, but sometimes because of the short time, I could not finish all of them as our videos, but all the patients are our patients who have seen in our departments. We have managed them according to the video that you are going to see. So a lot of protocols are there. It's not about reading and memorizing. It's about how you'll practice them. And in each situation, there is something that you know, there is a protocol that you must follow. For us in emergency, I think the rush protocol is the most important or the easiest one for us to perform. So let's have a look at the views of the echo. My advice to you, first of all, as any ultrasound lecture, they will tell you that first of all, you must familiarize yourself with the machine, because you have some buttons on the machine, you need to know about them. All the machines, they have the similar setup, but they have some differences in the nomenclature. So just familiarize yourself with the machine. You must know how to introduce your patient data and how to choose the settings. Why am I telling this? All the ultrasound probes, as far as I know, they have an orientation apart from the echo. What is meant by orientation? When you put the probe and the screen in front of each other, the echo probe or the marker on the pointer or on the probe should be matching the one on the screen, except the echo. In another word, an easier one, if you look at the screen of the ultrasound machine, you will find a pointer or 2 letters or the name of the company at the base of the ultrasound beam. In all other views or all other modalities, this will be on the left-hand side of the screen, except the echo, it will be on the reverse. So to relieve your head from all this headache, just choose the cardiac settings on your machine. Once you choose the cardiac settings, you will be able to choose the proper cardiac echo mode. So in fact, we have a lot of views for the heart. We have, we can countless according to the practice. We are not echocardiographer, we are not cardiologists. The most important for us are these 4, the parasternal long axis, parasternal short axis, the apical view, and the subcostal view. So let's have a look at them. Parasternal long axis, from its name, it starts, it's number 1 here. You will put your probe on the left side of the sternum and the parasternal line, which is about just 1 or 2 centimeters lateral to the sternum on the left side. And if you are getting a parasternal long axis, your pointer or the marker of the probe should be towards the patient right shoulder. Once you obtain this view and you get a very good view, you rotate your probe 90 degrees. So the marker will point to the left shoulder, and this will get you the short axis. And then you need to move your hand or your probe totally to the second point, which is the nipple or around the nipple line, which is the cardiac apex, in order to get the apical view. Apical view, we have apical 4, apical 5, apical 2. We just need apical 4 chamber, a standard view, to give you the information that you need. Let the other views for the experts or the echocardiographers. We don't need them in the emergency department. After we finish the apical view, which is somehow challenging in the department, really, in the sick patients, most of the apical views need to rotate the patient to the left side, but in the emergency department, it could be a little bit challenging. We then go to the subcostal view. In this view, we can look for the IVC, as Abdul Sadiq highlighted, and we will mention in depth now. The last thing, if you can visualize the lung bases to check if there is any pleural effusion or no. So let's have a look at these different ones. So let's see the slide. This slide will show you what will each view show you. What are the structures are you looking at, and what's the expectation to tell that you have a perfect or adequate view. So let's take them one by one in order not to waste time. This is the parasternal long axis. I think this is one of the main views in the echo, really, because it's very easy. It does not need a lot of positioning of the patient. It gives you most of the information that you need from the first time. So it's very important view to get. Let's see how can we obtain it. We place our probe, as we said, in the second or fourth intercostal spaces. The marker should be looking toward the right shoulder of the patient. And if you notice, I think you can see my pointer all. My pointer or my arrow is showing the pointer that you will read on the screen of the ultrasound. If you put at the ultrasound screen, this is the beam of the ultrasound. And on the right side, you will find the pointer. That means you are on the cardiac setting, and that's you are doing a proper proper echo. If it's on the other side, like other views, that means you have chosen the abdomen settings and you need to reverse it to the cardiac settings, or otherwise you will have to reverse all your probe positions. So rather than the right shoulder will be the left elbow. So don't confuse yourself. Choose the cardiac settings. Make sure that your pointer or the pointer on the left side of the patient or on the right side of the hand screen of the right hand of the screen, and your point marker on the probe toward the right shoulder of the patient. Okay. So what are we looking at here? We can see the right ventricle, left ventricle, aorta, and left atrium, mitral valve, aortic valve. So a lot of information really we can get from this view. What we cannot see is the left ventricular apex. Right ventricular apex can be seen within limitation, but can be seen. And what we cannot see the right atrium at all. So this is like a cut section, shows you the structures and how will it look clinically. And this is the true image of the parasternal long axis. This is the left, definitely the first structure you will see just next to the ultrasound beam with the right ventricle. Okay. Any notice anything? Okay. There is a septum. Next to the septum, the left ventricular cavity, and then the posterior wall of the left ventricle. Then this is the left ventricular outflow tract. After this, the aortic valve, which is aortic valve here, aortic annulus, and the ascending aorta. And next to the aorta is the left atrium. You can see here that there is the pericardium, which is a very wide, tough membrane here. And in order to have an adequate view, I'm sorry, this spectrogram is hiding the descending aorta. You must see the descending aorta at this site. You should see it like a rounded structure. It's passing behind the heart. It's important to see the descending aorta because if there is any pericardial effusion, the aorta will tell you if this pericardial effusion or pleural effusion, and we will see this later. So this is the descending aorta we can see here. Right ventricular outflow tract, right ventricle, we can tell it like crudely like this, aorta and left atrium. What we can notice that the right ventricle and the aorta and the left atrium are within the 1:1:1 ratios. Okay, it's not very accurate because in fact the right ventricle, it has a lot of definitions, but most of the literatures, it's below 2.4 centimeters. If it's below 2 centimeters, that's the normal. 2.6 centimeters is very, very enlarged. Despite the aorta can accommodate up to 3.5, the left atrium up to 4 centimeters, but within the eyeballing, they look all of them within the same parameter, like 1, 1, 1. Left ventricle definitely is the largest structure in this image. So in order to get an adequate view, I must get all those structures. I don't need to see the apex. I don't need to see the right atrium, but I need to see the pericardium and the descending aorta. So if there, in this view, I can see the ejection fraction very well. I can see the dimensions of the right ventricle, the aorta, and the left atrium. I can see the contractility of the heart and the left ventricular outflow tract, the exit. Let's see the next one, which is the parasternal short axis. My advice, try to get the best parasternal long axis view, the one you can see the tips of the mitral valve in, with the longest diameter of the longitudinal diameter of the left ventricle. If you can get this one with the tips of the mitral valve, now you can get your parasternal short axis. Keep your probe in the same position. Don't move the probe. Just twist the probe clockwise. Yes, it's clockwise. So your probe pointer will, or the marker will point toward the left shoulder. Okay. Parasternal short axis. Now we are cutting the heart in sections, like we can see in this one. This is the position. We are cutting the heart on 3 levels on a transverse section. Okay. So the first point we can see, or the lowest one, is that we call it the papillary muscle view. You know that there are papillary muscles here, which are like 2 shoulders. And you can see the ventricular cavity here. Mostly you can see only the left ventricle. This is one of the best views that will show you the regional wall motion abnormalities, especially the septal, the lateral wall of the heart, and the posterior wall of the heart. Also, it will give you an idea about the ejection fraction, because if you can put your finger in the middle of the screen here, you must see all the walls approaching together. And you can determine if it's really contracting well or not contracting well. And as I mentioned, most of our assessment in E&E is by eyeballing. We don't need to take Simpson methods. We don't need to take cut sections and do M mode and calculate the end ventricular, the diastolic dimension over the end ventricular systolic dimensions. No, we are looking for the eyeballing. Okay, so we start with this one. Mostly when you get this view, you are very close to the cardiac apex. And by the way, you can get the cardiac apex from the parasternal short axis if you fan the probe away from the heart toward the apex. Then this is the papillary muscle view, but this is a little bit proximal toward the mitral valve. In all the parasternal short axis, mostly the probe is fixed in place. It does not move. We will just swing it apically or basally toward the apex of the heart or toward the base of the heart. Why do we do this papillary muscle view? Because starting from here, you can start to see the right ventricle. And the right ventricle here is very important, because if you're looking for massive pulmonary embolism, right ventricular dilatation, especially if you're looking for the D sign, which is flattened septum or paradoxical septal movement, this is the best view to look for. If you swing or just flap your probe, which is in the same place, again toward the base of the heart, mean toward the head of the patient, you will start to see the mitral valve. And we call this view the fish mouth view. It's like a fish looking at you and opening its mouth. So this is the fish mouth view. And the fish mouth view, you can see the E-point septal separations. If you're expert in this, you can see the left ventricular outflow tract. Still, you can see the right ventricle and the septum. So this is the fish mouth view, and this is the mitral valve. This is the very circular appearance of the left ventricle, and that's a normal ventricle. If there is any wall motion abnormality, mostly it will not be that clear and very straightforward circular like this. Yeah, it will be remodeled ventricle, and the remodeling mostly affects the shape of the ventricle. Then at the last station, let's go again. So I'm sorry, I'll go back to remind you. We start to cut here at the level of the close to the apex. We got this one, which is the papillary muscle view at the shoulders. And this is papillary muscle view again. Then we just swing the probe toward the head of the patient in its place. So we will move the probe, or we tilt the probe toward the base of the heart, toward the aorta. So the first structure after the papillary muscle will be the mitral valve, which is the fish mouth view. Then after fish mouth view, if I did another tilt, most of the time by experiences, I did not manage most of the time to get it in the same view. Sometimes I have to move one space a little bit back, but by the time all of us will be able to do it. You should get this Mercedes-Benz sign, which is the aortic valve. The aortic valve view is very important, really, because in this view, you can see the right ventricular outflow tract. You can start seeing the right atrium. Any dilatation in the RV or the atrium will be apparent here. Another thing, if you have old patients coming with syncope looking for bicuspid aortic valve, this is the best view that you can look for bicuspid aortic valve in. Sometimes it's a little bit challenging, yes, with COPD patients, with hyperinflation, like all the echo patients, but most of the time it's obtainable. And this is very perfect aortic valve view. So this is the parasternal short. It's a very important view, as I told you. You can check for the regional wall motion abnormalities and the ejection fraction. So next is the very popular one, the apical view. Apical view is very popular because you can see the anatomy of the heart just in front of you, really, and it gives you a way to map the heart. It gives you better dimensions, and if you are more expert, you can do the Doppler studies in this view. The ideal, in order to do any M mode study, it needs to be perpendicular. So the best for the M mode is the parasternal long axis. But in order to do any Doppler study, including the color flow, better or the best is to do it through the apical view, because now your beam is parallel to the axis of the heart. So any flow of the Doppler checks only the flow of the fluid. So any flow of the blood within the axis or against the direction will be detected easily by Doppler. So that's why apical is very, very important view. For us as an A&E, as I told you, sometimes it's very challenging, especially if the patients are short of breath, ventilated, unable to mobilize, because the trick in this view is to let the patient lie on their left lateral side. Ask them to put their left hand under their heads and rotate to the left side totally. Then you will throw the heart toward the chest wall. You minimize the air interface between, if there is any lung point is covering the heart. Now you get the best apical view. How to get the view? Just you position your probe at the cardiac apex, which is around the 5th or the 6th intercostal space, lateral to the mid-clavicular line. Easier to start from the anterior axillary line and try to sweep medially until you get the parasternal apical view. And by the way, all the views of the heart, all the views of the echo, the pointer will point to the left shoulder except parasternal long axis. So if I tell you the subcostal, yeah, your pointer will be to the left shoulder. Apical, pointer to the left shoulder. Parasternal short axis as well will be the pointer or the marker on the probe to the left shoulder if you have chosen the cardiac setting on the machine. Okay, so try to put it on the apex. Try to go infra and lateral to the apex a little in order to get the left ventricle and right ventricle apex within the same view. If, as I told you, if it's very difficult, yeah, try to ask the patient to lean toward the left side and it will be easier. You can get apical 2 or something. Apical 2 is another modification that will allow you to get the anterior and inferior walls of the heart. And I don't think this is very, very important in our scope. Apical 5 will get you the outlet of the aorta, will open the aortic valve. You can check all the aortic parameters through the apical 5. And as I told you, for us as emergency physicians, most important, the apical 4. So this is the anatomy, and this, what will you see? You will see the left ventricle, right ventricle, a septum in between them, lateral wall of the heart, left atrium and intra-atrial septum, right atrium, tricuspid valve, mitral valve. So you can see that a lot of information you can get from this view. as I mentioned, just because apical 2 is people are talking about now, but I don't like to do it because we are not looking to the this scope. So this is how we mentioned how we can get it. Try to put the pointer to the left shoulder of the patient. Ask the patient to lie to the left lateral. And structures to be seen: the right and left ventricles, the interventricular septum and interatrial septum, both atria, left ventricular apex, mitral valve, and tricuspid valve. Now we move to the last one, which is the subcostal of the subxiphoid view, which is one of the important plan B views for you, really, because you deal with a lot of respiratory patients now, mechanically ventilated patients. Any hyperinflated chest, believe me, if you are the supreme echocardiographer, it will be very challenging. So your exit or the backup plan is just go for the subcostal, because most of the COPD patients, they have a hyperinflated chest. So the heart would be pushed down toward the abdominal cavity. So you can catch the heart down and get it from the subxiphoid. And if you look at the subxiphoid, it gives you a very, very nice image of the heart. It gives you the right ventricle. Definitely you are looking now, the probe is looking toward the base of the heart from down. So the first structure will be the right ventricle and the right atrium just proximal to it. And next to the right ventricle, the left ventricle and the left atrium. You can, even if the patient is very cooperative or the view is very good, you can see the aortic outlet or left ventricular outflow. And as we mentioned, all the views of the heart, apart from parasternal long axis, the pointer or the marker will be toward the left shoulder of the patient. Some tricks in order to get this view: ask the patient to take a deep breath, definitely. A second thing is ask them to bend their knees, because once they bend their knees up, they will relax their tummy. The muscles of the abdomen will be relaxed and they can tolerate your pressure. Try to go not 45 or 90 degrees. You are going like 30, like tangential to the skin, but pointing toward the chest cavity. And the most important in getting this view, to get a liver window. You must get a window, because now you are accessing the heart in a place there is air, okay, and there is gut and stomachs and a lot of things you will not see except if you have a window. And your friend here is the liver. If you have the liver window, you will see the heart. If you cannot get the liver window, you will not see the heart. Put the screen to the maximum depth. Some screens have 20, 25. Mostly our ideal screens get 18. Get until the maximum depth and then adjust the screen or adjust the depth until to get the heart on the middle of the screen. This is in all the ultrasound things. Get the most deep thing and then you adjust to keep your structure in the middle of the screen, because this is the site of the best resolution. And as I told you, it's the right ventricle, right atrium, left atrium and left ventricle. And the most important, as Ahmed highlighted in his session, the pericardium. If there is minimal amount of fluid, will appear here as pericardial effusion. And I believe there is very minimal pericardial effusion here. As we mentioned, the probe position. And in order, this is, I told you the probe will be looking toward the left shoulder. In order to get the IVC, like Ahmed said, this is the cardiac probe and the echo settings. So you can see that your pointer to the right-hand side of the screen. Now rotate your probe around 90 degrees or like 80 degrees toward the right shoulder, anti-clockwise. And this you will see a very nice image of the IVC. And IVC assessment, guys, is a dynamic process. It's not just you look at the IVC, you see it's dilated. You must watch it well, see it across the respiration, what's related to the breathing, how is it related to the leg elevation, how is it related to the IV bolus. So you need to get a good image of the IVC. We measure the IVC, so a lot of texts talk about measuring just proximal to the hepatic vein, which is joining here, just distal to the hepatic vein, like Ahmed said, from 2 to 3 centimeters of joining the atrium, which is this point. And this is the measurement. Now we will see a video. Hopefully it works well for the normal views. This is not my video really, because I didn't prepare one like this, but these are how normal views look. This is, as you can see, the parasternal long axis. Okay, this is the mitral valve. okay? And this is the septum, and this is the posterior wall of the heart. My point now is that you, in order to see is it having a good ejection fraction or no, look at the contractility by your eye. You see that both walls are approaching and thickening well and then dilating well. I'll go again, sorry, because I need to show something. Focus with the mitral valve. The mitral valve is nearly hitting the septum in the diastole. This is called the E-point septal separation. This is very important in determining the ejection fraction. I can tell this view is not adequate because we cannot see the descending aorta. This is the parasternal short at the level of the papillary muscles. Even this is the higher papillary muscle, so you can see the right ventricle here, and this is the left ventricle, rounded and approaching well. I see the contractility is doing very well. And this is the the apical fourth chamber. This is the left ventricle, left atrium, and this is the mitral valve, right atrium, right ventricle. And you see that how the walls are approaching to each other. This is the normal contractility, guys. This is apical 2. This is the inferior wall of the heart. This is the anterior wall of the heart. So I think now I finished the illustration of the views. We'll go for the quizzes directly. This is one of our cases. I was in the recess in Lincoln, and I saw this gentleman, 61 years old male. He has no medical history. He had a syncope and he came hypotensive. He had no chest pain, no shortness of breath. Systolic blood pressure is 80 and pulse is 100 and auto saturation 94 on room air. And clinically, he has no signs of heart failure, but he is hypotensive on the lower side. What's your next step in recess? Definitely, because it's an echo presentation, we will do echo, I know. So these are the findings. And as I told you, starting from here, all those are our videos and our true patients. What we can see here, this is the septum. This is parasternal long axis, the pointer on the right side. So this is a cardiac setting. Parasternal long axis. So our first, let me go back a little bit. You see this is the right ventricle, and this is the left ventricle. If you notice, the right ventricle should be less than the left ventricle, and as Ahmed said, should be 1/3 at least, 1/3 to 2/3. So this 1/3 is 2/3. So this right ventricle bigger than the left ventricle. And the septum, from all the physiology, we know that the septum tends to move towards the right ventricle, not the left ventricle. Now we call this the paradoxical septal movement. Now I switch to the parasternal short axis. I can see the whole contractility of the heart. It's very rounded and nice. But how is the septum behaving? Just look at this right ventricle. It's way dilated. Even it's out of the scope of the ultrasound. This is the right ventricle. Look at the septum and how is it behaving? Let's go a little bit back. It's pushed toward the left ventricle and it's causing what we call the D sign, D septum. D septum means that there is a paradoxical septal movement toward the left ventricle, and this is one of the signs of the right ventricular strain. Definitely, we put everything in a clinical context. Patient with no medical history, he does not have any respiratory history before, and came with a D-shaped septum with a syncope. So it's, for us, it's a PE until proved otherwise. The patient was thrombolized in recess and he had a very good outcome. So in fast, what are the RV strain signs to suggest massive BE? RV dilatation, and as I told you, it's very variable, but the upper limit is 23 millimeter. If it's cross 2.6 centimeter, mean the RV is dilated. There is McConnell sign, which is very specific for the PE. It will differentiate between the right side or the inferior MI and the massive BE, which is the akinetic RV apex. Akinetic, the free wall of the right ventricle will not move, but the apex will be moving very hyperkinetically. I don't have an image for that, I'm sorry. And any tricuspid regurg and paradoxical septal motion, like we mentioned, the D-shaped septum in parasternal short axis or the apical view. And this case number 2. This is an 80-plus-year-old lady came by the ambulance. She has a shortness of breath and she had the chest infection. She was treated with antibiotics. She's not improving. And she was admitted 6 weeks ago and came again to our department. She is not known cardiac or COPD. So next, definitely we'll do an echo. Let's see our echo. This is the bedside lung ultrasound. And it shows that you have B lines. Definitely, I don't call those P lines until you get the, like Dr. Ammar mentioned, yeah, we need at least 18 centimeters or until the end of the screen. So you need to get the abdominal probe or the cardiac probe. But you see how her heart is behaving. This is the parasternal short axis. And you can remember how was it previously. Now look at the parasternal long axis. Look at the mitral valve here and the septum. And you can give your opinion. Is it touching or coming close to it or no? It does not even reach halfway between the septum and the posterior wall, the ventricular cavity. This is a septal thickening. It's not HOCM, yeah, but it's noticed a lot in old people. It's not very specific that we have left ventricular outflow septal thickening, and this is non-specific sign. But my point, the mitral valve not reaching even halfway, and you look at the walls of the heart, barely moving. So there is a big difference between the image we see now and the image that you have seen. This is the thickening I'm telling you about. This is the septum and the lateral wall. The ventricle looks dilated. Yeah, it should be below 6 centimeters, but we're not measuring. It looks dilated, and they are not, the walls are not approaching to each other at all. It looks like this is a weak heart. With the P lines and pulmonary edema picture, and this is a very good illustration. This video was done by Dr. Abdul Sadiq. It's very good. You see how the IVC is dilated, distended, does not go with breathing, is not even collapsing. The collapsibility should be at least 50% with a deep inspiration. Now with deep inspiration or with the maximum breathing of the patient is not dynamic at all. So this is the systolic heart failure in echo. So dilated left ventricle, and it's not necessarily. So many patients, especially if they have hypertensive cardiomyopathy or something, they will not have a dilated left ventricle. But any left ventricle more than 6 centimeters, that's definitely pathologic. Also, a second sign, which is reduced contractility, motion of the walls of the ventricle by eyeballing. You will notice they are not moving towards each other, they are not approaching each other. And the walls do not thicken at all. They keep the same thickness through diastole and systole. And this is one of the signs of that failure. E-point septal separation, which is, I told you that the mitral leaflet should come approach the septum. It has some calculation because actually the EPSS should be calculated through the M mode, not the P mode, but just in eyeballing, if you see the mitral valve not reaching the septum, yeah, that's one of the signs of the reduced ejection fraction and the P lines. Case number 3, and this is actual case. I've seen him about 2 months ago, 45 years old male. He's a very tough guy. Obese. He came with the 1-day history of shortness of breath. Saturation is 88, I think. He had central chest pain a day before presentation. I did not seek any help on presentation. He came, had acute heart failure. He has crackles, systolic blood pressure 85, sats 80s, pulse 80, something like this. So it looks like acute heart failure. Trops are 450 and GFR is 30. So this patient is an acute renal failure now, acute heart failure. So if you are planning to any image, is a challenging thing. Let's see how was his echo, bedside echo. It's not the best image. Patient is obese, difficulty breathing. What can you see from this image? It was challenging for me and shocking because I didn't expect this. I'm looking for dilated LV. I'm looking for dilated RV. This is the RV. This is the aorta, and this is the LA. That's, remember the ratio we said 1 to 1 to 1. This is the RV. It's about 2 centimeters. This is the LA, very small, and all this is the aorta. Let's focus on this white structure inside the aortic root. So with this very low ejection fraction and low GFR, acute renal failure, This aorta measured 8 centimeters. So we planned to do a CT aortogram, and it was a high risk procedure because of the renal failure. And it came with a dissection starting from the root of the aorta till the bifurcation. And this patient passed away in the OR in Glenfield Hospital after 1 day because he came very late, really, and the dissection has had an already evolved the aortic annulus and got the carotid sinus. So I think it was like end stage, but we should not miss this one. My point in this, we do not diagnose aortic dissection with the transthoracic echo at all. I don't say do the echo if it's normal, it's not dissection. No, at all. It has nothing to do with the dissection, but we should not miss it if we saw it. If you find the aortic dimension out of the proportion you're expecting, you are telling maximum it's 4 centimeters. If you find it 8 centimeters, don't disregard it. No, take the finding that you can see as granted because you saw something with your eye. So my message again, we don't rule out dissection with echo, transthoracic. Definitely we do with the transesophageal, but if you saw it like this one, please don't disregard it, investigate it well. This is a proper dissection flap here, very dilated aortic root, 8 centimeters. I think now I'm finished with my cases. Last one, case 4. 45 years old with shortness of breath, came shocked, systolic 70. This is a very, very interesting case. I saw really, I was in Qatar at the time. That came after 16-hour flight from USA. He had pancreatic cancer, and he received chemotherapy and radiotherapy for 3 months. He came shocked, really. Systolic blood pressure 70, heart rate 145, regular pulsation. Autosat was 79 on room air. So what will be your first thing? The third thing, this discussion is not interactive yet, but I think it would be very interesting because my first thought is to prepare the altiplase. It looks like massive BE coming from 16-hour flight with cancer pancreas but never thrombolyzed without an echo. Look at the image. This is a true patient. You can see my name up. He had massive BE, pericardial effusion. And this massive, they drained 1.6 liters from this heart. Massive pericardial effusion with right ventricular collapse, okay? And right atrial systolic collapse. So the diastolic and systolic in the atrium and ventricle are reversed. These are the signs of the tamponade. He had pericardial tamponade. Let's see that his apical view, how the ventricle is collapsing and even not standing. And you can see other sign of the tamponade is the swinging heart. You see the heart is swinging around its axis. This is one of the signs of the tamponade. So before you take any decision in the bedside, you have now a blessing called the echo. Do echo for any thrombolysis or planning to thrombolyze any patients. I'm sorry, I'm going very fast because I'm out of time now. So signs of tamponade are the diastolic collapse of the RV and RA and RV as well. You see them in the M mode. Swinging heart, not singing, I'm sorry, that's the typo, it's swinging. Diminished transmitral flow by the Doppler pulse wave, more than 25%. If we go to the apical view, I told you the best Doppler view is the apical. We put the Doppler around the transmitral area to check the transmitral flow. As the patient take a deep breath, if they are cooperative enough, if it drops by more than 25%, that's signs of the tamponade. Another one is the IV plethora. IVC plethora means it's failure to collapse more than 50% on deep inspiration, the IVC on the subcostal assessment. These are my cases, but the quiz for today. But even I'll show you some cases that you can reach a diagnosis from just doing an echo, which is a very solid diagnosis. It will help the other specialties if you are doing it. And it's a very simple machine. Let's have a look at this gentleman. He came with right loin pain. I'm sorry, this came with a fever. And you can see the heart. What we can see here is the pericardial effusion. Okay, that's very straightforward thing. But no, look at the effusion. How is it? This is parasternal short. This is posterior effusion. It looks like there is some loculations inside, and there are septa inside here. So this is a loculated pericardial effusion with a lot of septations in between the parietal and the visceral pericardium. It's not just a simple pericardial effusion. He's not tamponading. This patient was taken to the OR without any other investigation, and it shows to have TB pericarditis.
IVC thrombosis.
This gentleman came with right loin pain, severe right loin pain, but he has short of breath. So I was assessing his IVC, and we track it distally close to the liver here on the right kidney. You can see the big thrombus like a snake inside the IVC. He had an RVT, which is renal vein thrombosis from the right kidney, which extended towards, even you see the transverse section of the IVC, it's not collapsible at all, and there is an obvious thrombus. If you go to the longitudinal again, I think it will open now, you can see the thrombus residing inside the IVC. Okay, so what does the literature tell us about the echo? I will not go in deep in this because Ahmed will take care of the echo in the life support, so I will not discuss most of those. But the most of the literature now that any cardiac arrest scenario, any life support scenario, you must have a bedside echo at least. You must have a look what's happening inside the heart. Even in the cardiac arrest, even now in the pre-hospital settings, now all of us know that the current renovations in the technology, you can get your butterfly echo probe with yourself. It's a little bit expensive, but you can have it. You can do all your procedures and everything like Professor Moore has highlighted. Every procedure now should be done ultrasound guided as long as this is accessible. Even the LP lumbar puncture, we do it with ultrasound help, not guidance. I know it's not in-plane, but you can do it with the ultrasound. So it's some tips just to get a good view for the echo. One last slide, get a lot of jelly, because you know the aqueous material of the jelly would help transducer or to transmit the ultrasound waves across the chest wall. You need to do some pressure, but please be courteous to your patient. Warn them, tell them that it will be some pressure. If they feel any pain, you should abort your procedure unless it's life-saving. Try to get your window. Most of the time, you will not just put the probe, it will come. No. If I told you parasternal long axis from 2 to 4, that means you start to 2 and then go to the 3rd intercostal, then go to the 4th intercostal, move towards the sternum a little bit, move away from the sternum a little bit until you get the best view. And the position lateral decubitus is your friend. Anytime you are unable to get the apical view, especially, yes, ask the patient to tilt toward the left side, and then it will be easier for the probe to be, or the heart to be picked by your ultrasound beam. So prepare, explain to your patients, prepare your machine, get the settings of the heart and or the cardiac examination. After the scan, definitely like any ultrasound, just clean the machine, save your images, and explain everything to the patients if you have any findings, and assure them if there are no significant findings. I think now I have reached the end of my presentations. If there is any question, Muhammad, we can highlight it now. Hello, Muhammad, Talat.
Assalamu alaikum wa rahmatullah. Thank you so much, Dr. Mahmoud, for the informative lecture. I received a couple of questions. Let me tell you about. One of the question was about diagnosis of aortic dissection by echo.
Yes, okay, that's a good question. I think I mentioned it also in the lecture because I need to stress on this point. You have a big hidden part of the aorta behind the thoracic cavity, which is the arch of the aorta and the descending aorta. You can see the arch of the aorta by the suprasternal view, but the suprasternal view, it needs expertise. You need to see it a lot of time before to take a decision with it, and needs a patient who is cooperative enough to sit up in the bed and they put their head in the position, and then you put the probe in the suprasternal and you try to interpret it. So as I told, it's not for diagnosis of aortic dissection, but if you saw a finding that goes with aortic dissection, we should not ignore it.
Okay, thank you so much. Thank you. I believe that the other question was answered during the lecture, and
Yes.
the one who asked said it's okay now. Thank you. Now with Dr. Ahmed Ala. Dr. Ahmed is a consultant of emergency medicine in Lincolnshire Trust. He is also a fellowship of the Emergency Board of Medicine and also the Royal College of Emergency Medicine. And he is an instructor in ATLS, ACLS, and ultrasound level 1 as well. Dr. Ahmed, the floor is yours.
So hello everybody. Assalamu alaikum. It's my honor actually to be between you here in this nice presentations. I even like the last presentation. It was very nice. Thank you, Saka, and it makes my life easy because it went through the echo and basics of the echo that I will going on to continue in this lecture. I'm just going to share my screen here.
Dr. Ahmed, minimize Zoom first, then open the presentation. Minimize Zoom, then open the presentation.
I'm doing it.
There is a button down there is share screen, green one.
Yeah. I think it's from the privacy. Just a moment, please. So it's there, isn't it?
Yeah, it's okay, Doctor.
It is
okay. Sorry for that. It's just the technology which happened. So today we'll speak about the ultrasound and cardiac arrest. So since morning we are dealing with a patient and we are trying to avoid this moment when we are going for the cardiac arrest. We are trying to solve the problem and protect our patient from being in this situation. However, it could happen, and that's why we need to know how to deal with it and how the ultrasound will help us in the cardiac arrest. During cardiac arrest, so you feel like you are in a dark room, and when you are in a dark room, you just need source of light to make your life easy, to find ways of obstacle, and to help you to find the appropriate management for this patient. And I think echo can help us. Ultrasound probe is the torch that you can use during cardiac arrest to help you in finding what's going on, if there's any reversible cause, what's the management plan that you need in the next few minutes. So use of echocardiography in arrest and peri-arrest situation. So let's speak, what can an echo exam in cardiac arrest achieve, and how long does it take to train people to use echo while they are doing this, the cardiac arrest situations or scenarios or in the real life? Where does it fit in the ALS algorithm? and re-evaluating of PEA definition after having an echo. How you imagine the B&E, it will be a bit different because of the pulseless bicentral. By checking the central pulse is totally different than how you can check while looking to the heart. We need to find the cause, definitely, especially if it's a reversible cause, and we will deal with it. And when do we terminate CPR? What can an echo exam in cardiac arrest achieve? So identifies the cause. So treatable versus non-treatable cause can rapidly change our management as well. So during the cardiac arrest situation, you need some equipment to help you, to tell you what is the management that we need in the next few minutes to help the patient to regain spontaneous circulation. Assess PEA is a patient truly pulseless. So yes, this is what we will speak about today, and early detection of myocardial activity and return of spontaneous circulation. How long does it take to train? Is it something difficult to have this skill? So a recent study suggested that web-based learning followed by an intensive 3 hours training period result in reliable echo-guided life support skills in emergency physician. Emergency physician who had been trained to use focused echo in 50 advanced life support scenarios have been shown to gain adequate view in 94% of cases. Most importantly, 90% gained this within the 10-second pulse check window. This is what we need to aim from the training, that you have just 10 seconds to check pulse, but at the same time, we are using this 10 seconds to find if there is any reversible cause and what's going on during the cardiac arrest situation. How to use the echo in the ALS algorithm? So actually, it's the 10 seconds. So because of that, once the heart, the chest compression is going, it's difficult to go and assess because the view will not be stable enough to find any data, gain any data from it. So we're going to wait until the 2 minutes finished and prepare our probe as we prepare our hands to check the central pulse. But the central pulse is very sensitive and specific. Pulse check centrally, so with a sensitivity of 86% and specificity of between 55 and 64%. And so we need something to help us in there. And it goes to how we are going to scan. So usually we use the phased array transducer. So usually we use the phased array transducer with a good subxiphoid view should be with good subxiphoid view should be obtained plus one other cardiac view. Know that from the day and from the last lecture, so we know what is the views, and I think every one of us, we are using ultrasound, so you know how to get the cardiac views. So what the subxiphoid plus one more, and together with an assessment of IVC would be enough to give you an idea about what's going on. To gain a good subxiphoid view, this is required increase the machine depth to around 20 centimeter and holding the transducer almost flat, like here in this picture. So we need to hold it as flat, it's anterior organ, and putting it perpendicular, you will not have the good views that you aim to. And holding the transducer almost flat against the epigastrium. Pulse electrical activity. So focused echocardiography can be used to predict the likelihood of successful return of spontaneous circulation. So we are aiming to differentiate between the true and pseudo BAA, and we'll find that now. So true pulseless electrical activity is when coordinated electrical activity is seen on the cardiac monitor, but there is no cardiac movement on echocardiography. We're looking here to the screen on the video on the left side. So there is no coordinating, there is no cardiac movement on echocardiography. However, if you can say that on the cardiac monitor that there's electrical activity, this is true pulseless electric activity. The pseudo one is coordinated electrical activity. There is no palpable pulse. However, there is cardiac activity on echocardiography, like we can see on the right side. The absence of coordinated cardiac activity proves to be an excellent predictor for failure to regain spontaneous circulation, but with negative predictive value of 97%. So there is differentiation between that you cannot feel the pulse and there is no pulse. And while using the ultrasound probe during cardiac arrest, you can have this idea what's going on. Is it true or pseudo pulseless electric activity? So pseudo PAA, there is no palpable pulse. There is semi-organized electric activity on monitor. However, there is organized cardiac activity on echo. We're going now to causes of cardiorespiratory arrest. So we all know 4Hs and 4Ts. So hypoxia, hypothermia, hyperkalemia, hypovolemia, and 4Ts of tamponade, tension pneumothorax thrombosis, and toxins. Let us see how we are going to tackle some of them with using the ultrasound probe during cardiac arrest in the 10 seconds assessment of the pulse and using the probe in. The first one is hypovolemia. And this is, I know that all the day we're going through lectures about how to check the IVC, you know, in WASH protocol, this was presented there. But let us to look here. So we need to differentiate, is it hypovolemic or it's normal, or it's overloaded. So looking to the left ventricle size and function. So if the left ventricle is small in size, hyperkinetic with end-systolic cavity obliteration, that means that it's hypovolemic. IVC as well. When looking to the IVC, we look to the two different parameters there, and we are looking to a point around 2 centimeters distal to the atriocaval junction, and we are looking to the size and collapsibility. So it's eyeball as well. I know that in emergency department, we're not going to check the index and count how many millimeter and how many, is it 50, 55, 40 plus, but with your eyeball, if it's the IVC is more than 2 centimeters and the collapsibility it's less than 50%, that means that it could be non-fluid response. I mean that this is overloaded. If less than 1 centimeter IVC diameter with more than 50% of the collapsibility, that means that this patient is probably fluid response, I mean hypovolemic. So this is how easy to assess if the patient is hypovolemic or not. The next question, if you got a patient with hypovolemia, so we need to go through why he is hypovolemic. Is it trauma related and this internal bleeding? Is the patient is dehydrated? Why is this hypovolemic? This is the next question that we need to answer. Going to the next one with the cardiac tamponade. So we all know that tamponade is a clinical diagnosis, definitely. But if your patient in cardiorespiratory arrest and you see the following feature, so we should think about tamponade, which is right atrium collapse, right ventricle collapse, IVC dilatation, swinging of the heart, if you can see it. So we're looking here, but what is the best views? So definitely subcostal views is one of the best views because it's good for cardiac arrest. So you are away from the scene. People, if you're using Lucas or a chest compression, so you are a bit down there, so you can prepare yourself even before the 10 seconds. And at the same time, you can assess the IVC. So the pasternal long axis one, sorry, is the float pericardial or pleural? So this is, sorry for that. So if we're looking here, this is the subcostal views, and as we have mentioned, so it's very good in cardiac arrest situations. And at the same time, if you just move the probe just 90 degrees, so you can assess the IVC. In the parasternal one, so because of the descending aorta here, it would be easy to differentiate between the pericardial effusion if it's above the descending aorta, if the fluid is down there, so it's a pleural one. But the question is, how much fluid matters? Is it the size of the road, or I think it's more about how quickly the fluid builds up. So rather than the absolute volume of the fluid. So if the fluid builds up very quickly, patient can go to tamponade because there's no compensation. So correlate what you are looking on an echo with the patient clinical and hemodynamic status. And this is what we usually do while using the bedside ultrasounds. For thrombosis, I know that Saka went through the multiple cases of PE, but sensitivity of echo for detecting PEs of any severity is approximately 6%. However, if your patient is unstable and absence of echo evidence for right ventricular overload dysfunction, so can exclude PE. So you need to find something else, especially patient cardiac arrest that should appear there. The signs that we can see on echo, if we are looking to the parasternal lung axis, so it's increase on the right ventricular diameter more than 3 centimeters. If we are going to the apical for Champer view, so increase in area of right ventricle as compared to the left ventricle. What I'm speak about the RV-LV ratio. So it's correlate with the pulmonary artery pressure, and the normal should be around 0.5. Ratio above 1, that means that the right ventricle is bigger than or equal the left ventricle. So if it happens that you find that the right ventricle is equal or more, this is associated with adverse clinical outcome, and this is the right ventricular strain. McConnell's sign is defined as right ventricular, down there, is defined as the right ventricular free wall akinesis with a sparing of the apex. This look as if the apex of the right ventricle looks like trampoline, bouncing up and down, while the rest of the right ventricle remains still. And this finding is not sensitive, but in a small study was specific for an acute PE. For the parasternal short axis view, T-shaped septum and paradoxical movement, this is one of the signs that we are looking for and what give us clue what's going on in the cardiac arrest scenarios or situation. For thrombosis and from the cardiac issue of thrombosis, so if everyone can diagnose the stymie, non-stymie, so looking to ECG give you good idea, but during cardiac arrest scenarios, so as long as you don't have ECG, so we're looking to the how is the movement? Is it normal pumping? It's hypo. Is it normal? I mean that the movement of the left ventricle. Looking to the blue color here, because this one is reflecting the LAT, the pattern of the LAT of the anterolateral. So if there's hypokinesia that you can find there, and actually hypokinesia and normokinetic, it's around peri-arrest or post-arrest. But if you have situation like that, and you can detect that there's hypokinesia around the palpitation of the heart, that it's relating to one of the coronaries, that will give you a good idea that there's something going on with the coronaries, and this patient needs PCR. So looking to the difference between the norma and the hypokinetic one, this is it's eyeball issue. So we're not going to do any measurement while we are doing in this situation. But if it's not moving like normal one, and you have the situation that you are suspecting that cardiac problem and problem with the coronaries, so we need to tackle it. So going with the tension pneumothorax, I know that it was a big lecture in the morning regarding lungs, so I will not go in details with that. I know that all of you now mastering how to detect the pneumothorax, and usually we use it with the linear tool, try to find the sliding of the lungs, and on the right side here on the M mode, so we can differentiate between the seashore and the barcode sign, which helps to tell you if the patient have tension pneumothorax or it's another cause of cardiac arrest. When do we stop CPR? And I try to find this is a systematic review that I can find here. It's a bit old, but it gives us idea about that echo that done during cardiac arrest that demonstrate an absence of cardiac activity, indicates significant lower, but it's not zero likelihood that a patient will experience FOSC. However, I think nowadays machines are much. This has have been done 2012, and I couldn't find any updated one. But nowadays machines are much better, and physicians became more expert. So it could be a bit different regarding the detection of how is the likelihood of FOSC if you cannot find any bumping issue with the heart. So going to the echo guided life support. So what I was starting with, is there pneumothorax? So I know that we are going quickly through that. So starting with, is there any B lines or is there any lung sliding? If yes, so you know what to do. So drain, or if tension pneumothorax, you need to tackle that with a needle. But what I'm speaking about, if you cannot find the pneumothorax, we are going to the next one, which is it tamponade, and easy to find it by if there's any pericardial effusion, how is the right atrium and right ventricle, they're collapsing, how is the IVC? If yes, we are going to tap. If no, so we'll go to is the patient is hypovolemic, and we know how to check hypovolemia now. So dynamic left ventricle function. So how is the left ventricle walls are kissing each other, and how is the IVC? Is it collapsing and less than 1 centimeter? If we are going to the direction that hypovolemia, so now we need to consider the hypovolemia as a cause and try to treat it and find what's the cause behind it. If no, so we're going, if the problem is that poor left ventricle function, and we can detect that easily by the association with the B lines on the lungs. I know that we have discussed that in the lung problem in the morning today, and it's plethoric IVC without respiratory variation. So if yes, so this is the problem now. So the patient needs inotropes, and what is the next step after? Is it treatable one, or it will not be treatable? If no, so we're going to is there any right ventricular strain, which is dilated right ventricle? Is there any D shape? Is there any paradoxical septal wall? I mean that in the short axis view. If yes, so we're going that could be a massive pulmonary embolism, and we need to deal with. The future is transesophageal echo, and I can find multiple studies about that, and it has a lot of advantage. And there's some side effects, but it's rare ones. And the advantage that we could find is that transducer used in the transesophageal echo is inserted into the esophagus and allows for visualization of blood clots in the pulmonary arteries, so we can find the aortic dissections and cardiac tamponade. Definitely, you are not interrupting anyone, so you are away from the scene, and you can find very clear views because it's just a few centimeters from the heart. So transesophageal echo permits the optimization of the real-time chest compression. So because you are not waiting for the 10 seconds to have a look to the heart, it's just going with the real time. So you can even optimize it according to the anatomy. For example, you know that there's some studies, radiological studies, have found that the left ventricular outflow tract, aortic root and aortic valve, are located beneath the center of the sternum and it's down to the center of the sternum. This is the side that we are bracing over in 50% of patients. Therefore, if you're having this transesophageal echo views while you are doing it, so you will do some modification. You ask them to just move to the right side away from the outflow, and you will optimize the cerebral perfusion by doing that. It will not be a blindly chest compression. You can even measure. So all the time they are telling that it's 3 to 5 centimeters. Who is good to count 3 to 5 centimeters every time? But you can do it while you are using the transesophageal echo just to check the measurement of the compression of the sternum. It's a real-time optimization of the resuscitation. Transesophageal echo also be used during post-arrest care for procedure guidance, including extracorporeal life support and placement of temporary pacemaker. Any questions?
Dr. Ahmed, thank you so much for the presentation. I think one of the attendees is asking a question in the Q&A. Can you see it? I can read for you if you can't reach it.
No, I just reached it. So presentation, kindly, I want to ask within the first 10 seconds how many HNTs you can detect. So what is your recommendation to the first view of the probe to detect which important reversible cause you can search first? So the first one, usually I use the subcostal one, and subcostal one will give you like 2 or 3 together. So you will have a look for the bumping of the heart if it's a peri-arrest, but at the same time you will have a look to if there is any pericardiac fluid. And if you just move just 5 seconds to check the pericardial effusion, if you move it, you will find the IVC, and it will give you like 3 information in 10 seconds. I know that as long as you are improving your skills, the practice as well, it will give you the chance to have multiple look at the same time. Sometimes you will not gain some information from the first time. So there's some patient with difficult views, but if you prepared yourself well, so if you prepared your probe, if you are waiting, if someone is counting, so 5, 4, 3, 2, 1, and put your probe, and you know what you are looking for. And now this time I'm looking for any pericardial effusion, and I'm looking to the IVC. So you can get more than one in one look, but definitely it will be the first one, subcostal, easier, and it gives some more information if you can get it.
Thank you so much. I guess no more questions. Thank you so much.
Thank you very much. Thank you, and have a nice day.
You can stop sharing, Dr. Ahmed, now. And
I just want to, the take-home message is prepare your ultrasound machine before your next patient comes. And thank you very much.
Thank you so much, Dr. Ahmed. You can stop sharing now. And we are going to have 10 minutes break. Then we are going to start again with Dr. Osama Kintab lecture, inshallah. Thank you so much.
Thank you.
Assalamu alaikum wa rahmatullah. Welcome back with the second session of the symposium. It will be about pediatric emergency medicine. And it's our honor to start with Dr. Osama Kintab. Dr. Osama Kintab is a senior consultant of emergency medicine, and he is the chairperson of the emergency department of the Princess Noura University in Riyadh. Dr. Osama, most welcome. The floor is yours.
Okay, نحطها بس على السكرين. طيب, السلام عليكم. Good evening to some people and good morning to some people. So thank you very much for inviting me for this interesting and excellent review that we have seen so far in this international symposium. I would like to thank the organizing committee for allowing me and giving me the opportunity to participate and really support the motion. So let's start without further ado. I'm going to talk about status epilepticus, advances and management. There is nothing for me to declare except my love for the specialty and my thanking for the Saudi German hospital that have proven really caring is like family, and the Saudi Society of Emergency Medicine. All right, so our objectives are going to be running through a life story, and the life story starts with definition, etiology, mortality related, prognosis. We're going to talk about what do I do now. Then we're going to let's talk the business. Let's find out what we are supposed to really do. And then we're going to talk a little bit about which one is better. Then we're going to look at advances into the context. And then we're going to try to look at, do we have a problem? Okay. And then we're going to give you a summary. So starting with this definition, when epilepsy treatment is not responding very well, the percentage of seizure-free patients that respond to the first anti-epileptic medication is about 47%. 13% of the population respond to the second or third anti-epileptic drug, and 36% are called refractory. So most patients with the new onset epilepsy respond to treatment. 30 to 40% of patients do not respond to medical treatment. Persistent seizures are more likely in patients with symptomatic epilepsy. Now, when we look at the epilepsy per se, and we look at brief seizures, how do we define them? There is a definition that came out that looks at duration. So a less than 5 minutes is a brief seizure, okay? Now, status epilepticus have been a seizure which is persistent more than the 5 minutes, reaching up to almost more than 30 minutes, which is a continuous seizure activity, more or equal to 2 sequential seizures without full recovery of consciousness. That means the patient did not come back to normal. Cerebral autoregulation and neuronal damage after 30 minutes is really very high. Now, there is a prolonged seizure which lasts from 5 to 30 minutes, and people have arbitrarily been putting this label to really get away from what medication we should use first. And then there is the acute repetitive seizures that usually we know, okay? Now, in status epilepticus, the WHO has defined it as a condition characterized by an epileptic seizure that is sufficiently prolonged or repeated at sufficiently brief intervals, so as to produce an unvarying or enduring epileptic condition. In the reality, continuous or repetitive seizure activity of at least 30 minutes with failure to regain consciousness between convulsions is a definition for status epilepticus. Now, during 2015, the Alliance for Anti-Epileptics came and looked at where do we stand, and does seizure which is prolonged after the initiation of mechanisms to terminate the seizure within 5 minutes, does that count as status epilepticus? And they were looking extensively into this issue, looking at the definition as a new marker now for a change. And they looked at also the refractory status epilepticus, which persists despite the adequate administration of benzos and at least 1 anti-epileptic drug. So now the changes in definitions have been really occurring, and there have been strong looking at where we stand and how can we attack this problem as fast as we can. Now, when we look at the rationale of the 5 and 30 minutes definition, we look at most seizures are really brief, and after 5 minutes of seizure activity, the risk of a prolonged seizure process increases. Now, 5 minutes threshold minimizes the risk of prolonged seizures and adverse outcomes from needless intervention during the brief self-limited seizures, which means if you are less than 5 minutes, your brain has sustained a seizure that may not leave a sequelae, and if it stops at that point, then nothing to worry. Now, the 30-minute definition duration of convulsive status epilepticus that may lead to permanent neuronal injury, which we want to avoid, we want to prevent, and we want to stop, as a matter of fact. Now, when we look at the pathophysiology of a prolonged seizure, the loss of cerebral autoregulation and neuronal damage, the hippocampal and the new cortical neuronal loss, complications occur with hypothermia, acidosis, hypertension, respiratory failure, and rhabdomyolysis, all these from the prolonged seizure effect. Now, looking at etiologies, most of the people have looked at why do we have it? Why do we have status epilepticus? And what's it caused by? So most of the pediatric etiologies relates to a 26% acute CNS insult, where we have a bleed, trauma, or infection. Now, in 21%, the underlying seizure is related to a sudden discontinuation of medication or fever as an upsetting to the system that causes the overdrive of the seizure activity to become status epilepticus. Now, 53% of the seizures that continue to be status epilepticus in children are unknown caused. Okay. Now, looking at that from another study, we found out that children, 35.7% less than 16 years of age, will have fever as one of the major causes of the status epilepticus, followed by medication changes or medication omission. And these will come to 19.8 compared to adults, where the cerebrovascular accidents comes up to 25%, and then the 18 medication changes are 18.9%. Now, when we talk about the status epilepticus presentations, we have two types, either convulsive, where we have a repeated generalized tonic-clonic seizures, persistent post-ictal depression of the neuronal function between seizures, or myoclonic. And then we have the non-convulsive, which is the most dangerous one, because the subtle status epilepticus and continuous or fluctuating epileptical twilight state with a spike wave stupor. Now, when we get into this stage, we need to remember that any patient that we have him in status epilepticus and we think that we have stopped the seizure, maybe we need to look at monitoring him by a continuous EEG, just to make sure that we're not really in a non-convulsive state. Now, who is at risk for status epilepticus? When we look at who is at risk, then the risk is related to age. The very young babies and the elderly are really highly patients that may have problems, okay? Precipitating events for status epilepticus, acute insults, neurologic abnormality, risk in patients with epilepsy are 10% with epilepsy presents with a status epilepticus, 25% of the status epilepticus occurs in those with epilepsy, and 15% of epilepsy patients experience status epilepticus, which means that there is a very high chance that patients who present with epilepsy may have problems. So does that reflect on mortality? Now, looking at seizures duration as a risk factor for mortality, we find out that in 10 to 29% to 29 minutes exposure to status duration, the risk is really low. Once we exceed the 30 minutes, exponentially, the risk for death is really high. In addition to death, of course, the issue which is related to handicap. Now, pediatric status epilepticus is 10 to 25% per 100,000, with the mortality risk in neonates or children, babies are 17%, and older children is 1%, and when you grow up, the higher the kids. So is that related to prognosis? Now, when we look at the outcome, we look at outcomes based on the 6 prospective studies in pediatric status epilepticus in the UK, USA, and Sub-Saharan Africa. We found out that the 1-year recurrence after the first ever continuous status epilepticus with prolonged febrile or afebrile is around 16% recurrence rate. The percentage with recurrence within 4 years is 20%. And the case fatality during hospitalization definitely differs between highly developed countries and countries that are really in the developing stage. So it's a 15% in the Sub-Saharan Africa and a 2.7 to 5.2 in US and UK. Subsequent epilepsy, 9 years post the continuous status epilepticus, had shown 25% patients develop that. So neurological, cognitive, and behavioral impairments outside of epilepsy are detectable within 6 weeks of the status epilepticus effect. And by 9 years follow-up, at least 1/3 of patients have some consequences. And that's why we're talking today about how we can prevent this, how we can stop that as fast as we can. When we look at the anti-seizure medication, adherence related to difference based on age, we find out that most of the adherence barriers type look around taste, we forget, the swallowing type, the embarrassed, refuse, activity, run out, and pharmacy. When we look at the older age, they get into the run out, the activity, the pharmacy more. But the young age is related really to the taste, not really being able to get it and not swallowing it properly. So that's really a major problem. So what do I do now? How can we tackle this? Now, when we looked at what should be the goal of the treatment the patients receives from caregivers and first responders, close your eyes and think of that question. What should we use? What should we do? What do we need really to do? Is it reduce seizure activity? Is it terminate seizure safely? Is it avoid unnecessary benzodiazepines? Is it transport to the ED? Is it terminate the seizure quickly? Does it look at shortening seizures, reduce seizure severity? All these answers in your mind are legitimate answers that we need to look at. How can we help these patients? How can we improve their status? Now, looking at the American Epilepsy Society guidelines, the evidence-based guidelines in treatment of convulsive status epilepticus, the goal of therapy is the rapid termination of both clinical and electrical seizure activity. Since appropriate and timely therapy of status epilepticus reduces the associated mortality and morbidity, they are really on the target. So we want to rapidly terminate that seizure. Now, the therapy that we use for seizure, so for status epilepticus, and we need to look at what do we need to do first. So remember, the ABCs, as they are part of our emergency practice protocols all the time, they come to real action here with status epilepticus. They come in all kinds of seizures, not related only to status epilepticus. That's what we need to teach the parents. That's what we need to teach the community. That's what we need to really make sure that these kids are not really affected by a lack of airway, breathing, or circulation. We stabilize and maintain the airway, establish breathing, and maintain the circulation. We monitor the vital signs, pulse, respiratory rate, blood pressure, temperature. All these are things that we do initially when we see these patients fast. And they are done within the 30 seconds of approach. So we're looking at their soft tissue being obstructed, secretions and aspirations, tonic convulsive seizures, central or iatrogenic pharmacological problems. Establishment of the airway is really necessary. Now, when we look at maintaining the circulation, definitely we need an IV. An IV access is very, very important. Whether you put it as interosseous, you put it an IV, you put it some sort of an access that you need to access to these patients as fast as you can. Electrolytes, toxicology, the anti-epilepsy levels, drugs levels, and especially glucose. Because if hypoglycemia is suspected, then there is a very high chance that you will not be able really to do much of improvement of the seizure unless you correct it. So consider bioreduction also. Cardiac monitoring, we look for arrhythmias spontaneously that occur during the status epilepticus or secondary to treatments, especially phenytoin. Now let's look at the graphs. These have been circulated all over the protocols, all over the places, all over the ERs, what we should do in the first time that our patient arrives. Definitely the stabilization phase, where it includes the ABCs, time seizure monitoring vitals, oxygen and respiratory support, ECG monitoring, check glucose, IV attempts. Then the first action that occurs that need to be really run very fast is giving benzodiazepines as a treatment in the initial therapy of choice. Whether you give IM midazolam, IV lorazepam, or IV diazepam, or you use the alternative routes where you give IV phenobarbital, pre-hospital options, which is rectal diazepam or intranasal midazolam or buccal midazolam, are the options in the pre-hospital arena. Now, in this 5 minutes, we need to make sure that that seizure stops or at least breaks so that we don't have a continuation of a status epilepticus. We're reaching to the 20 minutes and more. then we are getting into the second-line therapy, where there is no evidence-based preferred second therapy of choice, where we're going to choose a second-line treatment. You can give IV phosphonitine, IV valproic acid, levetiracetam, the IV phenobarbital as alternative. So all these are acceptable management tools that you can give during that period of time. You need to be fast. You need to be acting in advance for looking at these patients' prospect, because they can continue having the seizure, which you end up with the third-line therapy, where you need to go for anesthesia, whether thiopental, midazolam continuous, phenobarbital, or propofol continuous infusions that may need to be used. So let's talk the business. Let's find out what we are supposed to do. Now, in early, and the early part includes within the first 10 minutes, within the first 10 minutes, you need to start looking at your doses. These things has to be engraved in your ERs, engraved in the beds that you are dealing with patients with seizures on. Put them on the wall, put the seizure dosage on the wall. Make sure that you have a box that has the seizure meds in it that you can grab at any point of time that you need. You remember doses that are important, whether the rectal diazepam, the intranasal midazolam, or if you want to give the lorazepam IV. Dosage are very important to look at. And that's the early status epilepticus, within 10 minutes of the seizure onset. Definitely, we don't know how fast the patient will be arriving to your area, which means definitely if he arrives from anywhere nearby the vicinity of your coverage, that is more than 5 minutes. And if he's continuously seizure at that time of arrival, then he is already past that stage. So give him the first dose as fast as you can, and then prepare for the second line medication. And that will be within the first 10 to 30 minutes. So you give phosphonitine 20 milligram per kg. You can give and you can repeat the 5 to 10 milligrams per kg if needed. Or you give the IV levetiracetam, and that's 30 to 60 milligrams per kg. The IV valproic acid. Remember that you need to escalate as fast as you can. Appropriate medication and appropriate dosage. Now, when you exceed the 30 minutes, when you're reaching to the 30 minutes, always remember this is a refractory status epilepticus. Now, I may need to think of something else. Midazolam load, phenobarbital load, and then a continuous infusion, thiopental, or you start with the ketamine as a loading dose and titrate. Now, ketamine has been really introduced recently, where some people have been started using ketamine very frequently now for seizure control. Now, we use as the guideline support, so we start with the midazolam, phenobarbital, thiopental, and we still can use the ketamine in that order. Remembering these dosage are really important in children. So phenytoin and phenobarbital, valproic acid, and levetiracetam, always in the 20 milligram per kg dose, and it's easy to remember those. So it's something that's really common, and you can always repeat those. So pediatric patients for second-line therapy, phenytoin, valproic acid, levetiracetam, and the phenobarbital are other drugs that you can use. Now, when we look at the benzodiazepines, lorazepam comes to be really on the top because it has the longer anticonvulsant activity. The problem with is that only one route, that is the IV. The rectal route can be used, but the rectal route has to have a glass introducer. So who wants to do that in a baby who would give him a rectal with a glass introducer? So putting an IV is a good thing for lorazepam because it takes longer time. It works for a longer time. Benzodiazepines are fast acting, the faster onset of action because of the greater lipid solubility, and must be followed by another anti-epileptic drug in order to prevent further seizure activity. Midazolam is a great drug, one of the greatest drugs, but remember this is an ultra short acting drug. So it's a water soluble, it can be given IM, and it's a less sedation, less respiratory depression. It is mandatory to be able to maintain the airway whenever benzodiazepines are in use. And that's something that you have to remember and really actively look at. When we look at the extra, then phenytoin and phosphonitine come into the picture. Phosphonitine is a phosphate ester prodrug of phenytoin, one of the greatest drugs that have been established, introduced into the market. It's not a propylene glycol base, so it has less tissue toxicity and cardiac side effects, so you can give it faster. The pH of phenytoin is 12, but the pH of the phosphonitine is 8. So it's compatible with any IV solution, including dextrose. You remember when you give phenytoin with the dextrose, it crystallizes. So that is a no-no with phenytoin, but it's acceptable with fosphenytoin. Remember, the most advantage of this fosphenytoin is that it's being given IM, and that's a great advantage. Of course, some of the disadvantages occur, and about up to 50% we have suburitis and paresthesia that can occur. And the cost is a little bit high cost than really the usual phenytoin. The phenobarbitals is a drug of choice in neonates. It's a high sedative and really causes depression of the brain waves, which may be enhancing with the prior benzos and can affect the respiratory rate also. So prolonged start time is really something that we need to look for when we are using it. Sodium valproate is available as an IV preparation and alternative to you for use in the later stages of status epilepticus. The loading dose is about 10 to 30 milligram per kg, and hypotension has been reported as using it frequently. Now, refractory status epilepticus, the failure to respond to sequential treatment of benzos, phenytoin, phenobarb makes you think of what is the next step. And for that reason, you always have to be prepared. Midazolam infusion, propofol infusion, valproic acid infusion. We need to look at how fast we start using these medications and treatment for the refractory treatment. There's a lot of tables that you can see. Now, which one is better? Apparently, there's no clear evidence that any one of the second-line anti-epileptics is better than the other. And all the studies have shown that they are medication of choice among second-line agents, maybe therefore also be informed by individual patient characteristic and center availability. So whatever you have is acceptable to use, okay? Now, when we look at advances, the new approvals for seizure rescue medications, we have the midazolam nasal spray, now is coming up in the market, and the diazepam nasal spray. Both of them have been available, and I'm not sure if they are really being used in Saudi Arabia yet, but they have been approved. Again, midazolam intranasal have been really extensively worked up. I'm not sure how much time do I have, Mohammed, if you can just give me a hint. So
still there more than 20 minutes remaining, sir.
Okay, good, excellent. So in treatment success, we found out that seizure termination within 10 minutes and no seizure recurrence in 10 minutes to 60 hours is about 53.7% in the nasal midazolam compared to the placebo. Seizure recurrence was more in placebo than in the midazolam being nasally. So nasal midazolam has been really worked up as something which is really excellent. Now we're looking at the efficacy outcomes. Midazolam nasal spray have shown really an improvement, a better improvement than the placebo when we look at the outcomes. It's consistent with non-benzodiazepines, anti-epileptics, and sedation expected from the intranasal administration, some nasal discomfort. The side effects really low rate of respiratory depression type events, 0.7%, and there is no discontinuation that you need to do because of the side effects. There is the Artemis extension trial have made up an open label where they included 175 patients enrolled, 1998 seizure cluster episodes, and up to 2 doses of midazolam nasal, 5 milligrams during seizure cluster have been used. So treatment success, the first dose was about 55.5%, which is really a great number. Now, for patients requiring second dose, which is about 40% of the patients, treatment success on the second dose was 80%, which means that we have really a good success with this intranasal midazolam being used. Now, there is other therapeutic options, including an experimental therapy. Now, immunoregulatory therapies have been tried for status epilepticus, where we have case series suggesting some efficacy of broad spectrum immunotherapy treatment in super refractory status epilepticus, including IV steroids, IV immunoglobulins, and plasmapheresis. While steroids and immunotherapy may be considered as a last resort treatment options, we usually reserve this approach for patients with suggestions of an underlying inflammatory or autoimmune etiology, of course. Ketogenic diet has been really introduced, and it does show an effect. Strange enough, some studies have shown that within 5 days of starting a ketogenic diet for a refractory status epilepticus, patient has responded. Now, remember that the outcomes when we measure here is a stoppage of a seizure, not really the outcome looking at the patient outcome himself. What is he going to be having? Therapeutic hypothermia and other non-pharmacological therapies have been tried. Mild hypothermia of 32 to 35 demonstrated reduction in seizure burden during and after hypothermia treatment without relapse after hypothermia, which is really an interesting modality of treatment. Now, what came into the recent arena is the synergistic pharmacotherapy and future directions. They found out that diazepam ketamine valproate combination was shown to act synergistically and was far more effective in stopping status epilepticus than the triple dose monotherapy using the same individual drugs. Which means that if I'm going to go and use only valproate and the seizure does not stop and reload with valproate again, then the chances of me stopping that seizure with diazepam ketamine valproate is much higher than giving valproate alone. Same thing with phenobarbital, phenytoin, pregabalin in ratio of 1:1 and 1:1 demonstrated synergistic interaction, and of course in a mouse model of tonic-clonic seizures. And that puts in the mind that using synergistically drugs that in combination may really have a lower side effects and in addition a faster recovery from the status epilepticus. Valproate, lamotrigine combination was significantly more effective than the others used alone, whether carbamazepine, phenobar, phenytoin, or valproate. So that's an interesting new modality that people have been looking at this point in time. Though the latest guidelines recommend initial benzodiazepine monotherapy with rapid escalation to second-line agents, early monotherapy continues to gain interest as a potential target for investigation. So we're having time to come and see in the near future how this will change. Now, when we look at quality, healthcare especially, we look at safe, effective, patient-centered, timely, efficient, and equitable. So please make sure that we use the appropriate medication and we fix the things. Now, we have a problem. Now, I think this is something that we need to initiate a movement in all our emergency departments, our pediatricians, our colleagues who deal with seizures, and even patients. We need to look at how much the basic critical care and emergency principles of therapy have achieved in their widespread acceptance and routine implementation. Are we using what we are preaching? Are we using what we're really reading and reading about? Now, patients are still receiving inadequate treatment. Unfortunately, we found out that the use of inefficient therapies, whether sedatives or paralytics, and the administration of insufficient anticonvulsant doses leads to continuation of a seizure. Now, looking at the delays in anti-seizure medication are very frequent, okay? Now, looking at this, remember the 5 minutes time, the 20 minutes time, the 40 minutes time, and the 60 minutes time. The first initial medication, anti-epileptic medication, sometime we have reached almost to 30 minutes from the time of onset to give it. And that's too long to reach stabilization. And the first therapy, it takes longer time to really be effective. And that's what we need to avoid, okay? The third line therapy, we have some compliant here that we will give it earlier on, even looking at how improvement are going to be, but still we have some delays. Some people have not really looked at it except after a while. Treatment delays also happen in patients with prior epilepsy diagnosis or prior status epilepticus episodes, okay? And out of hospital seizure onset in patients with epilepsy, only 12 received the first benzodiazepines before arriving to hospitals. Now we have a problem with this because we are not allowed to give in the field or with the paramedics any benzos. So we're not giving them any chances. Maybe some of the families will have rectal diazepam that is being issued by their caregiver that will be really given earlier on. And most of the time that is given, and usually it does not really work very well, especially if the seizure is really a continuum. So that delays how much really we are giving our patient care. So in summary, how can we help? How can we change what we have now? We need to make sure that all our ERs are equipped looking at seizures, looking at how fast we look at the seizure patients and find out, is the seizure patients really having the treatment that appropriate that they need to get? appropriate dosage, appropriate amount, appropriate numbers? Do we really escalate very fast, giving the one single benzo, then looking at, do we need, because of the prolonged time, do we need to start the next phenobarbital or phenytoin, or maybe valproic acid or Kibra? So do we need to run through those? How fast and how really diligent we need to be on this? Now, looking at this, what have you learned during all the exposures that we have had with these seizure patients? How many of these patients we have lost, right? Like, we have to look at, are we changing the future of these kids? Are we helping them to become really safe? Are we giving the appropriate medication? Are we teaching the parents how to handle the epilepsy when it occurs or the seizure when it occurs? And are we helping them with the appropriate medication for them to control the seizure? Now, we need to be diligent in how much of information we give and how we teach them how to prevent sequelae of seizure to their children. It's very important that this is our task. This is, as a matter of fact, as a group movement, it's our task as physicians and ER physicians and pediatricians to look at how we can improve the status epilepticus occurrence and reduce it, because this affects the brains of these patients and unfortunately leads to a lot of sickness. Now, I would like to thank you. I finished my presentation. If you have any questions, and I would like to invite you for the SASM 2022, hopefully coming this February 14 and 16. Thank you very much for giving me again the chance to really look at, give you a look at the seizure medication and the epilepsy and status epilepticus.
Thank you so much, Dr. Osama. Jazakumullah khairan. It was an honor having you with us tonight in this wonderful cutting-edge lecture. There is these 3 questions. If you can reach them.
Yeah. Ahmed is asking us, is there a specific time to keep trial of peripheral line before inserting IO in a vitally stable patient with status epilepticus? Status epilepticus patients are not vitally stable. So if you see a heart rate which is high, a respiratory rate which is not really good, this is not a stable patient. So if you give them the chance of doing 1 IV, that is more than enough. I hope you have good nurses that insert the IV very fast for you. I wish. And unfortunately, that is not happening all the time. So please, if you are having a problem with it, please immediately insert a line. Okay? Don't waste the time. Give them a chance of 1 trial and then stop. Can we add phenytoin to dextrose 5%? No, we can't. We can add only phosphonotoin. The phosphonotoin is something that is really working very well with all types of fluids. If you're going to give it IV, but also you can give it as IM, and that's why it's really being used. The last question is about what are the most important recommendations you need to discuss with the parents if epilepsy happened at home before going to the ED? This has been already dealt with our epileptologists and the neurologists, where they recommend that they have the diazepam with them if they think that this patient is going to have a prolonged seizure or a seizure that is uncontrollable with their medication. They always advise them to bring all their medication with them to the ED, always give the first dose of diazepam at home, make sure that the seizure does not exceed 5 minutes. All this information is being given to the parents. And with our neurologists nowadays, they are very diligent into this because they know that these patients, once they get into status epilepticus, they go into the ICUs. They are not really observed in the floors. And that's why they has to be really advancedly taught. In addition, one of our part of usual emergency management is we teach them how to handle the seizure, how to keep the patient on the comfort position, in the left lateral position, making sure that he does not bite his tongue, making sure that his airway is open, so that he does not really suffocate till the team come in. Dr. Khawaja is asking, is there a role of IV glucose and thiamine in epilepsy patients? Sure, definitely. That's why this is what they call it. The initial management in the old days was look at the DONTs, and the DONTs really are the dextrose, the oxygen, the naloxone, and the T is for the thiamine. So we definitely give these patients related to their function. So if patients who are really having neonates, we look at pyridoxine more than thiamine. Patients who are old, patients who are really in the old age, yeah, thiamine has been really being used a lot frequently. Now, do you prefer which medication for the second line? Currently, I think the only familiar used in case is phenytoin IV with its side effects. What about phosphoramidine IV, Kibra IV, Dvt IV in case A? Dr. Khalid is asking really a great question. Thank you very much. To be honest with you, as we said, the preference here, both of them studies have proven that the second line medication that you use all of them are equal from the point of effectiveness. Now, what do you have in your area is important to consider and to keep with. So phenytoin is a great drug, one of the greatest drugs that I use frequently for trauma patients, especially if they come with seizures. And because that it does really not give me much of sedation, so that I will be able to assist the patient really frequently with reflexes. Now, the phosphoramidine, the Kibra are available, Dvt IV are available in the Kingdom of Saudi Arabia. And depending on the hospitals that you are in, your pharmacist can always bring them in. And if they are available in one center, they are available in the kingdom. So you always can request them and keep them on your rack. As we said, using multiple therapies rather than monotherapy has been really an acceptable behavior over the past few years and been really in trials. I hope I answered all the questions, Dr. Mohammed.
Thank you so much, Dr. Osama. Jazakumullah khairan. I can see the enthusiasm of the attendees for the lecture. Thank you so much. Jazakumullah khairan. Now we are going to have Dr. Marwan Al-Bladi in a very nice lecture about controlling the wheezy chest. Dr. Marwan is the consultant of pediatric emergency medicine in Madinah, and he is the leader of the pediatric emergency pathway in Madinah. Dr. Marwan, the floor is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for giving me this opportunity to be part of this conference.
Dr. Marwan, sorry for interruption. I think you are presenting in a presenter view. So
sorry.
You can see all, yeah.
What about now?
Perfect, sir. Thank you.
Still?
Still.
I will just have 1 minute.
Take your time, sir.
Sorry for the delay.
It's okay.
Is it shared now? Now, what about now, Dr. Talat?
Could you please shift to the next slide?
Yes.
Yeah, perfect. Perfect now. Thank you.
Good, thank you. Okay, as introduction, wheezing is one of the most common presentation in emergency. It is a continuous musical sound that originates from oscillation in narrowed airways. It is mostly heard in expiration due to a critical airway obstruction. It is a sign of lower intrathoracic airway obstruction. Differential diagnosis of wheezing, it's mostly not always it is a sign of it's a presentation of asthma. Not all patients presenting with wheeze have asthma. Sometimes it is infection like viral bronchiolitis, tuberculosis, chlamydia. Sometimes it's asthma, anatomic abnormalities like laryngomalacia, tracheomalacia, tracheoesophageal fistula. It's sometimes extrinsic airway anomalies like vascular ring, esophageal foreign body, or intrinsic airway anomalies like airway hemangioma, bronchial lung cyst, congenital lobar emphysema, or foreign body in airway. Sometimes it's disorder in mucociliary clearance like cystic fibrosis, primary serial dyskinesia, or bronchopulmonary dysplasia, aspiration syndromes like gastroesophageal reflux disease or pharyngeal swallow dysfunction, sometimes present with wheeze, or congestive heart failure, anaphylaxis, or inhalational injury. I will speak in this talk about viral bronchiolitis and asthma, as these are most common presentation in pediatric emergency. First, bronchiolitis is acute inflammation, edema, and necrosis of epithelial cell lining small airways, and increased mucus production. RSV isn't the only culprit of bronchiolitis. Also, human metapneumovirus, influenza, parainfluenza virus, and adenovirus, rhinovirus, etc., can be causes of bronchiolitis. So, how to diagnose it? It is a clinical diagnosis. History and physical examination are enough to diagnose bronchiolitis. Clinical presentation. The first episode of wheezing in a child less than 2 years of age after 2 to 4 days of viral prodrome of fever, cough, and nasal congestion between the months of November and April in northern climates. This is the classic presentation. The following symptoms are common, like fever in around 30% of cases, usually less than 39. Poor feeding, typically after 3 to 5 days of illness. And young infants may present with apnea without other clinical diagnosis. What is the typical course? Most children do well. Symptoms peak around day 5 of illness, and symptoms such as cough may present for up to 3 weeks. So what are the risk factors for severe bronchiolitis? Chronic lung disease, hemodynamically significant congenital heart disease, young infant under 3 months, and premature birth, particularly under 32 weeks, and neuromuscular disorders, and also immunodeficiency. Those patients can present with severe bronchiolitis. So what are the risk factors of apnea and bronchiolitis? And can it be predicted? Yes. The overall incidence of apnea and bronchiolitis is 2.7, but in those under 6 weeks of age, the risk can be as high as 5%. Risk factors that are associated with apnea in patients with bronchiolitis include small for gestational age, less than 2.3 kg, and age less than 2 months, oxygen saturation less than 90, and previous episodes of apnea. The severity assessment of apnea can be classified to mild, moderate, and severe according to the respiratory rate, work of breathing, mental status, oxygen requirement and suctioning requirement, and breath sounds and cough. I should suspect impending respiratory failure if any of the following are present, like signs of exhaustion, for example, listlessness or decreased respiratory effort, recurrent apnea, failure to maintain adequate oxygen saturation despite oxygen supplementation. The differential diagnosis, I will consider asthma if recurrent wheezes, personal and/or family history of atopy, onset without other respiratory symptoms, clinical improvement after administration of bronchodilator. While bronchiolitis sometimes present to the ED in a classic fashion, it's often not possible to distinguish bronchiolitis from asthma or pneumonia as the first contact in the ED, as their clinical presentation may overlap. Children with asthma usually present with recurrent wheezing in a child more than 2 years old with a personal and or family history of atopy or a family history of asthma. Environmental or allergic precipitants are often present in older children, and response to bronchodilator may help to differentiate bronchiolitis from asthma. I will consider pneumonia if high-grade fever over 39 and or persistent focal crackles Children with bacterial pneumonia often appear toxic and tend to have higher grade fever than those found in bronchiolitis. They may have focal chest finding and usually do not have wheeze. Asthma should be suspected when wheezing is recurrent. There is family history of bacterial pneumonia can accompany bronchiolitis. It can also present with wheezing, a prolonged fever, onset of fever after the first few days of upper respiratory infection, and worsening respiratory symptoms may indicate pneumonia. Treatment consists of antibiotic therapy and oxygen if needed. A chest radiograph and CBC may be helpful to differentiate pneumonia from bronchiolitis. I will consider foreign body aspiration if there is no upper respiratory symptoms and asymmetric breath sound, and chest radiograph may show unilateral hyperinflation. I will consider gastroesophageal reflux disease if onset is usually subacute and symptoms are typically prolonged, lasting 4 months. And also I will consider pertussis if paroxysm of cough end in a whoop, fever is uncommon, and apnea and cyanosis can occur. Investigations. Routine radiographic or laboratory studies are also unnecessary, and clinicians should diagnose bronchiolitis and assess its severity on the basis of history and physical examination alone. Testing for specific virus is no longer needed because multiple viruses may cause bronchiolitis. Chest X-ray of infants with bronchiolitis often reveals non-specific patchy hyperinflation and area of atelectasis, which may be misinterpreted as a consolidation. This can lead to increase and inappropriate use of antibiotics. While routine chest X-ray is not supported by current evidence, it should be considered when the diagnosis of bronchiolitis is unclear, the rate of improvement is not as expected, or the severity of disease raises other diagnostic possibilities such as bacterial pneumonia. A complete blood count and a blood culture should be considered if a bacterial infection such as pneumonia or sepsis are suspected. In bronchiolitis, a CBC is typically normal. If dehydration is suspected, the chemistry panel may serve as an adjunct to the physical exam. Determination of blood gas is useful if the patient is very ill. Nasopharyngeal swab for respiratory viruses generally are not helpful from a diagnostic perspective and do not alter management in most cases. They are not routinely recommended unless required for infection control, like cohorting of hospitalized patients. Recently, the high rate of co-infection with multiple viruses has called even this indication into question. So the ED treatment, supportive care is the cornerstone of the treatment. The management goals: adequate oxygenation, hydration, oral, nasogastric, or intravenous rehydration may be necessary if children cannot maintain fluid status. Supplemental oxygen may also be necessary if oxygen saturation are less than 90% persistently, and limited suctioning to clear the nares may be beneficial. Nasal suctioning, given that the infant are obligate nasal breathers until 2 months of age, and the upper airway obstruction from mucus can contribute significantly to the patient's breathing difficulties, a trial of nasal suctioning is reasonable in the ED. While it appears that suctioning mucus out of the blocked nares would be a harmless procedure, one recent study has suggested that deep suctioning and long intervals between suctioning are associated with increased length of stay. This suggests that if suctioning is performed, it should be done superficially and reasonably frequently. Some studies have shown that epinephrine nebulization may be effective for reducing hospital admission, and one trial showed that combined treatment with epinephrine and steroid reduced admission. However, the evidence remains insufficient to support routine use of epinephrine in the emergency department. It may be reasonable to administer a dose of epinephrine and carefully monitor clinical response. However, unless there is a clear evidence of improvement, continued use is not appropriate. A systematic review of 19 studies evaluating the use of epinephrine in bronchiolitis shows no effect on length of hospital stay, and there is insufficient evidence to support its routine use in admitted patients. Clinicians should not administer albuterol or salbutamol to infants and children with a diagnosis of bronchiolitis. They have been shown to provide short period of symptomatic relief in some patients. However, they have not been shown to decrease the rate of hospitalization, oxygen requirement, mechanical ventilation, the duration of hospital stay, or the duration of illness. A trial of bronchodilator can be tried. If there is no clinical improvement after one dose, the treatment should be discontinued. Children with bronchiolitis present with a wheeze that is clinically similar to that observed with asthma. So the pathophysiology of bronchiolitis is such that the airway are obstructed rather than constricted. Also, infants appear to have inadequate beta agonist lung receptor sites and immature bronchial smooth muscles. While studies have shown small improvement in clinical scores, bronchodilators have not been shown to improve oxygen saturation, do not reduce admission rate, and do not shorten the duration of stay in hospital. When the diagnosis of bronchiolitis is clear, a trial of salbutamol is not recommended. It nebulized hypertonic saline. It has been hypothesized that hypertonic saline increase mucociliary clearance and rehydrate airway surface liquid, with questions as to impact on inpatient length of stay. Recent evidence from meta-analysis, which accounted for improvement variation among included studies, does not support the use of hypertonic saline. In a typical North American population, 3% hypertonic saline has no impact on length of stay and should not be used routinely. Clinicians should not administer systemic steroid to infant with a diagnosis of bronchiolitis in any settings. Antibiotics provide no benefit to children with bronchiolitis. They are reserved only for secondary bacterial infections such as pneumonia or otitis media. Over-the-counter medication containing antihistamines, decongestants, expectorants, and capsaicins are not recommended for children with bronchiolitis. There is no evidence that they have provided relief in even uncomplicated upper respiratory infection. This is a clinical pathway for children with bronchiolitis, the management of children with bronchiolitis. They are classified to mild, moderate, and severe. The mild will consider suction bulb, and if they meet the discharge criteria, will be discharged. And moderate can be given albuterol trial and also suctioning, and discharge if they meet the criteria or admission criteria to be admitted. In severe, we'll use wall suction, NBO. If wheezing, we'll consider albuterol trial. If severe respiratory distress, we'll consider racemic epinephrine or high-flow nasal cannula and admission to be ICU. So the criteria for admission, if there is signs of respiratory distress, indrawing, grunting, or respiratory rate more than 70, supplemental oxygen required to keep saturation more than 90%, dehydration or history of poor fluid intake, cyanosis or history of apnea, infants at high risk for severe disease, or if the family unable to cope. The discharge instructions should be instructed to give frequent small feeds, nasal drops, analgesia for fever, and avoid smoke in the child's home because it increases the risk for more severe symptoms in bronchiolitis, and methods for limiting transmission like hand washing and avoiding child care centers while ill. And the natural course of bronchiolitis may take up to 2 weeks. They should know this. And also they should know that the bronchiolitis is progressive and the peak is from day 3 to day 5. After that, mostly started to improve. They should return to ER if worsening work of breathing, fluid intake is 50 to 70% of normal or no with NABI for 12 hours, apnea or cyanosis, exhaustion, for example, not responding normally to social cues, wakes only with prolonged stimulation. So peers and pitfalls. Bronchiolitis is a clinical diagnosis. We should pay close attention to vital signs. Very young infants and patients with comorbidities or highly abnormal vital signs have the greatest risk of decompensation. The majority of infants with bronchiolitis require no investigations and no pharmacotherapy. Management is to support feeding and oxygenation as required. So our goal is to encourage clinical diagnosis of bronchiolitis and decrease use of tests and treatments without strong evidence base for benefit, like chest radiograph, routine blood testing, albuterol use, antibiotic use, and decrease ED length of stay, admission rate, revisit rate, and improve parental satisfaction. Moving to asthma, it is the most common chronic childhood illness and the leading cause for emergency department visit and hospitalization. Asthma emergency visits vary seasonally, peak periods typically in the fall months after children return to school. Acute asthma exacerbations is they present with shortness of breath, audible wheezing, cough, mostly nocturnal, and increased work of breathing. Symptoms are usually gradual and progressive over several days. And common trigger for bronchospasm is upper respiratory tract infection. History assessment, we should ask about time of onset of exacerbation, potential causes like exposure to allergen, heat, chemicals, severity symptoms compared with previous exacerbation, all current medications, time, last dose, last course of steroids, history of sudden onset of choking. This is a concern for foreign body, previous history of asthma and wheezing. The pediatric asthma severity indicators, if the patient is having previous life-threatening exacerbations, admissions to ICU, intubation, deterioration while on systemic steroid, or using more than 2 canisters of short-acting beta agonists per month, or cardiopulmonary and psychiatric comorbidities. These are the indicators for severe asthma. The physical exam, definitely we will check vital signs, pulse oximetry, overall appearance, mental status, respiratory status, assess severity on exacerbation, hydration status, and symmetry on respiratory exam. Diagnostic study, chest X-ray is not routinely recommended. I will consider if focal chest finding, fever, extreme distress, subcutaneous emphysema, history of choking. I will consider VBG or ABG if in asthma, if it is not recommended routinely. If the BaCO2 more than 32 is indication but not diagnostic for severe exacerbation. If it is more than 50, it's a risk factor for impending respiratory failure. Metabolic acidosis is indicator of impending arrest. I will consider bronchiolitis if the patient has low-grade fever, first wheeze, and less than 24 months of age. I will consider pneumonia if he is toxic appearance, respiratory distress, febrile, and have crackles by auscultation. I will consider gastroesophageal reflux disease if he has heartburn, regurgitation, or dysphagia. I will consider tracheomalacia in the first 2 months of life, strong inspiratory component, no improvement with asthma medication, may even cause worsening of the symptoms. I will consider aspiration or ingestion of foreign body if through cough, choking episodes, wheezing, hoarseness, biphasic stridor or dyspnea, or decreased air entry. I will consider acute allergic reaction like anaphylaxis or angioneuritic edema if it has rapid onset of dysphagia, wheezing, stridor, or cutaneous allergic signs like urticaria rash. Severity assessment, we can use BRAM score. It is a 12-point clinical scoring rubric that captures a patient asthma severity using combination of scalene muscle contraction, suprasternal retraction, wheezing, air entry, and oxygen saturation. BRAM was originally developed for patients aged 3 to 6 years and subsequently validated for children aged 1 to 17 years old, in whom performed equally well. You can download PRAM score application in your iPhone or Android for free. It is a free calculator. So the goals of treatment of an asthma exacerbation in the acute care setting are to reverse hypoxia, bronchospasm, and inflammation, while also aiming to prevent recurrence of another exacerbation. The mainstay of treatment in acute asthma exacerbation is nebulized albuterol and ipratropium bromide, as well corticosteroid. Steroids should be administered as early in the ED visits as feasible. Significant clinical benefits begin 2 hours after administration and are most pronounced among the sickest children. A Cochrane review demonstrated that steroid use decreased the need for hospitalization, decreased risk for relapse after initial treatment, and may facilitate an earlier discharge from the hospital. And oral administration of steroid is just as effective as IV administration. Dexamethasone versus prednisolone suspension. Dexamethasone tastes bitter and may be given in smaller volumes. Studies shows that 0.6 milligram per kg for 2 days is as good as prednisolone for 5 days. The compliance may improve as a result. The treatment is depending on severity, PRAM score. An institutional pathway can be used if available in your institution. We will go through each pathway of this briefly, of mild and moderate and severe. In the for the mild PRAM 0 to 3, the doctor should assess the patient within 60 minutes. Salbutamol should be given initially, and vitals and PRAM assessment every 60 minutes. If PRAM more than 4, I will move to moderate pathway. If it is less than 3, I will consider discharge with instruction. In moderate pathway, PRAM 4 to 7, the doctor should assess within 30 minutes and keep saturation more than 92, and salbutamol initially and every 30 to 60 minutes, PRN. Oral steroid as soon as possible after first aerosol treatment. I will consider ipratropium and vitals assessment and PRAM assessment every 30 to 60 minutes. If it is more than 8, I will move to severe pathway. If it is 4, 6 to 8 hours after steroids administration, I should consider admission. If less than 3, I will consider discharge with instruction. In severe PRAM score 8 to 12, the doctor should assess the patient within 15 minutes and should keep saturation more than 92. Salbutamol and ipratropium initially and every 20 minutes for 3 doses, then every 20 to 60 minutes as required. Systemic steroid should be given as soon as possible after first aerosol treatment and should consider IV access and blood gas. Vital assessment and PRAM assessment every 20 to 60 minutes. If it is unchanged or less than 3 points improvement, I will move to impending respiratory failure pathway. If it is 4 hours post-steroid, I consider admission. If it is improving, I will move to moderate pathway. In impending respiratory failure, if the patient has lethargy, cyanosis, decreased respiratory effort, rising PCO2, the doctor should assess the patient immediately and administer 100% oxygen, support ventilation if required, and continuous monitoring of cardiopulmonary status and continuous nebulization, salbutamol with ipratropium, and should give systemic steroid as soon as possible after first aerosol treatment and obtain IV access. And also will consider IV magnesium sulfate, IV fluid, chest X-ray, and blood gas, and should contact pediatric ICU. I will go through each of the medications. Salbutamol for patients who weigh less than 20 kg, I will use salbutamol MDI 4 puffs or 2.5 milligram nebulized plus 3 ml normal saline. For patients who weigh more than 20 kg, I will use salbutamol 8 puffs or 5 milligram nebulized salbutamol plus 3 ml normal saline. Systemic steroid should be administered as early in the ED visit as feasible. Oral administration of steroid is just as effective as IV administration. We will consider IV steroid, like IV methylprednisolone, 2 milligram per kg loading, and then start 1 to 2 milligram per kg per day, divided 6 hourly, if unable to tolerate orally or in more severe cases. The inhaled steroid, there is no evidence that use of inhaled steroid in the ED are beneficial. There is evidence that they decrease relapse rate in the outpatient settings, like fluticasone. Ipratropium bromide, it is an inhaled anticholinergic agent which blocks cholinergic receptors, producing bronchodilation. It works synergistically with albuterol when nebulized together. The nebulized dose is 0.2 to 0.5 milligram every 20 minutes with maximum of 3 doses. Magnesium sulfate, the dose is 50 milligram per kg IV bolus over 20 minutes. Its common adverse effect is hypotension, can be avoided by infusion of the dose over 20 minutes and giving a fluid bolus prior to or during the magnesium infusion. We should monitor blood pressure, heart rate. So magnesium sulfate promotes bronchodilation by relaxing bronchial smooth muscles. A meta-analysis suggests that use of magnesium sulfate results in improved outcome for both adults and children. It's improving respiratory function and decreasing hospital admissions. IV magnesium sulfate may be considered in cases of moderate or severe asthma with incomplete response to conventional treatment. IV magnesium sulfate therapy should be initiated early within the first 1 to 2 hours of the ED visit. Epinephrine, recommended for patients who are minimally responsive or responding poorly to beta agonist, ipratropium, systemic steroid, magnesium sulfate therapies, or who are unable to tolerate nebulized treatments. Sub-Q epinephrine can be given 0.01 milligram per kg, maximum of 0.3 milligram per dose. IV aminophylline improves lung function in children when added to standard asthma treatment, but no reduction in symptoms, number of nebulized treatments, or length of stay. Risks, small therapeutic window, and high side effects rate, like headache, nausea, palpitation, cardiac arrhythmias, hypotension. IV salbutamol may improve recovery time and length of stay. When using IV salbutamol, be on the lookout for excessive tachycardia, low diastolic blood pressure, and rising lactate. It will start at 1 mic per kg per minute infusion and titrate to 5 mic per kg per minute. Is ketamine useful in preventing the need for intubation in the worsening asthmatic? Current literature on this topic is mixed. There is more convincing evidence that it is required before ketamine can be recommended for routine treatment of severe pediatric asthma to avoid intubation. A limited case series has reported the effectiveness of a bolus, 2 milligram per kg, followed by continuous infusion, 2 to 3 milligram per kg per hour of ketamine in children with severe asthma who were approaching respiratory failure. In this study, the use of ketamine resulted in prompt improvement and avoided the need for endotracheal intubation. This is an appealing use of ketamine because it may allow one to avoid the hazards of endotracheal intubation and mechanical ventilation in the patient with asthma. Randomized controlled trial showed no improvement in pulmonary index scores with administration of ketamine into patients with moderate to severe asthma. Patients were randomized to 0.2 milligram per kg ketamine bolus, followed by 0.5 milligram per kg per hour for 2 hours versus placebo. Pulmonary index scores were measured throughout the 2 hours and no difference was found. In 2001, prospective observational single-arm pilot study in 2 pediatric EDs over 3 months showed the effect of IV ketamine added to standard therapy in status asthmaticus was evaluated. Initiation of ketamine in patients with severe asthma was associated with clinical improvement. Side effects were easily managed with treatment or discontinuation of ketamine. Non-invasive post-pressure ventilation, like CPAP or BiPAP, pediatric studies are limited but suggest that it is generally well tolerated. Improved dead space, VQ mismatch, and gas exchange, decrease auto beep and work of breathing. The exact mechanism not really understood. Intubation and mechanical ventilation should be last resort. Invasive mechanical ventilation associated with high rates of complications and mortality, indicated in children with persistent hypoxia and responsive hypercapnia with change in mental status and respiratory fatigue due to increased work of breathing. If intubated, mechanical ventilation setting must allow adequate time for expiration due to air trapping from bronchospasm, like IE ratio should be adjusted to 1 to 4. Criteria for hospital admission. Frequent albuterol, generally defined as more frequent than every 2 to 4 hours. Having persistent hypoxemia requiring admission. Significant dehydration also require admission. Infection requiring inpatient treatment or monitoring. Medical history, cardiac disease that may impact the respiratory system. Criteria for safe discharge home, needing beta agonists less than Q4 hours after 4 to 8 hours of conventional treatments. A reading of SpO2 94% in room air, minimal or no signs of respiratory distress, and improved air entry. Discharge instruction should complete 2 to 5 day course of oral steroid. Prepare a written asthma action plan. Salbutamol until exacerbation resolved, then as needed. Inhaled steroids such as fluticasone 50 micrograms, 2 puffs twice daily for all, but the mildest of asthma patients seen in the ED. Review techniques for using inhaled asthma medications is important. Encourage follow-up with the patient's primary care physician or local asthma clinic to review asthma control, environmental history, and symptom recognition. When the patient should return to the ED, if needs salbutamol more than 4 hours, difficulty breathing, walking, or talking, if pulling in of skin between ribs, cyanosis, or audible wheezing. Feels and pitfalls. Asthma is a clinical diagnosis and routine imaging or testing is not required to make the diagnosis and should not delay therapy. Patient without wheezing may have more severe symptoms than those with wheezing, as these patients may have near complete airway obstruction. Early and aggressive treatment with steroid and inhaled albuterol is the mainstay of treatment. Delaying treatment can lead to increased morbidity. Intubation is indicated in patients with impending respiratory failure, not responsive to treatment. A trial of non-invasive positive pressure ventilation should be attempted in severe asthma exacerbation if possible. Thank you, and if there is any question.
Thank you so much, Dr. Marwan. جزاكم الله خيرا على المحاضرة. There is a question in the Q&A section. Can you see it?
Yes, from Dr. Ahmed Badair. Thanks for a great talk. How about nebulized magnesium sulfate for acute asthma? And should we continue controller therapy during admission for acute exacerbation? Regarding nebulized magnesium sulfate, there is no enough studies in pediatric population, up to my knowledge, and I don't know about adult population, but it is recommended as IV infusion of magnesium sulfate, which causes bronchodilation and improvement for respiratory status.
Okay, I think that's it. No more question. جزاكم الله خيرا دكتور مروان. Now we are going to have the Dr. Amal. Dr. Amal Youssef, we are very, very honored to have Dr. Amal with us in this seminar. Dr. Amal is the first certified Saudi female physician in pediatric emergency medicine subspecialty, and actually she is the first one in Gulf area. She is assistant professor in King Saud Ibn Al-Aziz University for Health Sciences. She is a senior pediatric emergency medicine consultant. She is section head in triage area and emergency department, and also she is the vice president of SASM. Very, very, very long biography. Thank you, Dr. Amal, and it's our honor to have you with us, and the floor is yours.
Assalamu alaikum. Good evening, everyone. Thank you so much for such an introduction for me. Thank you so much for the invitation, which I value very much, and it's an honor and pleasure to be among you guys. We're going to talk about the top 5 papers in PEM. There are a lot of top papers, but I tried to choose what might make a difference in our practice. So buckle up, it's going to be a bit of a rough journey there. Okay, so first one is going to be association of pre-procedural fasting with outcome of emergency department sedation in children. This study was published in July 2018. It's a huge number of study, and it made a big difference. The question was, and the key points of this, does the duration of the pre-procedure fasting alter the risk, pulmonary aspiration, and associated adverse outcomes in children undergoing emergency department procedure sedation? Now, that's a 6,183 children, healthy patients who undergone sedation in one of 6 geographically separate and nationally representative Canadian emergency departments. 2,974, which is around 48.1%, did not meet the fasting guidelines prior to the sedation. Data analysis failed to identify an association between pre-procedure fasting of any duration and any type of adverse events. And there were no cases of clinically apparent pulmonary aspiration. Now, the meaning that delaying sedation to meet established fasting guidelines appears not to improve sedation outcomes for children in the emergency department. And for us as an ER physician, the money comes in the time and the beds. Without both of them, you can't function as an ER physician. And again, the time waiting, especially with children. Remember, you're going to leave a child who's going to be fasting, which is depending on the age, how patient they can be fasting during this time. So the importance, there is no clear whether adherence to the pre-procedure fasting guidelines prevent pulmonary aspiration and associated outcomes during the emergency department sedation. So their objectives was, they wanted to see the association between the fasting time and the incidence of the adverse outcomes related to doing the procedure. And it was a large sample of children. So they conducted it as a planned secondary analysis of a multi-center prospective cohort study of children from 0 to 18 years of age who received procedure sedation for painful procedure in 6 Canadian pediatric emergency departments from July 2010 until February 2015. The primary risk factor was procedure, pre-procedure fasting duration. The secondary risk factors were age, sex, American Society of Anesthesiologists classification, pre-procedure and sedation medications, and procedure type. 4 outcomes were examined: the pulmonary aspiration, the occurrence of any adverse events, the serious adverse events, and the vomiting. Now, the results out of the 6,183 children, the median age was around 8 years, and they were healthy, 99.7%, or mild systemic, which is an ASA classification 1 or 2, and they were included in this analysis. 48.1%, which is 2,974, and 310, which is 5% of the children, did not meet the American Society of Anesthesiology fasting guidelines for solids and liquids, respectively. There were no cases of pulmonary aspiration. There were 11.6% adverse events, of which 68, which is around, were serious adverse events, and around 315 were vomiting. The odd ratio of the occurrence of any adverse events. Serious adverse events and vomiting did not change significantly with each additional hour of fasting duration for both solids and liquids. Now, what they have done, they have the tables to show about the factors that they were looking at. These are fasting for the solids who are more than or equal 6 hours, and this is the American Society guidelines. And these are the more than 2 hours or 2 hours for the liquids. And they were looking at the age group, the sex of the patients, the procedure types, the sedation medications, which was basically between ketamine, ketamine plus, propofol or propofol. And they looked at the ASA classification of these patients. Now, the characteristic of the patient who vomited, there were, the procedures were done was variable between foreign body removal, burn debridement, lumbar puncture, laceration repair, burn debridement, and orthopedic reduction. And it was basically all with ketamine. People who have been used. Some of them used opioids, some of them none, and some of them had an antiemetics before, but it did not vary between fasting hour and non-fasting. you could see children who have been fasting 13.9 hours, and for Solace 13.9 hours, yet they vomited, and children who have been fasting for not considered with the guidelines, and again, they were vomiting. They observed for the incidence of the sedation outcomes, and they were looking for the any events or any serious events and any vomiting. And their conclusion that, to our knowledge, our study is the largest prospective emergency department procedure sedation cohort with the most complete documentation of fasting status and the outcome assertments and most robust statistical analysis conducted to date. In this study population, we failed to identify any association between fasting duration and the type of adverse events. These results indicate that delaying sedation to meet established fasting guidelines does not improve the sedation outcome for children in the AD, and it is not warranted. I really think that we were doing this ahead of a time, long time ago, because sometimes we're restricted with time limits that we have to repair this laceration if the parents come in a time window that I have to do the 6 hours repair or something like this. And sometimes it's the bed occupancy that can push the limits sometimes the availability of the other subspecialties. So we were doing it, but we were not evidenced about it, and we were doing it with a big challenge and a medical legality. Now I think we can say that no, it's a big ode to the ER tigers who were doing this, but now we give you an evidence to say that's the message we can come from this. It does not have to meet the fasting criteria. If adverse effects is going to happen, it's going to happen. Let's look at the second study, and that's the clinical trial of the fluid infusion rates of pediatric diabetic ketoacidosis, the famous PCARN guys. And we were waiting for this study for long, ups and downs. It had been since the 2015 promise, but again, it was published in June 14th, 2018. And the background, diabetic ketoacidosis in children may cause brain injuries ranging from mild to severe. Whether intravenous fluids contribute to these injuries has been debated for decades. In fact, we came into medicine and we inherited that theory, that saying that will cause the cerebral edema in a DKA children. So they conducted a 13-center randomized controlled trial that examined the effects of the rate of the administration and the sodium chloride content of the intravenous fluids on neurological outcome in the children with diabetic ketoacidosis. Children were randomly assigned to one of 4 treatment groups in 2x2 factorial design, 0.9 saline or 0.45, half normal saline, and rapid or slow administration. So they were looking at the content or the concentration, and they were also looking at the how fast or how slow the administration. The primary outcome was a decline in the mental status, 2 consecutive GCS scores below 14 on a scale range from 3 to 15, with lower score indicating worse mental status during treatment of the diabetic ketoacidosis. The secondary outcome included clinically apparent brain injury during the treatment of the diabetic ketoacidosis, short-term memory during treatment of the DKA, and they had specific tests for it, and memory and IQ 2 to 6 months after the recovery from the DKA, just to see the sequelae this brain get injured. Out of 1,389 episodes of DKA, they were reported in 1,255, which means some of those kids really had a second attack of this episode during the time of this study, and they were included too. The GCS declined to less than 14 in 48 episodes, which is 3.5%, and clinically apparent brain injury occurred in 12 episodes, which is 0.9%. No significant difference among the treatment groups were observed with respect to the percentage of the episodes in which the Glasgow Coma Scale score declined below 14. The magnitude of the decline in the GCS score or the duration of the time in which the GCS score was less than 14. With respect to the result of the tests of the short-term memory or with respect of the incidence of the clinical apparent brain injury during treatment of DKA, memory and IQ scores obtained after the children's recovery from the DKA also did not differ significantly among those groups. Serious adverse events other than altered mental status were rare and occurred with similar frequency in all treatment groups. So they started with huge number and they got excluded some of them. Some of them they cut out because of not accepting to be there as in the study, or because of lack of some informations. And then they ended up with the 1,389 children, and they went into those 4 arms. Let's put the table of the 4 arms. So all the children received the 10 ml per kilo bolus of 0.9 saline over 1 hour as a standard. And this is all the 4 arms. Now, the additional intravenous fluid boluses were given in 2 arms, 10 ml per kilo of 0.9 saline solution, and the 10 ml per kilo of 0.9 solution. This is for the fast administration, and this one for the slow administration. This is the 0.45 fast, this is the 0.9 fast, this is the 0.45 slow, this is the 0.9 slow. So in the 2 fast groups, they received additional bolus. In the 2 fast and the 2 slow groups, they did not receive any additional bolus. And all of them were counted between the fast ones around 10% of body weight dehydration as a deficit, and the slow ones about 5% of the dehydration. And during the initial 12 hours, they replaced half of the deficit plus the maintenance fluids, and then the rest was replaced over the coming 24 hours. The slow group, whether the half or the full saline, they received unanimously all the amount of the deficits equally over 48 hours. And they used the fluid replacement here as a 0.45 saline and in the half saline, and 0.9 saline in the 0.9 saline, and again half and 0.9. And they looked at all the events and as a primary outcome, which is any evidence of the decreased GCS or a brain injury during the incident, and they looked later on about the evidence of the brain injury. And they looked at the outcomes to see any significant episodes happen. So they have some confirmed decreased GCS, as we mentioned, and that was the primary outcome. And it was not statistically different between the fast or the slow, the high concentration or the low concentration. And then they looked at the apparent brain injury with a short IQ and the long one, which is the 2 and 6 months after the discharge. And they were looking at the variables, which was any adverse events happens, any serious, any outcomes about the recovery, any deaths occurred, and it only occurred in 1 person. They looked at the severity of the events, and they looked at the other clinical adverse effects. The commonest as a presentation was the headache, and then some of them, they had the oropharyngeal pain, pyrexia, abdominal pain, and constipation. That was the commonest presentations to come in. They concluded neither the rate of administration nor the sodium chloride content of the intravenous fluid significantly influenced neurologic outcome in children with the diabetic ketoacidosis. So the message is hello facts and goodbye myths. Having said that, none of the guidelines internationally, including ours, have changed anything from what we have. We still give the basic bolus. We still don't exceed the 10 ml per kilo, and every almost guideline says don't ever give the 20 ml per kilo unless the patient is having hypotensive shock. Yet that study strongly says if you give it fast or slow, if you give concentration, but the amount was also, they were not that liberal with it. So until the moment, we are playing it safe. It's still doing fine. But it gave us a window that for the children who are very dehydrated and you're looking for another bolus, given another 10 ml per kilo over 1 hour is not going to harm a child and probably will do good, not bad. Third study would be, let's see. The third study is talking about 2,495 children, grafting requirements in pediatric burns. The first statement when you look at that study say, what are we doing with this as a pediatric ER? But I will tell you, this study was published in January 2020, almost a year ago. And it says cool running of water would minimize the skin grafting requirement in pediatric burn patients. So the first aid guidelines recommend that you administer a cool running water in the early management of thermal injury. Now, people have been variable, and when they reviewed these people, the literature, they found some people are different in their guidelines. Some of them, like the Australian people, would say around 10 minutes. The others would say 5, in UK around 10 minutes. But no one had a real evidence-based block or cornerstone to say it. The studies of doing this was a couple of studies on adults, and they did not really look for what this study looked at. So the objective was to analyze the association between the first aid and the skin grafting requirements in children with burn. And when we say skin grafting, it means the degree of the burn was worse, the healing was not doing very well, and the morbidity of that child to develop infections with skin grafting, with the scarring is really high. So this is a cohort study. They used a prospective collective registry of patients managed at the tertiary children's hospital. Multivariate logistic regression modules were used to evaluate the relationship between the first aid and the requirement of skin grafting. Secondary outcome included the time to reepithelialization, the wound depth, the hospital admission, and the length of stay, and the operating room interventions. Adequate first aid was defined as 20 minutes of cool running water within 3 hours of injury, which means it's hours as an ER. And probably as a paramedics and EMS are the first responders. So the result of 2,495 children, 90.6% received first aid involving running water, but only 71% were given the adequate duration. A total of 236 children, which is 9.5, requiring grafting. The odds of grafting were decreased in the adequate first aid group. And the provision of the adequate running water was further associated with the reduction in the full thickness depth, hospital admission, and operating room intervention, but not the hospital length of the stay. So in conclusion, burn severity and clinical outcomes improved with administration of cool running water. Adequate first aid must be prioritized by out of hospital and emergency medical services in the primary management of pediatric patients. So it's our job even for spreading this message and encouraging people. Instead of people are coming and putting some ice, some of them they put the toothpaste, some of them put the local herbal stuff or the Meebo cream. Maybe if that family just ran the cold water in there and left it for a good 20 minutes, they would have done the best for their child. What is already known for this topic, many guidelines recommend irrigation with cool running water for 20 minutes duration after burn. What the question of this study addressed is there is association between the 20 minutes of cool water running within 3 hours of the injury and the skin grafting requirements in children with burns. And what this study adds, and to our knowledge, in this cohort study, the odds of the skin grafting were decreased among children who had the good 20 minutes of cool running water. And how this is relevant to the clinical practice, although the study established only the association in the absence of better evidence of first aid guidelines, physicians should promote for the 20 minutes of cool water irrigation for burns in children. So they had these children, and some were excluded as a mist, and some of them refused to be. The rest of them agreed, but some of them were excluded because they were non-thermal injuries and they were not sure of the first aid. And the rest of them were included, which is the 2,495 children. And this is, they had the adequate first aid, which is the more than 20 minutes within the 3 hours, and the rest were not. And they put them in tables looking at these, some of the demographic data, looking at the sex, looking at the mechanism of injury, the place of the injury, the body part got affected, the total body surface area percentage affected, and the wound depth of the patients. And they looked at what they were looking primarily about it was the skin grafting. And then they looked at the secondary ones, which is the depth of the injury, the hospital admission, the operating room intervention, and the time of rehabilitation, and the length of the stay on the hospital. Now, the length of the stay did not go different in both of them, but the other factors were really different. And they did all their analysis about it. And they looked at, they put the regression analysis module to see how things are. And in summary, this study showed significant improvement with cool running water first aid in the injury severity and the clinical outcomes among children post-burn. The provision of adequate first aid consisting of greater or equal to 20 minutes of cool running water within the first 3 hours of the injury. And it was highly associated with reduction of the skin grafting, as well as fasting re-epithelialization among burns with which wounds closure were more protracted, and decreased the odds of full thickness depth, hospital admission, and operating room interventions. So if we have anything to say, when knowledge makes a difference, can I spread this knowledge? In fact, I'm looking forward to be on a brochure for the parents. I'm looking forward to be on the site of the Ministry of Health of our countries to say what to do. And I'm looking at it to small educational videos while waiting people for their appointments, just to tell the people, stop putting anything, stop getting busy to find something to put it in a burn. Just put that child on arm or leg or whatever they got burned at, running a cool water for a good 20 minutes before you come to us. Then we can take it from there and we can do more after that. Now, the fourth is doing the LP in a well-appearing young infants with a positive urine analysis. Now, the thing have been going for the last 1 or 2 years is the neonates and the neonatal fever, and should we do this, should we do that? And everyone agrees in the first month, we all said it, is gonna get the full package, complete sepsis workup, including LP, regardless of the source of the infection. These guys came and says, well, we can do a bit of discount on something different in the first 30 days if we have a positive urine analysis. So to determine the factor associated with the cerebrospinal fluid testing in febrile young infants with positive urine analysis, and to assess the probability of delayed diagnosis of bacterial meningitis in infants treated for urinary tract infection without CSF testing. So the method they did, they performed the retrospective cohort study using data from reducing excessive variability in infants, sepsis evaluation, quality improvement project. A total of 20,570 well-appearing febrile infants from 7 to 60 days old, presenting to 124 hospitals from 2015 to 2017 were included. A mixed effects logistic regression was conducted to determine the factors associated with CSF testing. Delayed meningitis was defined as a new diagnosis of bacterial meningitis within 7 days of discharge. So overall, 3,572 infants had a positive urine analysis. 70.3% went under CSF testing, because this is what every criteria says. Rochester, Philadelphia, Boston, even in the beginning of the PCAR, everyone says in the first 30 days you do, and some of them plus or minus the 60 days, you do the full package. There was wide variability by site, with the CSF testing rates ranging from 64% to 100% for infants 70 to 30 days old, and 10 to 100% for infants 31 to 60 days old. Factors associated with the CSF testing, including the age, 7 to 30 days, adjusted odds ratio, and abnormal inflammatory markers, site volume, which is more than 300 febrile infants per year, which is the site volume for that center or that ER. And among 505 infants treated for UTI without CSF, there were 0, and I say 0 cases of delayed meningitis. So they had the 20,570 well-appearing children, 18,379, which is around 89.4%, received the urine analysis prior to the decision to admit or discharge from the ED. 3,572, 19.4, had a positive urine analysis. 2,511, 70% of them had the CSF testing. 1,061, which is 29.7, did not have the CSF testing performed. And they put them in tables and looked at the demographic data, looking at the age, the sex, the abnormal inflammatory marker, the hospitals, which is affiliated with what, and the urban setting or the annual volume of the febrile infants and the region. And they did their statistical testing for 0 to 30 and from 31 to 60 days. And among the tables, they looked at the factors associated with the CSF testing, and they ended up having 1,061 infants with positive urine analysis. 69.2% received empiric antibiotics, 505, 68% treated for UTI, 0 infants with delayed meningitis, from 0 to 30 with 0 of 98%, and from 31 to 60 days. And 229, which is 31.2%, not treated for UTI, 0 infants with delayed meningitis. So when they looked at the length of the stay, the median disposition, the discharge from the ED, how long admitted, below 48 hours, 2 to 6 days, 7 to 13, some of them went to 14 days, like empirically treating as meningitis, and they looked at them to see the ages of the children. Their conclusion that there is significant variation in the CSF testing among febrile infants below 60 days of age with a positive urine analysis. CSF testing is more likely in infants between 7 to 30 days of age, those with abnormal inflammatory markers, and infants evaluated inside with high annual volume of febrile infants. There were no cases of delayed diagnosis of meningitis within 7 days of discharge in this large multi-center cohort of well-appearing febrile young infants treated for UTI without CSF testing, most of whom were 31 to 60 days, suggesting that CSF testing may not be needed for all infants with a positive urine analysis in 31 to 60 days of age. Additional large studies were needed for further elucidation of the risk and benefit profile for the CSF testing. Having said that, definitely below 30 days is still the gray zone, despite that we didn't have any. But again, everyone says below 30 days or below 28 days, they get the full package. But between 30 to 60, now we started the bargaining about and the discount of it. And that study says between 7 to 30 days, they did not even have any, 0 meningitis for any kid who had a positive UTI. So there was a wide variation between CSF testing with a positive urine analysis, but they think that there were no cases of delayed meningitis, and they can say, we suggest that routine CSF testing for infants 31 to 60 days with positive urine analysis may not be necessary. Having said that, I'll be very clear. These are well-looking appearing infants, but they only hit your ER or your center with fever, which we don't like in this age and we always get worried about. Having said that, puts you in a dilemma to be or not to be. That's the time when I say, take it or leave it. But the study is fair enough to say, okay, from 30 to 60 days or 31 days to 60 days, probably we do not need a CSF if we have a positive urine. Last but not least, these are the associations, the mortality associations of the risks with the mortality risk of children with the pan-CT or a whole body CT. Now, that was published in JAMA June 2018. And the reason I picked up this study, we're the country #1, unfortunately, for trauma MVAs. We're considered #1 for the children's MVAs and head injuries, unfortunately, in the G20 countries. And it's very easy. The tip of your finger, you just snap your finger and you can get a pan CT in any place. The problem is, am I doing good or harm? Sometimes not doing good is not the main thing, just don't do harm. So the question was an emergent whole body computed tomography associated with lower mortality rate of children with blunt trauma compared to selective computed tomography. Probably it's a good intention always if it is done or asked for. I'm not intimidating anyone. The thing I'm saying is you want to know everything in that guy from head to toe to make sure that you didn't miss anything so they don't get a risk of non-diagnosed or undiagnosed hidden something. The finding in this propensity weighted study using records from a national trauma data bank of 42,912 children, there were no significant difference in mortality between children with blunt trauma who received emergent whole body computed tomography and those who received a selective computed tomography approach, meaning the results of the study raised the question about the routine indiscriminate use of the emergent whole body computed tomography for children with blunt trauma. It's very well known that we do it in adults and is done in adults, but in children, I know that most of our data of children unfortunately extrapolated from adults, but they are not small adults. They are different than the adults. So we can't apply everything and all the things for them. So it's better we go with the selective computed tomography. So these guys looked at this data to answer that question for us. Is it worth it that I snap my finger and just get a pan CT or a whole body CT? So although several studies have demonstrated an improvement in the mortality for injured adults who receive a whole body computed tomography, so that's the real fact that made us go for this. But it's unclear whether children experience the same benefit. So the objective there were to determine the emergent whole body CT in association with a lower mortality rate among children. Can we do the same like children, like adults with the blunt trauma and save more lives? So they designed the setting and the participants. It's a retrospective multi-center cohort study conducted from January 2010 to December 31st, 2014, using data from the National Trauma Data Bank on children aged 6 months to 14 years with blunt trauma who received an emergent CT scan in the first 2 hours after emergency department arrival. The data analysis was conducted from February 2nd to December 29th, 2017. The exposure patients were classified of having a whole body CT if they received the CT scan, head, chest, abdomen, pelvis in the first 2 hours, and as having selective CT if they did not receive all 3 scans. So among 51,793 children with blunt trauma and emergent CT performed in the first 2 hours, 8,881 excluded, 8,871 transferred, 10 were missing their mortality outcome. So they ended up with the 42,912 study sample, 8,757 whole body CT, God bless us and bless them, and 34,155 selective CT. The main outcome was in-hospital mortality in the 7 days after ED arrival to adjust the potential compounding and propensity score weighing was used. The subgroup analysis were performed for those with highest mortality risk, occupant or pedestrian involved in a motor vehicle crash, children with the GCS score lower than 9, and with children who have hypotension and those who are admitted to the intensive care units. The results out of those 42,912, you've seen how many of those have received whole body and how many of those have received selective. After adjusting for the propensity score, children who received the whole body had no significant difference in mortality compared to those who received selected CTs. All subgroup analysis similarly showed no significant association between the whole body CT and the mortality, like in the adult study. So these are the numbers of the whole body, these are the numbers of the selective, and this is the adjusted sample. And they looked at the mechanism, the motor vehicle, the pedestrian, the motor vehicle occupant, They looked at the high-risk ones with the score of a GCS below 9, the hypotension, and the children who were admitted to the ICU. And they looked at also some other data looking at the AD length of the stay, and they looked at the total hospital admission of those patients. And their conclusion, in this large multi-center study of children with blunt trauma, emergent whole body CT was not associated with lower mortality rate for children with blunt trauma compared with selective CT. This outcome was consistent regardless of how severely injured the children were. These results have implications of how emergency and trauma specialists care for injured children. Although a whole body CT may provide more information about the injured child, that information does not appear to be a life-saving. With growing concerns regarding the excessive radiation exposure for injured children, physicians should attempt to limit CT exposure whenever possible. And I'm just so enthusiastic about this because I'm a person who's very hard to get a CT done for a child. I don't pay for it and I don't have any benefit for this, but I will never forget the figures in my mind of saying, and that's an evidence-based level 1. In a child who's 10 years and below, any CT of the head, 2 CTs in this age are fair enough to raise the chances of bone cancer and leukemia 3-fold. And I didn't say percent, I said folds. So if they come from a genetic background family, that they will have 1% leukemia or bone cancer, it will be 3. And if they come from a family background of 10, for God's sake, I made it 30%. So I took it very strongly for this. And that among children with blunt trauma, a whole pan CT or a whole body CT compared with a selective CT was not associated with lower mortality. And these do not support routine use of whole body CT regardless of the severity of the mechanism. Examine them, let the clinical sense talk on its behalf, and whatever they pronounce or show you sign and symptom, that's the time when you ask for the selective CT for that person, for that site. Having said that, I would urge and say, please be beneficent, not maleficent. And by this one, I conclude the 5 running journeys of those papers. I'm ready for any questions.
Thank you so much, Dr. Amal, for this wonderful talk. Actually, the 5 papers were about very controversial topics, and we have one question here: at what degree was the water, or at what degree was water recommended? I think he's talking about the paper in which
yes, yes, and the agreement was opening the tap water on a normal temperature, the cold temperature water is fair enough to be considered cool water. The preference was running it continuously, thinking that some people might fill a basin, fill a bowl of water and put the hands in there. They said running continuously is way better. So it's a simple, straightforward, regular cold tap water. I'm not with the tap water of ours in July and August. I meant the regular normal tap water, right? And it should be for 20 minutes, and it should be in the first 3 hours within the injury or the burn happened.
Thank you so much, Dr. Amal. Jazakumullah khairan for this wonderful talk. Now we are going to Dr. Khalid Atiyah.
Thank you so much. It's an honor.
Thank you so much.
Thank you.
Dr. Khalid.
السلام عليكم.
وعليكم السلام ورحمة الله.
مرحبا دكتور.
Thank you, Dr. Khalid, for being with us today. Dr. Khalid is a very, very dear friend and colleague and one of the seniors in Madinah. Dr. Khalid is a consultant of emergency medicine and one of the leaders, or maybe the most important leader, especially in teaching and training and education in emergency medicine in Madinah. Thank you so much. We are going to have you in traumatic brain injury in this talk. The floor is yours, sir.
So thanks a lot for the introduction. I'm not senior at all in the presence of Dr. Osama, Dr. Amal, and I hope we can enjoy this talk because we have unexpected emergency from other colleagues, and we'll cover their part by this presentation. So today we're going to talk about the head injury, and we'll have some of the controversy over there, and let's clear some concepts regarding the head injuries. So I have no disclosures. So in general, we're going to review the overall management of the traumatic brain injury, and why should we go for CT in a mild, or when should we do that? So the International Brain Injury Association stated that the brain injury is the leading cause of death and disability worldwide. And about half of the patients die from the traumatic brain injury within the first 2 hours after the injury. So it is a significant and devastating injury in general. Regarding the epidemiology, as you see, 47% of all the cases are due to falls, and these falls occurs mainly in the elderly. And they have calculated around 1 TBI every 3 minutes. Regarding the motor vehicle accident, we're the highest in the young age, 20 to 24 years of age, which is considered economically costly. And why is that? Those are young and healthy people, so they get admitted to the ICU with a severe injury. They don't die. They don't die. And they stay for a long time, and they cost the government a large amount of money. And they found that the incidence of the TBI, the greatest in 0 to 4 years, and the child abuse was more in the less than 2 years old, and in adults, more than 65. One minute, please. Sorry for that. So we're going to review now the management of the traumatic brain injury. So we have an initial primary injury and subsequent secondary injury. You have nothing to do with the primary injury. So from our point of view as a physician, it's really difficult to intervene in the primary injury unless you work in a community or preventive medicine. Then you can help in that. Otherwise, nothing to do. But for the secondary injury, we have something that we can help the patient with. So they divided the primary brain injury into 2 main parts: closed head injury or penetrating head injuries. Penetrating, we have a bullet, which causes a massive destruction, or a knife, which causes a minimal mass effect, but it depends on the knife size. So there is the patient to infection and CSF leak. Here is a simple explanation to the primary brain injury. The concept of COB, counter-COB mechanism, that we need to understand that the patient might have, as shown here in the picture, an impact direct impact would have a COB injury, but in the same time, you need to study carefully the opposite part of the injury, which is called the counter-COB injury. So you might have a finding of those areas, both areas of injuries. And of course, the diffuse axonal injury, which is the hallmark of the severe TBI, in which you don't have a specific finding other than loss of association, loss of differentiation, and maybe some petechial marks in the brain CT, but the patient GCS is very low. What are the outcome predictors for TBI? They found hypotension is one of the most important things that would affect the outcome adversely. Old age, male gender, associated fever or coagulopathy, or if the patient have any cranial abnormality, something like olfactory, trochlear, abducent, or facial, those are the more common. Low GCS is directly correlated to low, bad outcome. Fibrillary status will give you some examples now. Time to surgery and hematoma size, there is some controversy regarding the surgery. So the classic classification of the TBI, they classified into mild, moderate, and severe according to the GCS level. Mild, it has to be more than 13 GCS, moderate 9 to 12. But why it is important to know those classification? Because if the patient is in moderate, we cannot take this lightly or underestimate the injury, because they have a more than 12% chance they will progress to severe brain injury. So they have a high chance of intracranial hemorrhage anytime. Regarding the severe, you need to admit them, you need to have an ICP monitoring, and they might go to the OR anytime. We have something called the SMS, which is the Simplified Motor Score. The beauty of this score is that it's easy to remember at the time of accident. If you have a mental block or you forgot what to do, you can just simply use the SMS, which is simple 3 parts. If the patient obeys commands, we'll give high score, 2 points. If the patient localizes pain, we'll give him only 1 point. So it's abnormal, it's less than normal. Or if the patient has something worse than localizing, so withdraws to pain or anything worse, so you don't really need to remember the much details. So anything other than localizing or obeying command will receive a 0 points. So what's the benefit of this SMS? Why we mentioned this? So they did a comparison between the GCS and the SMS from the outcome point of view. And they found that the correlation between the outcome of high or low SMS and low GCS is exactly the same. From the brain injury point of view, from the emergency intubation, surgical intervention, and survival. So it's okay for you to substitute the SMS for GCS. Okay. When we think about the TBI management, you have tons of things that comes in your mind, with things that you think about, which things that you need to treat, how you will do the best management of each, from the temperature control, CO2, hypoxia, which medication to intubate, what about the CCB, the cerebral perfusion pressure, and what you do with the increase in intracranial pressure. Let's see. So we divide the management into 3 main parts. I will give you solid concepts regarding the overall management. So pre-hospital, our colleagues, paramedics, what they need to know. In the emergency, what should we do? And when the patient goes to the critical care. So please, in the pre-hospital setting for our colleague, paramedics, I just want them to take the management very simplified. They need to fight hypoxia and hypotension as much as they can. This is the main focus, the main idea. They should fight hypoxia and hypotension as much as they can. Why? Chestnut and colleagues did a study, and as you see here, patients with hypoxemia only have a 33% chance of mortality. And if they get hypotensive, they get 60% chance of death. If they have both hypoxia and hypotension, they have a 75% chance that they will die. So from the pre-hospital point of view, we need to fight and prevent hypoxia and hypotension as much as we can. The other thing that I want to add to you here, please do not bother yourself intubating the patient pre-hospital. You're wasting your time and you are not doing a good favor for the patient. So one group, they did a study and they found that intubation pre-hospital increases the mortality fourfold than intubating in the emergency. So please, you go with our sort of strategy, scoop and run to the hospital, do not stay and play. So we go with the North American school that we don't treat the patient much in the pre-hospital field. We just do the most important intervention, then we just rush the patient to the hospital. And this is proven by studies, and this is one of the studies. So we can ambubag the patient, deliver oxygen any way we like, at max, we can put the LMA or King's airway, but do not waste your time intubating the patient. You are not doing a favor for the patient. So in the emergency department, we have the same principle. We have to ensure brain perfusion and oxygenation at the same time. So understanding the cerebral perfusion pressure is very important concept that we need to understand. So keeping the normal cerebral perfusion pressure is between 50 and 70. The MAP needs to be more than 60, but less than 110. And they found that if the MAP drops below 50, the risk of brain ischemia increases. The issue with the traumatic brain injury is a vicious circle. So if the patient has high ICP, it would decrease the perfusion, it will worsen the ischemia, ischemia will cause edema, edema will lead to more increase in the intracranial pressure, and the cycle goes on. So what we have from the emergency point of view that we need to calculate the MAP and go according to the MAP until we can have something that would measure the intracranial pressure for us, like a VB shunt or whatever. So those are the ways that you can have to calculate the MAP, either the diastolic pressure plus 1/3 the systolic minus the diastolic, which is the pulse pressure, or 2 multiplied by the diastolic pressure plus the systolic pressure divided by 3, or you can do the 2/3 of the systolic blood pressure plus the 1/3 of systolic blood pressure. They give you a hint about the MAP. Good. Herniation, there are many types of herniation, and it is of the things that we are worried about during the traumatic brain injury, and we look for their signs. You have a cingulate, transtentorial from the central, transclavicular, an ankle herniation, upward cerebellar and downward cerebellar. So what are the signs that might predict a herniation? And pupillary abnormality. This is why it is very important to check pupils very early in any patient with traumatic brain injury, even before intubation, before A. So you check the pupil before intubate the patient, and check the CNS level of consciousness before you tube the patient. So that would help later on. So if it is dilated and reactive, or reactivity is less than 1 millimeter, so this is a bad sign. Or if the difference between the two eyes are more than 1 millimeter, so it is again, it is a sign of possible herniation. Or the posture, if the patient is decerebrating or decorticating, it's another sign that you need to be considered. Okay. So here, I want to bring your attention to this sign. So hematoma in the middle cerebral cranial fossa, here shown, can cause herniation without a rise in ICP. So be careful when you do CT and you find this patient with this kind of hematoma. So sudden rapid decline in the GCS, drop in the GCS more than 2 score would give you also a sign of herniation. Caution phenomena, which is not that common, but it is hypotension and brady. I mean by brady is bradycardia and bradypnea or variable respiration. So those signs that might give you a reflection of high ICP impending herniation. So those are some of the signs that you need to review and consider. Change in the pupils, eye movement, the pupil edema, and posturing. So in general, the management of the high ICP, we summarize it in every H that comes in front of you that you have to treat. And we'll discuss it in detail right now. So we have, number 1 is hypoxia and hypotension, as being explained in the study. So prevent hypoxia, prevent hypotension as much as you can. I mean by hypoxia, something less than 90. Otherwise, also hyperoxia will harm the patient. So do not over-oxygenate the patient. Yes, we should fight hypoxia, but do not expose the patient to excess oxygenation. Same thing, hypotension, we need to fight, but do not do permissive hypotensive strategy that we do in some trauma cases. In patient with associated TBI, don't do the permissive hypotension protocol. In the same time, also hypertension will be harmful for the patient, but it's not as important as hypotension. Same thing, the hypercapnia, as you all know, we hyperventilate our patient initially. It is helpful in the first 30 minutes to 1 hour only. It will not help after that. So why we fight hypercapnia? Because it increases edema. So we need to do the pseudo hypocapnia or intentional hypocapnia, iatrogenic hypocapnia to cause vasoconstriction of the vessels. But it should not exceed 30 minutes in total, this hyperventilation strategy. And the CO2 should not drop below the lower normal, which is 35, should not drop, because you might risk the patient for ischemia and decrease. Hyperthermia is not good for the patient, as we said, fever. So we have to really consider normothermia for the patient. And hypothermia did not prove that it is that much effective for the management of TBI. Again, to continue with the HHH management of the traumatic brain injury, hypohemoglobinemia, so anemia, the hemoglobin should be at least more than 7. Hyperglycemia, both of them are not good. Euglycemia is the best. Hypervolemia, so the patient should not be over-restricted with fluid and should not be left dry. Any electrolyte abnormality, any hypernatremia, hyperkalemia, just name it. Or acidosis, either excessive alkalemia or acidemia. Positioning of the patient, they found that if you elevate the bed 30 to 35 degrees, it might help in decreasing the risk of hypoxia, decrease the VQ mismatch and ventilation mismatch, and decrease the ICP, and improve the respiration functional capacity, improve the cerebral perfusion pressure, and will help and aid in the venous drainage. And we'll mention more details about that one. So as you know, in trauma, sometimes we cannot elevate the head of the bed because of the risk of associated vertebral or spinal cord injury. So we can do the reverse Trendelenburg for the patient in order to achieve the 30 to 45 degrees, and which would help the patient from those aspects. Regarding the venous drainage, you can improve the patient venous drainage by keeping the C-collar on, but make sure it's not tight on the patient neck and in the just placed. And we avoid an internal and external jugular lines, those patients, subclavian, femoral, whatever. And when you tube the patient, don't forget that your tie should not obstruct the venous drainage. From the osmosis point of view, I just want you to remember this picture that hypertonic saline is favorable over other osmosis. And it's very simple and safe. 3% hypertonic saline over 30 minutes. It's a safe and small dose. Make your threshold of using this hypertonic saline low. So order it quickly and do it timely. It's preferred to be done before intubation, and you can tolerate hypernatremia up to 155 to 160. It can be tolerated. And as you know, the mechanism, it would act as an osmotic, so it will withdraw the fluid from inside the cell and decrease the cell swelling that happened due to trauma and ischemia. The other osmosis is what? The mannitol. Although we have all these points regarding the mannitol, still it is #1 medication used in trauma, in traumatic brain injury. They are not deviating. They are not considering those factors. So you should not be using mannitol if you have another associated injuries. It's not isolated, head injury. You should not be using prophylaxis. And we don't use it in hypovolemic patients, and most of our trauma patients are hypovolemic, severely injured patients. And you need to monitor ICP when using the mannitol. It might risk the patient for hyperosmolar state. And of course, it might risk the patient for renal failure, rhabdomyolysis, and hemolysis. What is the sweet potato doing here? What is the relation of sweet potato and mannitol? Yes, they found that sweet potato contain a large amount of mannitol. So we can remember the sweet potato is a true mannitol. And of course, there is too much sugar there. So you are supplying the patient with the too much sugar, and you know, it's a diuretic effect. So be careful with mannitol. And hypertonic saline is superior to mannitol, although there is some controversy, but we have some limitation of mannitol use. Regarding oxygenation and fear of hypoxia, you need to consider dual oxygen supply to prepare the patient for intubation. So you minimize the risk of hypoxia as much as you can. And see what we do, usually, not only for traumatic brain injury patients, but for most of our sick, difficult intubation patients, we do a dual oxygen supply. And look carefully here to this picture with me. We have non-rebreather, high flow, with a nasal cannula in the same time. So we're supplying the patient with a dual oxygen source. And when we come to intubate the patient at the time of passing the tube or just before, you know, manipulating the airway with the laryngoscope, we take off the non-rebreather mask and we replace it with the ambu bag, but still we keep the nasal cannula running, attached there, and the oxygen running with a high flow. And even at the time of manipulating and doing laryngoscope, the nasal cannula should be running there until you have the tube passed the patient, then you can take off the nasal cannula. But we do the dual oxygen supply in order to minimize hypoxia during intubation as much as we can. And you know how much dangerous is the hypoxia for traumatic brain injury. For emergency intubation, we might prefer ketamine for induction because it might improve the CCB, but anyway. There are some studies that said that it increases the ICB. So it depends on our situation, but it is favorable in the appropriate situation, I would say. Non-debriding agents, it's no doubt preferred over the debriding agent, the succinylcholine, of course, I mean. So vicronium, bricronium, or pancronium is better than succinylcholine. And if you want to sedate the patient, of course, we put the patient on propofol sedation to calm the brain. So monitored, gauged doses to monitor the patient after intubation with propofol is better. From the catecholamine point of view, they found the phenylephrine gives higher MAP and improves the CPP. Some studies found that it is better than dopamine or epinephrine. Tranexamic acid, if it is used within the 3 hours window of injury, they found that it reduces all-cause mortality and progression to intracranial hemorrhage. It was reduced, yeah. So what medication should we avoid? Please, the succinylcholine, the debriding agent, needs to be avoided. Forget about steroids and albumin. It's been very well studied and found to have no benefit. Albumin even did harm for the patient, and they cut the study. They stopped the study in the middle because it is harming the patient. Progesterone is the same, has no benefit, and intensive insulin therapy also has no benefit. So please don't waste your time giving your patient those medications. Prophylaxis for seizure in TBI, it is more considered in pediatric than adults. With any bleed, intracranial, subarachnoid, epidural, anywhere, you might consider yes prophylaxis. Any fracture, even linear skull fracture, penetrating injuries, and if the patient has non-seizure disorder, seized at the scene, seized at the hospital. So the patient can benefit from the seizure prophylaxis. This is a study done and found that level 1 recommendation is phenytoin is superior to other antiepileptic for the seizure prophylaxis. So what do I need to have from the neurosurgeon in the emergency department? So I really need them early if they would take the patient to the OR and do craniotomy, in which, surprisingly, it is controversial. They found that people or patients do worse when they get operated in some brain bleeding. So it is really debatable. So they need to really choose the appropriate patient. This is not straightforward. Any bleed, even it is approachable, it won't have the good outcome. So it depends on the amount of injury that the brain tissue had. But VB shunt can help us to monitor the ICB and to have a good knowledge about the cerebral perfusion pressure. EEG monitoring is really critical and important, especially if the patient stayed long time in the emergency. We might start it there for the subtle or non-convulsive seizure that we need to avoid. Bladder pressure, urinary bladder pressure, to monitor the intra-abdominal pressure. What is the relation of that? How far is the bladder from the brain? No. They have a correlation between increased intra-abdominal pressure and increased ICB. So it is correlated. So the most sensitive, or one of the most sensitive procedures that you do to measure the intra-abdominal pressure is doing the urinary bladder pressure. To monitor that one, it is simple. They do it with the Foley catheter, and it is simple, but it is inserted in the urinary bladder. So measuring and monitoring the blood pressure, it is correlated with the increase in the ICP. If the intra-abdominal pressure is increased, most likely the ICP is increased. This is another study that they found that beta blocker is around 2,250 patients were studied. And they found that in 15 trauma centers in Canada and America, and administration of beta blocker found to have improved survival in those patients. Anyway, this needs to be reviewed carefully. Here I'm gonna discuss with you the CT in a mild head injury. Why did I choose mild head injury? Because the moderate and severe cannot be discussed. CT brain is a must in those patients. We don't need to discuss, we don't need to debate, we don't need to prove it. Any moderate to severe injury of the brain need to be CT'd or imaged. But the controversy and the debate and the confusion comes with the mind. Let's see what we have. See, this is the amount of recommendation that we have, tons of recommendations. And you need to remember all of them so you can give your patient the best outcome. And this is the clinical decision rules that you have everywhere. And each study is stronger than the other study. And they did the comparison between all the studies. And the difference is minute, and every area or every country is using their own decision rules. And this is the guidelines. Also, just name it. Tons of guidelines. I don't want to mention even their names, so I will not make make it complex for you or confusing. I intentionally did not want to mention. You can just go back to it and you find it. It is accessible and available everywhere. You can just simply use the Bean and Bash mnemonic to review your patient and decide about doing CT or not. And they found that applying Bean and Bash have a sensitivity of 98.3% and a negative predictive value, which is the one we are really looking for, is of 99%. So what does the Bean and Bash says? If the patient has any behavioral abnormality, emesis, vomiting, age more than 65, any neurological deficits, or the patient have a bleeding disorder, hemophilia, von Willebrand, whatever, altered mental status by any means, skull fracture, or hematoma in the skull. Those patients, you can't just CT them. Given the fact that they have mild head injury, that means their GCS is more than 13. If it is mild head injury and the patient has none of those, the patient can be discharged safely home without doing CT. Just remember Bean and Bash, and you can apply it. It is validated. What about pediatric? I'm really sorry to talk about pediatric patients having our teachers here. But anyway, let's see what they say here about that. It's same thing. They have tons of clinical decision rules, tons of them. But we prefer the BCAR. So the BCAR is the biggest and the largest association that is looking for tons of things. One of them is the traumatic brain injury. And as you know, we have the famous less than 2 years protocol and more than algorithm and more than 2 years algorithm. When I face a patient with pediatric patient with head injury, I open this table and discuss it with the family. I explain to them everything in the table, including the percentage. I would say 4.4%. And if the patient have no to all those, I would say you have chance of less than 0.02% of clinically indicated traumatic brain injury. And I explain to them what we mean by clinically indicated. Actually, I tell them in words. If you go to a private hospital and you do a CT brain for your child for self-satisfaction, you might have an abnormality in the brain from the trauma itself. But I can't promise you that this is an injury that does not require operation intervention, does not require admission, does not require medical management. So this is very important that I explain to the parents when I discuss with them the BCARN algorithm of pediatric less than 2 years. The other thing that I mentioned to my colleague regarding the children less than 2 years, there is no mention of vomiting here. Look at this. No vomiting, no vomiting. But still, I would put here MD experience. If the patient has an intractable vomiting after traumatic brain injury, I would consider this in my arm of observation versus CT. But I should not be obsessive regarding and worried about 1 or 2 times vomiting after mild head injury in those age group, less than 2 years. After, of course, careful evaluation and careful assessment. If you cannot remember the item that need to be done and you don't have your app with you to open the algorithm, just remember scalps. This is a mnemonic to remember the important thing that you need to do for pediatrics. So scalp hematoma, except the frontal area, caregiver concern, and alter level of consciousness, loss of consciousness more than 5 seconds, not 1 to 2 seconds, bulbar skull fracture and severe mechanism. So this would help you to make a decision. If you have any of those positive, you need to CT the patient if you cannot remember the BCARN algorithm. This is the one again, more than 2 years. It's almost the same, but I added here to show you that vomiting is a concern if the child is more than 2 years. So I need to be more careful in a patient with a more than 2 years and having vomiting, although vomiting per se does not equal CT. Vomiting will take you to the arm of observation versus CT. And then you can observe the patient there and then decide whether the patient with other elements that would have. Actually, BCARN is a very nice one regarding the head injury. It needs much more time to discuss the more details in the each and every element in BCARN, but for the time's sake, I think what we have said is enough. Again, if you don't remember this algorithm more than 2 years, remember basilar as a mnemonic and basal skull fractures and consciousness and headache and vomiting is there. Again, if you have a big problem and you did not understand or you could not remember the BCARN study that would help you to take a decision regarding the mild traumatic brain injury in children, go back to Bean and Bash and take off the age, and you can apply Bean and Bash mnemonic for even pediatric patient, and it has been validated for pediatric also. And it gives a sensitivity of 98.6% and a negative predictive value, which you're looking for, with of 99.1%. And it is exactly the same. Behavior abnormality, MSAs, we said no age because it's pediatric. Neurological deficit, bleeding disorder, ultimate status, skull fracture. If it is no for all, the patient has a sensitivity of 98% and 99% of negative predictive value that won't have clinically indicated traumatic brain injury. So Bean and Bash for both adult and pediatric. Last study I want to discuss with you is this study, but please, please do not misuse this study. Do not overuse D-dimer. So this is the study D-dimer regarding the unnecessary CT scan. So it is done to 663 patients, less than 18 years old. And they found that if it is drawn within 6 hours of the injury, and it is less than 100, which is 0.1 in our parameters, it is 100% accurate that the patient has no traumatic brain injury. And if it is more than 900, it is 100% the patient have clinically indicated traumatic brain injury. But remember, the dimer is confusing study. It's a confusing lab test. Anything can elevate the D-dimer. And trauma is one of them. Any trauma can rise the D-dimer. So be careful in using this one. If by chance you could glance the D-dimer and it is less than 100 and the family are very, very obsessive, this would help us as strong negative predictive value. It will reassure us that there is nothing. But if it is high, it won't give us that much difference unless it is more than 900 with associated brain injury. Then it would help us. But again, it has a very low positive predictive value. So do not misuse the D-dimer in patient with head injury. So this position, admit all. So the rule is to admit all. The exception is to discharge patient with traumatic brain injury. If the patient is having isolated traumatic brain injury with a normal neurological evaluation, negative bean and bash. Discharge instruction, please spend time. Give your patient time at the time of discharge. Sit with them and talk to them. As much as you talk, as much as they get satisfied, as much as they listen and remember your instructions. So what to expect, what to watch for, and when to return to the ED and repeat it for them as much as you can until you make sure that you remember everything. Thanks for your time. I hope we enjoyed this.
Thank you so much, Dr. Khaled. جزاكم الله خيرا على المحاضرة. I think someone is saying, can I get it through the email? Yes, I think we are going to email you the link for the live streaming and the YouTube recording just after the symposium itself, inshallah. Any question for Dr. Khaled before we leave for tonight? Okay, Jazakumullah khairan, Dr. Khaled. Thank you so much for you and your effort. And also thank you so much for all the speakers. We are done for tonight. Inshallah, tomorrow we are going to continue and for the second day of the symposium. Thank you so much. Jazakumullah khairan.
شكرا جزيلا لكم. شكرا لوقتكم.